करता पहला એટલું કહી દો કે So good morning, respected faculties and delegates. We would start the session in this hall on time. I would like to invite chairperson of this particular session, Dr. Vijay Shah, sir. He is president, Ahmedabad Obstetrics Gynecological Society for the year 2010-11, chairman, Transport Committee, AICOG 2000 Ahmedabad, first national satellite conference held at Ahmedabad, BISEC Studio Management, Transport and Accommodation Committee, president and secretary of different societies like Rotary Club, Sabarmati Medical Association, Chandkheda Medical Association, and Jain Yuvak Mandal. Vice President for the current year in Jain Doctors Federation, Ahmedabad, and Director of Darshan Maternity Nursing Home and Sonography Center, Ahmedabad. We welcome you, sir, for chairing today's session, which is comprising of 3 talks from Dr. Archana Trivedi Madam, Dr. Kirtan Vyas, and Dr. Manisha Ghate. Thank you, sir.
Hello.
Hello, good morning to everybody. Now we are starting our first session. And, I invite Dr. Kirtan Vyas. He is Consultant Director, Sevak Maternity and Surgical Hospital, Ahmedabad. Teaching experience as an Assistant Professor, Government Medical College, Rajkot for 4 years. Recipient of many awards and appreciations, University Gold Medal and UA Foxy Oration and UA Trooks Order Award. Keen interested in Indian classical music, reading and traveling. All of him, he is my best friend.
Thank you very much for your kind words. And a very good morning to one and all. And I'm fortunate to be over here. And thank you so much to Dr. Alpesh sir, Dr. Deliwala sir, Dr. Munjal, of course, and for this wonderful academic session. So we are starting with the first session of the first day of our conference. And the topic allotted to me is supine hypotension and shock, prevention and management of the same. So supine hypotension syndrome is a specific condition with severe supine symptoms and hypotension, specifically in late pregnancy. Second or third trimester of pregnancy, patients are more susceptible for such condition, and advanced recognition of susceptibility to the syndrome that depends upon the supine intolerance and an increase in heart rate or decrease in pulse pressure of the patient. There might be a range of severity of different symptoms ranging from minimal cardiovascular alterations to severe syncopal shock. It is also known as inferior vena cava syndrome or even aortocaval compression syndrome. The mechanism is very simple and straightforward. The compression of gravid uterus upon inferior vena cava leading to this decrease in pulse pressure while lying down in supine position. So the name is aptly said as supine hypotension syndrome. Central venous return decreases significantly in this condition, and it leads to decrease in cardiac output. It is experienced by almost 8 to 10% of women in second and third trimester of pregnancy, and symptoms typically happen within 3 to 10 minutes of lying down. So as the name itself suggests, as the pregnancy proceeds, the uterus grows with increasing gestational age and compression becomes more common. So obviously, the more the size of the uterus, more pronounced are the symptoms. So it is found in multiple pregnancy, patients who are overweight, patients with polyhydramnios, or when the collateral circulation system is not working well enough. The symptoms might range from mild pallor, drowsiness, sweating, nausea, weakness, shortness of breath, and in severe cases, some patients might even feel fainting attacks. The classical diagnostic sign is decrease in systolic blood pressure by 15 to 30 millimeters of mercury. So how to prevent this condition? When awake, most women are capable of compensating for the decrease in stroke volume by increase in systemic vascular resistance and heart rate. And even more importantly, collateral circulations also help in compensation. The most pronounced collateral circulations in pregnancy, specifically in second and third trimesters, are paravertebral circulations and azygous systems of circulation. But there is a glitch over here. When lower aorta is compressed, in this condition, blood flow to the kidneys, even uteroplacental circulation and lower extremities are also compromised. So we need to be extra cautious because these kind of patients may progress to sudden and acute event of shock. Symptoms are typically transient and they resolve with change in positioning. So pregnant women should lie down in complete left lateral position after 20 weeks. Other preferable positions, if patient is not comfortable with left lateral typically, then a left lateral tilt. In that condition, we can place a wedge under the right hip to achieve 15 to 30 degrees of left lateral tilt. Even manual displacement of gravid uterus can be done in some patients who are not comfortable with lateral position, in which uterus is shifted from midline to left side when the patient is lying in supine position. While taking this patient up for any kind of surgery, including C-section, how to prevent this supine position or supine hypotension? So the most importantly, adequate pre-anesthesia hydration. Number 2, regional anesthesia. Of course, the spinal anesthesia should be the choice of surgery for such patients. And the patient should be kept in left lateral position while giving this anesthesia, or even keeping a pillow under the right hip, the typical left lateral tilt. Even we can keep the entire OT table tilt to a left side down. And of course, keeping all the emergency anesthesia drugs ready. If the patient is susceptible to such condition, if the patient has experienced such episodes in her antenatal period, then yes, we have to be little extra cautious. Sudden syncopal shock. Shock is of course uncommon and it is found in very less number of cases. Clinical suspicion should be followed by BP examination to diagnose this condition. The problem arises when patient is at home and attendants notice such collapse. In this condition, immediately shift the patient to hospital in ambulance with all the resuscitation facilities. In ambulance, the typical protocol of airway, breathing and circulation is followed. Fetal well-being simultaneously is ascertained by auscultation of fetal heart rates. Patients usually respond well with immediate resuscitation and left lateral position with hydration. Sometimes, if the patient is already admitted in hospital, then the patient should be shifted in ICU. And there are a few case reports of sudden maternal and fetal death following supine hypotensive shock, but they are fortunately uncommon. If tissue oxygenation and perfusion is re-established promptly, patients usually respond well. So explain the relatives regarding this situation, but don't panic. Occasionally, if fetal heart rate decelerations don't respond to oxygenation and IV fluids, emergency delivery may have to be done. So to conclude, supine hypotension is common, but syncopal shock is uncommon. Explain all pregnant women regarding possibility of such an event at the beginning of the second trimester itself, maybe during antenatal classes if you are conducting the same at your center. Demonstrate correct position and posture to patients and relatives. Adequate hydration and proper positioning is required in most of the cases and nothing else. Rush to the hospital in case of syncopal shock. Thank you so much. Thank you, sir.
Hello. Hello.
Thank you, Kirtan. You have nicely elaborated the situation. Now I invite Dr. Archana Dwivedi. Manisha. Manisha. Dr. Manisha. Dr. Archana. Dr. Archana, a senior consultant and gynec obstetric at Sterling Hospital, President BOGS, President BMS, Vice President BOGS 2019-20, practicing since 20 years in Vadodara. Key interest in is high risk pregnancy, laparoscopy, vaginal surgery, NDVH, faculty for adolescent counseling and menstrual hygiene awareness and anemia eradication program in School of Vadodara and Periphery, faculty at various national and international conference, winner of Jagdishwari Misra Award at ICCOB and Gujarat Gynec Excellence Award at UFOXI 20 in Ahmedabad, Appreciation Award for Midlife Charity Work, winner of Best Paper Award and attached with NGO's name Foundation and first prize at West Zone UFOXI, a Superstar Foxy 20, West Zone Coordinator for Breast, Adolescent and Safe Motherhood Foxy Committee. So I invite Dr. Archana Dwivedi for vaccination during pregnancy, preventing complications.
A very warm welcome to everybody. Good morning. And it gives me immense pleasure to stand here with, in collaboration of AOGS, this Criticon. And one of the very viable, vibrant topic, I would say, is vaccination and pregnancy with COVID setting in. And so many talks now, Omicron. So I think vaccine is the most appropriate talk to start with, because it's a most cost-effective, proactive healthcare intervention which is available, and they prevent disease that can be deadly and dangerous to all of us, including the pregnant ladies, which are more prone to such infectious diseases. And vaccine helps the immune system to produce the antibodies in order to fight with the disease. Pregnant women and their fetuses are among the vulnerable populations that can be severely affected by communicable diseases. Vaccines such as influenza, Tdap, and other vaccines can be offered based on the risk factors, because we have to evaluate. Development of vaccine has come as an array. There are so many things available in the basket. We have to be very judiciously when we use that, especially this is a very busy chart, but I would like everybody to focus on this, because there are certain vaccines which are recommended before pregnancy, during pregnancy, and after pregnancy. So when we talk about vaccines like hepatitis A, B, HPV, influenza, you can see, choose the patients accordingly, especially meningococcal vaccine, because if they belong to a high risk categorically, you can give the vaccination, explaining the risk to the fetus. But when I talk about the other vaccines which can be given during pregnancy, Tdap should be given because it has been seen that it imparts extra immunity to the infants for the pertussis and varicella. So recommended vaccines are influenza and Tdap. Influenza vaccine, because of the risk of flu in the population has been increasing, there are so many changes in the viral strains, risk of morbidity and mortality from influenza, especially the preterm birth, low birth weight, stillbirth, and neonatal death can be prevented by 40 to 36% if you give it into the pregnancy. So CDC recommends that anytime during the pregnancy it can be administered, and it has got a very good safety profile. Talking about the Tdap, which I think we all have started using in the practice, between 27 to 34 weeks of gestation, you can give Tdap, which during pregnancy, and also can be given during postpartum period, because it has been seen that higher levels of pertussis antibodies is present in the women who receive the vaccine in the postpartum period. There are certain adverse effects like pain in the injection site, erythema and swelling, but that is part and parcel of all the vaccinations which we talk about. So the recommended thing is that pregnant patients receive Tdap vaccine each pregnancy, regardless of the previous vaccination history or receiving of the tetanus vaccination. So WHO recommends that pregnant ladies should be given tetanus toxoid, a complete 6-dose series of tetanus toxoid containing vaccine, begun during infancy, will have a sufficient antibody levels to protect themselves and their newborns. Optional vaccines like hepatitis A, B, pneumococcal and meningococcal vaccines can, or also including the yellow fever vaccine, can be restricted to the population who is at high risk or who are traveling abroad. Like hepatitis vaccine A is not that strongly recommended, I would say, because it can be harmful because it's a live attenuated virus comparison. But when we talk about the adverse side effects of the pregnant lady belongs to the endemic area where she's at high risk, we should always offer them the vaccination. Hepatitis B vaccine is comparatively safe, but again, it is administered intramuscularly in 3 doses at 0, 1, and 6 months. Teratogenicity, preterm labor, or spontaneous abortion does not seem to increase with vaccination. So this can be offered more safer than compared to the hepatitis A. Again, the pneumococcal vaccine should be avoided in first trimester, but that can be given safely in the other 2 trimesters of pregnancy. Meningococcal vaccine is given as a single subcutaneous dose, whereas it is administered MCV4 and MPSV4. There are 2 tetravalent conjugate vaccines which are available. So MPSV4 is given single dose subcutaneous, and MCV4 can be administered single intramuscular dose, but is usually conjugated with other vaccines. Contraindicated ones are measles, MMR, varicella, and HPV vaccine, which should not be given unless it is very much risk to the pregnant ladies. So now talking about something about the COVID-19 vaccine, it is no more a mystery now. We all know that can be given very efficiently to all the pregnant ladies. It should not be refused at any platform. Though when I talk about the Omicron surge, which is being seen nowadays, there is still talks going on, and we don't know how effective this vaccine, Covishield or Covaxin or the others which have peeped up into the market. But still, if you have been, the lady has received even a single vaccination, almost 20 to 80% immunity can be imparted to the coming virus strain also. So I think we are all using it rampantly with all our pregnant patients, and we are trying to make them more safe, especially elderly primigravidas, second gravidas who are at high risk with having other comorbidities like obesity, hypertension, diabetes, and other illnesses. They can be offered it very judiciously. Even the ladies who are planning for the pregnancy, if they have taken the COVID vaccine, they are not allowed to terminate. They can easily carry forward with the pregnancy. So at present, it is believed that risk of getting COVID-19 in pregnancy and its resulting morbidity is much more than the theoretical risk which is occurring with the vaccine. So it should be offered to every patient. Though some countries have a risk-based approach, FIGO believes that such an approach might actually be a disadvantage to the pregnant women. We are preventing that lady to have a healthy and immune life. So ACOG states that pregnancy testing should not be mandated before vaccine administration and could be deferred for the patients who are in the preconceptional period. So all the international bodies, FIGO, ACOG, RCOG, SOGC, they all recommend that COVID-19 vaccine should never be declined. They should be given. And long-term adverse effects and safety of the vaccine for fetus, though is not yet established, but pregnant women with increased risk of COVID-19 complications, which include, because most of the patients who are coming to us now are elderly primaries with comorbidities. So if we are offering the COVID-19 vaccine to our patients, at least we are giving them a better immune status to them and the fetus as well. So it is safe in pregnancy. Minor side effects, we all know, which occurs with all the vaccines. That is part and parcel of the vaccination program. So in case a woman has been infected with COVID-19 vaccine during current pregnancy, then she should be given vaccination soon after the delivery. There is one guideline which says that if a lady has taken a COVID-19 vaccine, after 14 days, you can give the second other vaccines also. Or if the lady has taken any vaccination, she can be given the COVID-19 vaccination after 14 days of the previous vaccination. So the anti-AGI recommendations are that the pregnant women may be offered a choice to take any COVID-19 vaccine. Lactating women could be inoculated anytime after the delivery. And people testing positive for COVID-19 should defer vaccination for 6 months after recovery as a routine protocol in all the, as a mob patients, I would say. So FOXI suggestions are that obstetricians and gynecologists should be allowed to administer COVID vaccines, and these doctors will be ready with the preparations to manage any adverse outcomes which happen. And even after the vaccination, women should follow COVID appropriate behavior. This is a very important counseling which we should tell our patients. So FOXI position statement says women should be counseled, empowered to make their own decisions, supported by the care providers whom they are seeing, and there should not be any discrimination between women who accept or refuse the vaccine. Because we have a parental attitude. If we have said something and the patient is not going according to our ways, we start having a different discrimination which is inbuilt in all of us. So we should not try to practice that. It is her choice that she wants to take it or not. We have to offer it to every pregnant patient. So they should be made aware. Thank you so much for patient hearing. I hope I finished in time, sir. So any questions I would like to answer? So I think we have a consensus that everybody should be getting the vaccination, except for the low risk or high risk. We have to be very judicious when we decide about the hepatitis A, B, or meningococcal vaccination, even the yellow fever vaccination, because nowadays pregnant ladies are traveling abroad rampantly. So I think, yes, ma'am.
Is gap between vaccines when they have to take more than vaccine and pregnancy.
Yeah.
So that's something which we need to address.
Yeah, that is what I said, madam. If a lady has taken a vaccination, after 14 days, she can be given the other vaccine, especially with the COVID-19, because we're talking about it right now. So once she has been inoculated with the COVID-19 vaccine, she should wait for 14 days to take the other vaccination. And in case if she has been vaccinated with something, so she has, if she wants to take a COVID-19 vaccine, she has to wait for 14 days to get inoculated for that. And Tdap should never be refused. It should be given. Tdap and influenza can be taken anytime.
Boostrix.
Boostrix is Tdap.
It can be taken on separate sites at the same time.
Yeah.
Because people have difficulty in getting appointment for the vaccine also.
Yes, yes.
So that is one thing.
One thing.
Not taking it at the same time. Then the
14 days gap is a protocol which we, like in the infants, we say that either you vaccinate simultaneously or you follow 4-week protocol. In the adults, we follow 14 days protocol. So that is what we should. I think Sir was saying about the Boostrix. Boostrix is another name for the Tdap, so that can be administered anytime. Influenza and Boostrix or Tdap, whatever trade name we're using, should never be refused. It should be given because now we are seeing less pertussis patient, obviously, because of the government policies, and we have been very, very sincere about the vaccination protocols. But this should be offered in nowadays practicing scenarios, and I think we are all practicing it, sir. 24 weeks beyond and 34 weeks. Lady should never be refused. At least a single dose of Tdap is also good. If she has not taken, even in the postpartum period also you can administer. Yes, yes. Three vaccines should be given. Thank you so much. Thank you, sir.
Thank you, Dr. Archana. You have nicely elaborated the vaccine and some of you remove the confusion about COVID. Thank you very much. Now I invite Dr. Manisha Ghate. She is Waste Zone Coordinator, Food, Drug, Medico-Surgical Equipment Committee, Chairperson, Women Doctors Wing, IMA Chandrapur, Secretary of Chandrapur Obstetric Gynec Society, Maharashtra since 2018, Vice President of IMA Chandrapur, Director of Chandrapur Test Tube Baby Center, Director of Santaji Mahila Nagarik Sahakari Bank Chandrapur, first to bring and start colposcopy in Chandrapur, invited as faculty speaker in state, national and international conferences. Areas of interest are laparoscopy, infertility, and colposcopy. Work as consultant in Ghate Surgical and Maternity Hospital, Chandrapur.
Thank you, sir. A very good morning to all the respected seniors and dear friends. At the outset, I would like to thank the organizing committee, Dr. Alpesh Gandhi, sir, for giving me this opportunity. Respected chairperson, my topic for today, it is how to examine a rape victim. Now, first of all, the procedure for the examination and the instructions to the victim not to clean up before reaching the hospital, should not take bath, go to bathroom, comb hair, change clothes, brush teeth before undergoing a medical examination. This will help to preserve all the evidences. Let us know the law new definition according to the 2013 amendments. I think we all know the definition of the rape, so I am not going to go detail in it. But according to the 2013 amendment, injuries to the victim's body has no relevances. And the classification of the offense, it is a cognizable, non-bailable, non-compoundable offense and can't be settled even with the permission of the court. The three most important things are needed, that is the trained doctor and the team, special kit for the examination, protocol for treatment to prevent STD and pregnancy, it is very crucial. Now, what is the principle of emergency care? The doctor's job at emergency room is not to determine if the offense has occurred or not, because rape is a legal term, it is a crime, and whether this has been committed or not will be decided by the honorable court. Principles of the emergency care: the attitude of the medical staff should always be caring and compassionate. Life-threatening emergency if present will need urgent attention and treatment. Then the victim, the first aid medical treatment to the victim of rape should be provided promptly and free of cost by all the hospitals, may it be public or the private. Medical examination of the victim should be conducted by a female registered medical practitioner, and the police requisition FIR is not mandatory for seeking the medical care and treatment of the victim. The principal features of the examinations are: the first, the informed consent, preliminary data, the statement of the victim and others separately, collection of the clothes of the victim, signs of struggle on clothes and body, examination of the genitals for local signs of violence, any genital injuries, presence of spermatozoa and other microorganisms, any evidence of STD, collection of all the laboratory specimens, inference and advice on follow-up. Now, first of all, the informed consent of the victim should be taken in writing in presence of a witness if she is above the age of 12 years. If she is under the age of 12 years or is a mentally subnormal person, the written consent of the parents or the guardian should be taken. Now, about the statement of the victim should be written down word to word as much as possible. The amount of violence used, the position of the assailant, mode of the act should all be noted down properly in presence of pain, hemorrhage, and inquiry should also be made of the events after the assault, like if she has changed the clothes, bathed or passed urine, and should be properly noted down. As I have previously mentioned, three most important things we need: trained doctor and her team, special kit for examination, and protocol of treatment to prevent STD pregnancy is very crucial. So, physical evidences, let the evidence speak for itself. Every contact leaves a trace. So, collection of all the clothes of victims should always be done. Guidelines for injuries as per the new law 2013. Signs of struggle on victim's body are irrelevant according to the new law. Injuries are seen in only 1/3 of the cases. Common sites of extragenital trauma are mouth, throat, wrist, arm, breast, and thighs. It is very essential to do a careful examination and notification of all the findings which are present. Nail scraping. The victim usually scratches the assailant during the struggle, and this may result in injury to her nails, which should be recorded. The debris in the nails should be removed and collected for examining the presence of any epithelial tags, blood, fibers, etc. of the assailant. Sorry. It is one of the most important steps and should not be missed at all. Guidelines for medical examination. We should know 2-finger admissibility test on a woman victim should not be performed, and documenting of victim is habituated to sexual intercourse or not shall not form a part of the report at all. Soon after the act, the tone margins are sharp and red and bleeds on touch. Even when examined after 3 to 4 days of the offense, the edges of lacerations are congested and swollen. The surrounding tissues are also swollen and tender. This is the photo of sample collection kit. Now, regarding the collection of forensic sample, the following samples are to be collected. Vaginal sample slides for microscopic examination of motile and immotile sperms. Motile sperms can be visualized up to 4 to 5 hours. Vaginal swabs from vulva, low and high vagina, to stress here that it should be made a routine. Nail scraping samples, I have already said earlier. Hairs from the mons pubis to look for seminal tags and foreign hair. Seminal scale for blood grouping. Ultraviolet test for detection of saliva and seminal stains, but it is optional. Then blood for blood grouping, beta HCG, STDs, and also for testing drug intoxication, if any. Urine for testing suspected pregnancy and drug intoxication. Mouth swabs from under the tongue and buccal area near the molar. Rectum sample should be taken from the external orifice and other from 2 to 5 centimeter around the external orifice. For crucial evidences in rape cases, the implementation of national protocol of the rape victim examination, collection of the forensic evidences, sampling and labeling it properly, and accurate documentation is very much needed. The screening tests recommended are pregnancy test, HIV, STD test, blood and urine for addiction or substance abuse, such as heroin, opium, benzodiazepam, and alcohol. Collection of the evidence. Even if the victim is not sure whether she wants to report the attack, it is still important to collect and preserve the sample so that it can be assessed at later date if necessary. Evidences, if not collected within 48 to 72 hours of the incident, is often unrecoverable or invalid. Now, for us doctors, punishment for non-compliance for we doctors, exam care, evidence collection. This is most important. Whoever being in charge of the hospital, public or private, whether run by government, local bodies, or any other person, contravenes the provisions of Section 357C of the Code of Criminal Procedure 1973 to of 1974 shall be punished with imprisonment for a term which may extend to 1 year or with fine. So our treatment aim should be pregnancy prevention, STD prevention, emotional support and care, and counseling also is very much helpful. So please remember, girls cannot stop rape just by changing their own behavior. Violent people never stop unless they are severely punished. So let us all join hands together as Foxians to do accurate medical examination and care so that the accused is severely punished. Thank you for the patient hearing.
Thank you, Dr. Manisha. Now I invite the second session and panel for pregnancy, COVID and century. Panel discussion.
Hello, good morning, everyone. For the next session, which is on the topic of panel on pregnancy with COVID-19, a challenge of the century. I would like to invite the esteemed moderator for the panel discussion, Dr. Reena Wani ma'am and Dr. S. Ajit sir. Welcome ma'am, welcome sir. And I would like to invite the esteemed panelists for the same session, Dr. Ashish Gokhale sir, Dr. Bipin Nayak, Dr. Munjal Pandya, Dr. Nalini Anand, Dr. Niharika Malhotra, Dr. Jitesh Shah, and Dr. Nilesh Valkavade. Welcome, I welcome all the panelists.
Good morning, friends. Good morning, friends. And I think they technology issue. They're looking for the PowerPoint again. I had loaded it. Give us a minute while we get it done. Connection nahi. ICCOB go down. नीचे 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 पेन ड्राइव मुख्य छवे नीचे जा 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 ICCOB हाँ ये सेव कर ऑन द डेस्कटॉप कॉपी कर बाबा और मेरा पेन ड्राइव निकाल के दो हाँ पेन ड्राइव निकाल तो बाद में भूल जाएंगे सेव इट ऑन द हाँ चलेगा ओके रन इट्स ओके छोड़ दो ओके कॉपी किया सुपर रे भाई till then why doesn't the MC introduce the panelists? Excuse me, can you just give the introduction of the panelists till then? While she's here. Okay, yeah, come introduce the panelists.
Yeah, first of all, I would like to introduce the esteemed moderator for the panel discussion. Our first moderator is Dr. Reena Wani ma'am. She is a professor and unit head at the HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. And she is a core committee Foxy Violence Against Women Cell in 2015 and 21. Ma'am is member of Foxy GCPR for COVID Guidance and Vaccination 2020-21. Ma'am is President Mumbai Breastfeeding Promotion Committee, Chairperson Foxy Perinatology Committee in 2015 to 2017, and ma'am is ICOG Governing Council member since 2021-22. Welcome, I welcome you, ma'am. And now I would like to introduce our panelists for the session. Our first panelist is Dr. Munjal Pandya. Sir is
the co-moderator.
Yes.
It's a pleasure and privilege to be here with you all today. And Dr. Ajit is my co-moderator from Thrissur. Dr. Ajit's introduction.
It's not here, ma'am.
So Dr. Ajit is a well-known obstetrician and gynecologist, president of KFOG, Kerala Federation of Obs and Gynae. And Thrissur is very well known for the educational activities, and we are privileged to have him here with us. We also have, of course, everybody knows Munjal Pandya, and we have a young brigade up there on the dais with us today. Munjal has been introduced yesterday also, but you can go ahead.
Yeah.
2 lines. Yeah. Okay. Next, we have Nilesh Valkavade from Pune. He is synonymous with Quiz Committee, and he has done great work throughout Foxy for that. So I'm not following the formal introduction, but I'm telling the key points. Niharika Malhotra, Young Talent Promotion Committee. She is the most enthusiastic and also on social media. And also I remember she does a lot of extracurricular activities like Holi and other things. So we appreciate that. And our last panelist is...
It's not there, ma'am.
Dr. Nalini Anand. Yeah, Dr. Nalini is... sorry, Dr. Nalini, aapka... So Nalini ji is HOD at Jamnagar, and we are very happy to have all of you here today. And to make things interesting, we are actually going to have a case discussion, a case-based discussion for COVID in pregnancy. So to start the ball rolling, Dr. Ajit and I will be discussing it with case scenarios. Let me hand over to Dr. Ajit for the first case, sir. And to make it easier, we are going to have, of course, this is not like an exam. We are just going to be having a discussion. What we are doing in the interest of time, we will ask one case to each panelist. And if the others would like to put in anything, we would ask you to just raise your hand and we will add in to that. Yes, we can do that.
Good morning, all. The first case, a 22-year-old lady, pregnant second time, last period 2 months back. Husband had a positive COVID test last week. She's also having now fever and cough for the last 3 days. Her RT-PCR test is positive. G2P1 with 7 weeks, 4 weeks gestational age with COVID positive status. Her temperature is 100 degrees Fahrenheit. SpO2 98% in room air. Respiratory pulse rate is 88. BP 110/70. Respiratory rate is 16 per minute. CVS respiration normal. So I would like to ask Dr. Niharika, what is the clinical stage of this condition?
Hello, thank you, sir. So we actually, whenever a patient with pregnancy with COVID positive status comes to us, we actually divide her into a mild, moderate, or a severe disease. And this patient is definitely comes into right now in this mild disease because she does not have main symptoms. She has fever, but her SpO2 is more than 95%. Her pulse rate is controlled, her respiratory rate is controlled, and otherwise she's asymptomatic. So any patient who comes with a mild system with COVID positive may just need home isolation with basic investigations. And also because she's pregnant with 7 weeks, I also feel that she should have, if she's not had an ultrasound, we should keep a close follow-up of such patients, because to rule out ectopic pregnancies, because we have seen that these patients report late and then they can come up with ruptured ectopics also.
So Niharika, you've pointed out one very important issue. As obstetricians, we have patients who have come and are reporting. Now, this lady does not yet have COVID, but she may be a suspect COVID, and she brought up another important thing of ultrasound. In COVID times, most of the guidelines have said you need to postpone investigations unless there is a clinical suspicion. And in fact, there was a wonderful paper, the meta-analysis from UK, Patrick O'Brien, who gave the oration yesterday. In that meta-analysis, they said the incidence of surgical management of ectopic pregnancies increased during COVID because diagnosis was often delayed. And my sister concern, Nair Hospital had 1,600 COVID positive patients, and they found ruptured ectopics. And in fact, one of them died because she came late. And by the time she got operated, it was, so in the maternal mortality audit, it was found that these are issues. So you nicely pointed that out. So if you feel there's a suspicion, definitely you have to insist on the ultrasound. Otherwise, we can manage more
close follow-up can be done.
How do you clinically stage the severity?
I would just like to add that even when we are advising her home isolation, telemedicine should be an important part of monitoring her during those 14 days. And we need to reassess these patients every 24 to 48 hours, because they may enter from an asymptomatic or a milder state to a severe one, pregnancy being an immunocompromised.
So you have to reassess it every 24 to 48 hours, isn't it?
Thank you very much, Nalini ji. You have also put in an important point that the situation keeps changing, and telemedicine. In fact, our President Alpesh ji has really made telemedicine very big, and teleconferencing and telemedicine both became very big in the last couple of years of the pandemic. And these are a couple of factors which are associated. In the latest review, we've talked about first wave, second wave, third wave. Everyone was expecting. Some felt it just became a bubble, but now Omicron has changed things. But again, in Omicron, milder disease is being found, and hospitalization may not be required in all.
Pregnancy is mostly asymptomatic. Most of the patients are asymptomatic, but some patients are severe. Especially in pregnancy, severe infections are more common. Which are the group of patients
Pregnancy
where you
with
see
comorbidities is also a very high risk factor, and I think those patients maybe daily follow-ups on phones or video calls should be done if you're giving them home isolation.
So which factors would you think are more at risk? Which patients would you be more vigilant or ask them to get admitted?
Most patients who are obese especially, or who have comorbidities like blood pressure, diabetes and all, and also patients who already have some form of chest infections, asthma, COPDs, then those patients are on a higher risk of admissions and
So you should be very
ICU.
careful in such patients, isn't it?
Yes, and in fact, another thing is, about maternal age and also facilities for home isolation. It is not necessarily only that we are not admitting her because she is sick. It's also because they are sharing, for example, a chawl system where they're having a common toilet and they are unable to home isolate effectively. To protect not just them, but to reduce community spread, we are admitting that patient into the hospital. So that is an important point which our panelists have put across about when to call in or hospitalize.
Anyway, the antenatal care is very important. We should not change the way we do the care. It's very important.
Yes, sir. Dr. Ajit has also pointed out how in our FOXI guidelines, we have talked about maintaining the standard antenatal care, but maybe reducing the number of times you call into the hospital, except as we discussed. So for the second case, let me ask Dr. Munjal. This is Mrs. ABC, a 39-year-old multiparous patient with all vaginal deliveries who came to my hospital with 2 months of amenorrhea and a positive urine pregnancy test asking for an MTP. This is a very standard situation. And this was actually in the beginning, all these 6 cases are actually real cases handled by us. So this lady came for MTP, everything was done. RT-PCR as per hospital policy at that time, it was within 1 week of admission. Now it is 48 hours of admission, but this came positive. Now what to do? When she has come for MTP first trimester and says, Ki, I want MTP, and now she's RT-PCR positive. Kya kare?
So first thing is like clinical examination is of utmost importance with regards to this possibility of ectopic. We need to actually do it clinically. If we are pretty much sure that it is intrauterine pregnancy, that again, we might avoid sonography. If we have any doubts, then we need to do sonography because that ectopic pregnancy would be of disastrous scale maybe. The only point is with regards to positive RT-PCR status, if she is still asymptomatic, we might tell her to wait for some time till the active phase, or I cannot say exactly infective phase because again that is controversial. But yeah, up to 14 days we need to counsel her for wait, and then reassess the situation and her desire, and then accordingly we can offer her medical or surgical methods of MTP as per the desire and the clinical status. In between, if she worsens, then again we need to take the call. But again, surgically terminating that particular pregnancy would be disastrous for her physical health. So again, counseling and then informed consent with regards to that particular waiting period and proper monitoring and analysis for those 14 days is required if she develops symptoms.
So Munjal has brought out one important point that if it is possible, she wanted MTP with possible tubal ligation. And she was asymptomatic. So she had already been examined. Everything was done in the OPD. We had confirmed intrauterine pregnancy. Yes,
and I would like to add something. So
yes.
As she is an asymptomatic case, and MTP and tubal ligation being, a small procedure, we can just finish it off in few hours only. We may offer after getting her all investigations done, because we many times do not know which way she would progress. But if yes, tubal ligation is considered, then tubal ligation being adding the liabilities to the government, that is to be thought of.
So not only that, infectivity is important. Even the anytime she can progress to deteriorate. So if we can defer the tubal ligation, is better. And another thing is she's in a hypercoagulable state.
Yes, Nilesh, you were adding about the guidelines.
Yeah,
yes.
there are no guidelines to this, but I think we have got FOXI GCPR
so
guidelines,
in fact,
which say
FOXI,
that we should wait for 14 days at least for the first period where the infectivity, the viral load is less. And we can treat the patient, follow up the patient in these 14 days, and probably even if we convert a medical MTP to surgical MTP, that would be fair enough.
Yes. So in fact, this is the second version of the FOXI GCPR guidelines, which is available on our website, done by our beloved President Alpesh ji, with all of us participating in it. And this is the ICMR Department of Health flowchart of how to manage COVID in pregnancy and about the choices for breastfeeding. Now, what actually happened in this patient, because she was unsure and there were issues, and there are certain anesthesia guidelines. So the anesthetists also have their own thing, and their anesthesia guidelines say that 4 weeks for any elective or semi-elective procedure from the time of COVID positive is what the anesthetists prefer, because it is, especially if the patient requires GA, you may say it will be done under spinal or saddle, but if conversion is required, it is a possible aerosol generating procedure. So this patient finally was advised to follow up for a MTP later. And we are happy to report that she was otherwise okay. She came back. We did a second trimester termination, which was done under spinal anesthesia because she was almost 11 weeks at that time with a tubal ligation. So that she was a para 5. So we didn't want to deny her. A lot of people are scared of doing tubal ligations because they feel कि बाद में मर गई तो ये national state level का inquiry हो जाएगा, which is also an issue. But I think we should not deny women the opportunity.
We should balance between the risk
We have
and
to balance. But of course, doctors also have to be safe because we are living in a medico-legal environment. Yeah. So next case, Dr. Raju.
She's a 28-year-old lady, pregnant for the first time, last menses 3 months back. Husband is positive, or RT-PCR positive. She is asymptomatic. Now, who will take up this case? How should the patient be counseled about the home isolation?
So I think we can have Nalini ji taking up this case.
As regards home isolation, this patient clearly requires a home isolation. It's only that we have to advise her about the COVID appropriate behavior. Once positive, first and foremost, like Madam already pointed out, we have to make sure what are the possibilities of home isolation, what are her home conditions. So if it is a common toilet or something like that, an individual toilet is not available, then we might offer some, there were some COVID care places which had
What
come
is your
up.
opinion on the walk test? Because that for non-pregnant patients also we talk a lot
Yes.
about it. And is it different in pregnant women?
So for walk test, we definitely require to do it at least 20 once in the 24 hours. And because she can progress to any side towards, she can progress, like if it is like this, she is we do not know even her status as yet. She can progress to be positive, and from even once they are positive, they can progress from mild to moderate as well, or the other way as well. So it is, you have to take pulse oximeter readings, then you have to advise her to walk approximately 40 steps, or as they say, 6 minutes. And then post walk also we have to take
Look for the
pulse
change in the
oximeter.
SpO2.
If it is more than 3%, then it is significant.
I think Munjal wants to add something to that.
I just wanted to ask about the practicality of that particular thing. As in the walk test in a near-term patient, how actually
So
fruitful an
Munjal, this is a
interpretation
very important question. There is a question, some patients, now pulse oximeter has become like thermometer. Most people will keep it at home also. But what is important is in a term patient, it has been suggested that instead of 6 minutes, make it 3 minutes walk test when the patient is in the third trimester. This patient was not in the third trimester, so the 6-minute walk test. And another option is a single breath count. That has also been suggested. If you don't have a pulse oximeter, you ask the patient to count with one deep breath, count the numbers 1, 2, 3, 4, or Hindi mein, Gujarati mein, whatever she is able to do, she should be able to count at least 30. Or if there has been a change, then we are worried. So these are practical things, how you can decide about the home isolation.
Also, ma'am, because she's pregnant, so all the basic supplements also should be advised to her right now. And secondly, she should not be on bed rest because they say ambulation is very important, because if we lock them in one room, then ambulation becomes a little difficult.
So I think we are going to cover a few points about thromboprophylaxis and this, but I'm glad Niharika brought that up, that we have to treat them like a regular pregnant patient. Only thing, the isolation, you have to tell them some exercise or this when you're doing your home isolation should be. So we'll come to that.
One
in the next case.
one
Yeah.
more point was with regards to all the pregnancy and thing, we started up with the Garb Sanskar and all those things, right? With regards to COVID, we are actually limiting that particular patient, inside 4 walls without any proper support. So we are neglecting that psychological makeup of that particular patient with regards to all the things that can actually nurture her as well as her baby inside. So that particular component.
So Munjal, you have actually touched upon something which we can do a full panel discussion. In the
Thank you,
Lancet 2021 June, a meta-analysis of 40 studies was published in which they found the Edinburgh postpartum depression scores and the issues related to depression were significantly increased, because women, as it is, pregnant women have emotional lability, they are tearful, they are weepy. And here, when all this happens, it's even worse. In fact, some of them even become suicidal. So thank you for bringing that up. Because of lack of time, we have not focused on that aspect. But yes, looking after the mental health, and here, mobile, people may not have a proper electricity supply in their house, but everyone will have a mobile phone. So using the mobile apps or having group discussions, or as one of the panelists already pointed out, having teleconsultation and video consults with the patients. This was found in our hospital also, that we had one hospital which was complete COVID hospital, where there were a lot of problems and relatives were creating hangama, going to the superintendent. So then what was done was one tab was kept in each ward, and turn by turn, the patient, because patients' relatives are not allowed when it's a known COVID positive. So the video of the patient was shown to the relative. So at least once in 12 hours, this was done. So this reduced the incidence of anger or concern. And even if the patient dies, they don't say ki are andar kuch kiya nahi, hamara patient to aise gaya. You know, these are all other problems which have come up in COVID. So you want to? The next case is this is now we are going to a little more severe situation. 21-year-old gravida 2 with 1 abortion. 30 weeks pregnancy, was referred to our hospital from a private nursing home, where she had already been treated for cough and dyspnea with antibiotics. Basic steroids had been started, but her saturation was not being maintained to 90% or more, and she was diagnosed COVID positive. They had already started her on remdesivir, but because of this, she was directly admitted and put in ICU situation with ventilatory support. Now, what was the problem in this case? That we have discussed up to now spectrum of severity. So can any of the panelists tell us where do you feel this patient, and if she had come to your triage area, Nilesh, what would you do? How do we go about it when a patient comes to you referred like this?
So we categorize this as major, mild to moderate disease, then critically
Moderate
ill
to severe, because she's
critically ill.
Critically ill, yeah.
But this patient falls into critically ill.
Yes.
Because she'll require ventilatory support, and I
So
think
she started off as moderate to severe, but then as we were saying, times changed. So within 2 days, she became critically ill, and this is the spectrum which has been described in most of the guidelines of the clinical picture of SARS-CoV-2 and how we are supposed to prioritize and decide. And it's only for the first 2 that we can afford to wait, and we have to remember the numbers 30. 30 breaths is, in fact, in pregnancy, we may reduce it to even 24. 95 is the saturation. In non-pregnant, 93 is still acceptable, but if it's below 93, she's critically ill. And imaging, the scores of more than 50% lung involvement. And of course, if they are immunocompromised, it is a bigger problem. And this is where we decide. Again, there are sometimes fights between labor ward mein rakhenge ya ICU mein rakhenge. But this is something, a critically ill patient is definitely going to be better off unless you have an obstetric HDU, which is now becoming a NMC requirement. And whether now here, what was for obstetricians? This patient has come, she's 30 weeks pregnant. Do you continue conservative management of COVID, or should you deliver this baby? That was the big discussion, which was between the medicine unit, which was managing her, the anesthetist, which was giving input, and us. So can we have any of the panelists giving their suggestions on that?
So, ma'am, because we don't know how she's going to progress further, and if your baby is viable and if the baby's weight is acceptable, I personally would like to deliver and give her a live baby instead of wait for a intrauterine demise or a problem.
Does anyone, do you all agree with her?
No, I differ here. First and foremost is we have to stabilize the mother. We have to get all our investigations done, and we have to see which side she is progressing. And if we find that because it is 30 weeks, might be survivable in a good NICU setup. And so if she is going to worsening side, and also the physician feel that the delivery of the baby would make the patient more comfortable and her respiratory status would improve, then we have to deliver for maternal reasons. And
Fine.
second is the fetal reasons. If we have,
so can we have a vote from the audience? How many of you would deliver this patient, primi gravida, 25-year-old, 30 weeks? Would you like to deliver? And she is now tubular closed cervix, 30 weeks. Who would like to deliver? Please raise your hands. She's already on intubated and critically ill.
So actually,
For the mother's sake.
Yeah. So to be honest, she was critically ill, but she was already on low molecular weight heparin. We decided that I think we will stop the low molecular weight heparin, wait 12 hours because we don't have, this was in the middle of the night, we said we will take this decision. Next morning, we will take her up for section when seniors are available and this. But unfortunately, she succumbed to the disease. And we had a big discussion on this in our maternal mortality audit meeting. And as you were saying, it's a group. Still the decision was that delivering her would not have changed the outcome, and it would have led to more medico-legal and other issues. And hence, there are certain things of a perimortem cesarean. Yes. So in couple of patients where they are near term and you feel it's NICU salvageable and other issues, you can consider. Yes.
We have involved the multidisciplinary
We have done one this type of CS when the patient was on the verge of succumbing. They were about to start CPR. You never require anesthesia. That we immediately delivered the baby. That child survived in after 15 days NICU admission.
So basically, I think for delivery or cesarean section, it would be an obstetric indication for induction or cesarean.
So all the international guidelines, excuse me, time is not over. This is a 1 hour panel. Huh? Your timer is wrong. Yeah. They have put 20 minutes. Munja, you are organizer. You have to give us priority.
You just stop the display.
Yeah. So anyway, but we promise we will shorten it a bit so that
we are on time, ma'am.
So what important point is that this decision is something which is very crucial. It has to be done keeping everything in mind. And there are no clear-cut guidelines, but here.
And honestly, madam, with regards to Indian scenario, it is the physician who would be pushing us that, you relieve the cardiorespiratory component and then things will be fine.
I would like to tell you now, because at least in Maharashtra, since more than a decade, we are having each and every maternal mortality audited with great discussion. The physicians have also become very cautious and very previously, because if the mother dies, they also have to face the audit. So we group.
Yes, ma'am. Because of maternal death review meetings,
because of maternal death review, people are putting lots more attention to making mothers survive. Yeah. And the consensus was that in this case, intervention may have worsened it. So it may not have been salvageable. And as I think you all have correctly mentioned, most of the international guidelines have very clearly said obstetric indications for cesarean, but case to case for critical cases where you feel, especially near term, that they are salvageable. We may be considering doing that. So, but in these kind of severe cases, to take that decision, Nalini ji, you said you all have done perimortem cesarean. So what are the investigations you would like to ask for in these kind of cases?
All the routine investigations, CBC, LFT, RFT, apart from them, CRP, LDH, procalcitonin, ferritin. Serum ferritin is going to give us a good idea about the prognosis. So these are all that we get to get done, and there are, along with X-ray chest imaging for her respiratory status
imaging,
as well.
how many of you use
D-dimer? I forgot to say D-dimer, but D-dimer is not very, we don't have to rely too much on it for taking CS, because I personally have done a CS with 10,000 D-dimer. That mother survived. Yes. Definitely, we had to push lots of components, but then other ferritin and LDH, they are giving more about the idea about the prognostic.
So most of the guidelines and reviews have suggested that no one mode of birth, vaginal or cesarean, is better. It depends on the obstetrician's indication, and wherever possible, involve the mother, or if she is in no state to give a decision, involve the family in this. And this is a very latest WHO review from Mercedes Bonnet. It's actually, if you all want to look at this, you can actually click it. And this, every time it gives an update of what is the latest management of COVID in pregnancy. And they have said that the outcomes right now, they found that if you are getting COVID far from term, the first wave, it was said that it was not badly affected. We have done a death analysis in our own hospital. And in second wave, we did find maternal mortality had gone up. But now they are suggesting that those women who become COVID positive around the time of the delivery have a higher incidence of ICU admission, need for ventilatory support, and perhaps more stillbirths. The data is suggesting that, which was comparatively, and these are the statistics from 82 cohort studies, the meta-analysis of that now the thought is changing. Previously, we used to say they do as well as non-pregnant women. But if they are about to deliver or at the time of delivery, hence pushing for delivery. And if you feel she can be stabilized and we can push the delivery further, she may actually do better than that. And this is the same meta-analysis which also showed that recent studies like pediatric journals have also shown that there is increased mortality and severe outcomes, maybe more stillbirths, if they are pregnant at the with COVID at the time of delivery. And the largest systematic study, although it says that pregnant women are not at higher risk, UK maternal mortality rate had shown this, but the consensus is saying that RCOG, Lancet, WHO, ACOG also have talked about it, that we have to look at obstetric indications only for delivery. And this was the wonderful helpline number our Foxy President 2020 had started on the patient safety day for Foxians, one for medico-legal and one for COVID. And I'm happy to say that a lot of us were part of the helpline. And here, of course, because treatment policies keep changing, finally you go to Bhagwan Bharose. Upar wala bachaye, to hi bachegi, aisi bhi halat hui hai. So these are certain things and treatment protocols. Can anyone comment on steroids? When should you start steroids? We've talked about the severe case. So this is something which is extremely important. We should, because sometimes they don't, now of course the physicians get involved. About steroids in pregnancy with COVID, you have to remember in the viremic phase, it should not be started and not on patients who are at home. Sometimes people, general practitioners and all have started patients on high dose steroids at home. That is completely wrong. And in the virus replication phase, if you start steroids, you're going to make more trouble for the patient.
The right dose of steroid, the right time.
Yes. So
And the
only
right
if you
dose.
feel she's moderate to severe, she needs admission, that's when you start the steroids. And that is to stop the cytokine storm. Yes.
Dexamethasone has to be given preference over the prednisolone.
Yes. Yeah. So in fact, and no hypoxia, no steroids. If you're, that is another golden rule we have to remember. And we've somebody was talking about anticoagulants. Would you all like to comment on that?
I just wanted to ask about steroid. Whether being an obstetrician, we are legally allowed to prescribe steroids, or should we be taking the physician decision?
Munjal,
That
if the
is-
general practitioner also can prescribe
True.
steroids, we definitely are more qualified than them. But
You have to involve the others.
Yeah.
Should be a multidisciplinary team.
Like where we were, where there was very much load of COVID, practically it happened that even the surgeons were treating, and so pregnancy we used to start, and then definitely whenever the physicians got time, they were.
But Munjal's question, is important because that 30-week patient which we talked about, steroids for lung maturity, is that separate from this? But steroid for lung maturity, anyway we give. But along with that, we have to continue with the other steroids as per your hospital protocol. So what is being given, and dexamethasone seems to be the preferable one, which is available everywhere and it is being used. We can give that. And low molecular weight heparin, although they say unfractionated heparin is easier, is better because it can be stopped if she goes into labor, and within a short period, you will be able to stop it. Unfortunately, it is very difficult to titrate the dose.
And another thing is thrombocytopenia.
Yes.
Thrombocytopenia. Even the COVID can cause thrombocytopenia. Heparin can cause.
Even with LMWH, there is monitoring of anti-10X activity before you start the first dose, and then monitoring would be helpful.
So
As
these-
they say, literature,
yes,
but
yes.
then practicality is very
And
different.
these tests are very expensive. Dr. Nalini spoke about procalcitonin. It's a very costly test. It is not done everywhere. Patient as it is complaining, and we have these government schemes, JSSK, JSY, which say that don't make the pregnant patient even buy, a single tablet of paracetamol. Everything should be given through the government schemes. So to do these tests also becomes difficult. So we have to use our judgment. But what you talked about, serum ferritin and IL-6 are two important things. D-dimer is anyway elevated in pregnancy. And you have to look at what is the range, nanogram per ml or milligram per liter. But usually, if it is more than up to 500, is just pregnancy-related change. If it's above 1,000, the D-dimer level is, and Nalini spoke about 10,000.
That will be dependent upon
Trimester, yes.
First trimester it is 1,200 or 1,500 something, but otherwise it is up to 600.
So so ferritin and interleukin-6 are more important as markers of severity. D-dimer will just help us.
Even
Yes,
with
Munjal.
D-dimer, some of the pathologists said that, like in malaria, we don't do D-dimer. In chikungunya, we don't do D-dimer. So there might be other causes of rise in D-dimer, and that is why it was non-specific, along with the rise in pregnancy, which is expected anyway. So
Yeah.
She's a post-cesarean section patient who's just recently developed COVID, then maybe heparin should be advised.
So
to them
we'll,
because
the
they'll
last
not be,
case is post-cesarean.
yeah.
But before we go to that case, This is just a summary of various treatment protocols of antivirals. Now, again, remdesivir was first thought to be the blue-eyed boy. Then there was a lot of discussion that remdesivir should not be done. But we are giving it for severely and critically ill patients, 200 milligram on day 1 and then 100 milligram once a day for 5 days.
But ma'am, of late, the latest guideline which the WHO delivered, they were saying that the remdesivir is of no use. and we don't have
But
to
it
give
is useful in patients who is
But
deteriorating.
we have all used
Yeah,
it, but
yeah.
after that it was given after
The-
second wave.
The
that
patient is
now-
not improving with other drugs. Definitely we
And
can.
remdesivir, the recovery trial actually showed there was a slight reduction in mortality when it was used along with steroids, not used alone. So in patients who are on steroids, who are not responding to steroids, it is used and we are still using it. But the other drugs like oral favipiravir, oseltamivir, which we use for swine flu, are all out. And
Another new drug that is coming is tocilizumab, because especially the recommendation by the RCOG is if the CRP is more than 120, CRP is more than 75, or any patient who is admitted in the ICU, you have to give tocilizumab. It definitely has a survival benefit.
so this drug Tosi, to be honest, let me be, I myself have taken this because I was having abnormal IL-6 and there was a whole dilemma. They did remdesivir and Tosi was brought and kept. I was of course in no state to decide, but they said remdesivir will not work on her. She's going into cytokine storm. It was like a magic bullet. And I actually recovered from the breathlessness and need for high flow oxygen. But the next day, the Covacta trial was published, which said Tosi is useless. So of course, I read up all this later when I recovered, but I'm just telling you that statistics and clinical judgment don't always go hand in hand. And you have to trust the doctor to whom you're going and use the clinical judgment to
Actually, it's
decide
an
what will work.
individualized thing.
So
You can't say what will work
cases
for
have to be
everyone. Yes.
individualized. This I'm speaking from personal experience. So let us go to the next case. Yeah, and another thing, inhalational steroids. You know, asthmatics, you really wonder that the inhalational budesonide, which is used by a lot of people, is something which sometimes protects them from getting severe COVID, because that is something which is also recommended, which can be used in the home isolated patients. And we've talked about steroids already. So, and this is the SOFA score, which has been modified for obstetrics, which we are looking at here in the interest of time. And low molecular weight heparin we talked about. Sir, you would like to comment on this? Yeah.
Actually, we give low molecular weight heparin to all patients who is admitted in the hospital. And we should continue it for at least 10 days. Yeah, it's very important.
10 days has been suggested, and thromboprophylaxis may be continued with. So low dose aspirin is a viable option, especially when now the drugs are expensive. Patients are not able to take it at home. So 150 milligram per day given after a meal can be given to women who are not able to take heparin once they are being discharged. And these are some of the guidelines.
But our first option is definitely low molecular weight heparin. If
Low
the patient is not able to take it, then only
Yes,
go for it.
Munjal wants to say something.
With regards to this LMWH shifting to aspirin, I just wanted to ask one particular question, that is like steroid, whether we would require tapering, because there are views where tapering of doses is not required with steroids, and there were views where there was actually recommendation of tapering of doses of steroids. So what was the take on that particular practical?
So Munjal, actually, I'm supposed to ask you the question, but
So
since
basically,
you have asked two questions. He has
Sorry,
asked one
sorry.
question about steroids tapering. The answer is yes. The steroids, most of the medical protocols do say you need to taper the steroids and then stop. And it is being done. A lot of patients are sent home on tapered dose of steroids if they have been on high doses for a while. But the other question is about the crossover from low molecular weight heparin to aspirin. There is no need to do any tapering. You can just start or, add the aspirin 1 or 2 days before you are planning to stop 1 day. Yeah.
So I just
Yes.
asked with regards to there is
Yes.
no
Yes.
black and white in those cases. So I
Yes.
just wanted to know, because the experiences would be shared. So
Yes. No, but you're right. We are not tapering, and we are. Yes, you just add it. There is no issue. And actually, we have to remember it's the INR and the APTT which we are supposed to use. The bleeding time, clotting time really does not give us any information. So can we go to the next case, sir? Yeah.
The next case is she's a para 1 L1 post-update 2. She had an emergency CS done in view of fetal distress, was referred from a local private hospital as the patient turned COVID positive. They had no facilities for the same. She has no comorbidities and is stable.
So this
And
is what,
who want to take that?
Yeah. One of you all were asking, that if patients sometimes come COVID positive after delivery.
Yeah, so most
Now
of
what to
the
do?
patients were referred to a COVID ward. Maybe the RT-PCR had come late, and that's why they were referred later. So maybe if once postpartum patient comes, I feel that low molecular weight heparin should be started, even if she is stable with no comorbidities. And maybe then, as we were discussing, given it for 10 days and then taper it down towards aspirin, shift her to on aspirin, and then send her home.
Okay. Will you allow her to breastfeed?
Here I will share my personal experience. Like we have received many patients like this, but we haven't given them LMWH, maybe in view of the limited resources or whatever. But we have been following them with the sequential laboratory investigations, and just 1 or 2 required LMWH. Rest we did not give.
No, but Dr.
definitely
Nalini, then what did you give?
That's what I'm saying. But definitely we were very, very vigilant about their, ambulatory status and promoting that, and that had helped.
Actually, we heard some even asymptomatic patients coming died that after this. So it has to be given.
We did not, and
Yeah.
we did not have any
Postpartum
morbidity, but
patients-
definitely if the patients moved from asymptomatic to, low morbidity to the severity, then we definitely added.
Definitely,
But
we have to
this type
recommend
of-
low molecular weight heparin after delivery.
So,
But I'm telling you the personal
no,
experience
but
I told.
one second. There are 2 important points in what Dr. Nalini is saying. She's saying ambulate. But on the other hand, we are saying we're supposed to isolate them.
Isolate.
So if you are putting like we had actually got one, all of us in institutes are supposed to have a separate COVID ward.
Yes, we have.
So you can allow them
Yes.
ambulation inside that.
Yes.
So what she has said is that that kind of ambulation is to be advised.
Yes.
And our country, most of the areas do not have very cold or those other factors. So you
So-
can use your
and-
discretion.
As
But-
sir asked about breastfeeding with COVID appropriate behavior, that was also allowed.
Yeah.
Yes.
We had allowed.
So I think
in
this
active
is
viral
yeah.
phase,
Yes.
we should allow breastfeeding, but I think rooming in which should be avoided during that active viral phase.
So Nilesh, you have touched upon a very important point. So how many of you are doing rooming in? Can you put up your hands? What is the view? Nobody. So here I would like to, yes, Munjal. You're raising hands for rooming in. Well, I would like to say that, okay, this is just values to remember for the pro-inflammatory markers. For those who are interested, this is just a summary table of this for your information. And D-dimer, we've already talked about, and ferritin, antibiotics. Now, impact on the fetus. It has been said that COVID-19 does not necessarily have serious complications in the fetus. And this is the most important point. Mothers who wish to breastfeed should be allowed to breastfeed. Rooming in also, in fact, I'm happy to say that on World Breastfeeding Week, we have released a complete manual, which in fact, if anybody is interested, you can mail me. I will send you all the PowerPoints also. And through MCure, we have published the book in which we have got neonatology experts who have talked about it. And everyone says just a minute, that is wait for a minute for cord clamping. Rooming in and bedding in is also allowed, because most hospitals, you have the foreign guidelines at first said keep the mother and baby 6 feet apart. We don't have 6 feet for 6 patients also. Sometimes it is that difficult.
Even skin to skin contact is
Yes.
allowed.
Skin to skin contact is also allowed, but meticulous hand washing and use of masks. So here I'd like to say our personal data, 650 COVID positive women in 20 months, only 4 babies turned COVID positive, with all this being followed. Skin to skin contact, rooming in, bedding in, exclusive breastfeeding. So it's a very low incidence, and most of the international studies have also supported that. And a viral DNA has rarely been detected in tissues and body fluid. And there are certain criteria for that. Most of the studies say not more than 1.8% of neonates become positive. So all these questions, can my baby stay with me? Yes.
Yes.
Can I breastfeed my baby? Yes. As I'm already infected, will I need the vaccine? So, after 6 months, we'll be last case is on vaccination. We are and when will I be eligible for the vaccine? So these are WHO patient information charts, which you can download and put up in your hospital so that you don't have to keep answering the same question. These are put by WHO. They can be downloaded about breastfeeding, COVID, coronavirus, and you can put them up. And these are what WHO is recommending to patients about for breastfeeding mothers. And this is if the person is in ICU and severely ill, even then they say pumping and giving the breast milk is important. So the last case, sir, you want to read it?
She's a 36-year-old woman, primi gravida, diagnosed with diabetes, hypertension, and thyroid during pregnancy.
Should she
All
take-
controlled on medication. Can I take COVID vaccination?
Yes. So I think our previous session, Archana spoke very well on vaccination and pregnancy, and this was covered. But some of you who did not attend that session, the bottom line is COVID vaccination should be given, and women with comorbidities are more at risk, and they should in fact not be denied. Only thing here I would like to add, there are guidelines that the vaccine should be given in a tertiary care or this setting, not in a, in case they have adverse events, and if the person is on a blood thinner, like for example, for hypertension, I've already put her on low dose aspirin, pressure at the injection site, waiting for a little longer time and keeping her under observation. And and even if she wants to take in the first trimester, there is no problem. So these are the current guidelines, and Ministry of Health and Family Welfare had come out with the letter. And I have to say our Ahmedabad Society headed by Alpesh ji has really worked hard, and it has been a battle. Initially, when the vaccination guidelines, pregnancy lactation was a contraindication, but FIGO had already given that recommendation. We followed it in, we follow international guidelines like ACOG, and FOXI has also said this, and we empower women to make their own decisions. So we don't need to do a pregnancy test before giving the vaccine. If she says, I'm pregnant, I want the vaccine. In fact, in our vaccination centers, there are queues, but pregnant women are supposed to be allowed to bypass the queue and should be given priority. Those are the government guidelines. And there is no need for MTP if she has taken vaccine in first trimester. So these are the key messages. So can we have each of the panelists telling us what you feel is the key message we want to give to our audience? Last 5 minutes. Yeah.
That we need to, stay updated with regards to the treatment guidelines as well as the counseling part, and at the same time, not taking those labels of COVID heroes. We need to save ourselves from the proper documentation and paperwork. Thank you.
So Munjal is emphasizing the importance of taking care of yourself and the patient both. So safety first for pregnant women and for Foxians.
I think initially it was thought that pregnant women are not at an increased risk of COVID-19. I think which is not a fact now. They are definitely at an increased risk and respiratory symptoms as against non-pregnant women, and this fact should be highlighted.
Okay, thank you.
Yes, we should inform them about all risk and morbidities, but it's our duty to not to scare them, because their mental health is also very important. And I feel as obstetricians that tender loving care has to be given at all times.
Yes, Niharika, that's a very important aspect. Yes.
We need to basically treat pregnancy as pregnancy itself. Nothing should be left behind because she's pregnant, because she is COVID positive. So we do not give her proper care that she deserves. At the same time, only indications for MTP or cesarean section or induction are only obstetric indications by and large. And also we need to keep ourselves updated, because something which is a major guideline yesterday becomes contraindication today. So we need to keep pace.
Nalini ji has made a very important thing, that keep up with the changing times. And these are my recommendations to just tell you that how our own facility, I can't say that I need a new building of the hospital to do it. Use your facility, adapt, accommodate, and act proper use of whatever protective equipment is there. Then otherwise, then there is chaos. And try to get a separate area for donning and doffing. That is also important, and teamwork. And you can see here, India's largest slum, Dharavi. You can see the mobile phone. Doctors from Sion Hospital are doing teleconsultation to reduce the number of visits to fight the corona. And sir, your message, what would you also like to give an important message to the panelists?
Yeah, we have seen the changing things. Actually, in the first wave, actually, most of the women were asymptomatic. The second wave, we have seen symptomatic women, more mothers dying. And now we don't know what is going to happen with Omicron. So we have to be updated.
Yes. So thank you, everyone. And thank you, audience, for being here with us. And I think we have finished 15 minutes earlier. So we can take one question from the audience, 1 or 2 questions, Munjal, or we want to, yeah. But I think we've answered all the questions. So let's have a photograph of all the panel. Chalo, come. Thank you everyone for a patient hearing and for being with us today. Thank you.
Thank you, Reena ma'am, Ajit sir, and all the panelists for this intense discussion. And now for the next session, we have Justice India session on a topic which is very challenging, and every one of us are facing this, especially at Tertiary Care Center. This is on panel on near miss cases, the unseen base of an iceberg. And I would like to invite the esteemed moderators for the session, Dr. Girija Bagman and Dr. Arun Madhav Barua, sir. I request sir and ma'am, please come on the dais and take the seats. And I take this opportunity to introduce our moderators. Girija Bagh ma'am is a professor OBGYN, Bharati Vidyapeeth Medical College Hospital, Pune, and she's consultant Cloud9 Apollo Hospital, Pune. Ma'am was a chairperson Medical Disorder in Pregnancy Committee, FOXI, since 2012 to 16. And ma'am is moderator National Eclampsia Registry since 2008. And ma'am is supervisory board of PCPNDT Act 2010 and 2014. And ma'am has won award for excellence in medical services. I welcome you, ma'am. Please take the seat. And our next moderator is Arun Madhav Barua, sir. Sir is consultant Apollo Fertility, Guwahati, Assam, chairperson ISAR and NE Northeast, IAGE, president Dibrugarh OBGYN Society, senior vice president IMA Assam State Branch, vice president East SOVSI, and active Rotarian for more than 25 years. I welcome you, sir, on the dais. And I would like to call our esteemed panelists for the discussion. Dr. Deepak Bhagre, sir. So please come on the dais. Dr. Mitra Saxena, ma'am. Dr. Sampat Kumari, ma'am. Dr. Uma Pandya, ma'am. Dr. Vidyadhar Balkrishna, sir. And Dr. Pankaj Nimbalkar, sir. We all know Deepak Bhagre, sir. I don't have to introduce, sir, but for the formality, sir is a past, sir has held many prestigious past positions. Sir, he has the Department of Gynec, MP Shah Medical College, Jamnagar, and Scientific Committee Chairman, Gujarat State Gynecologist, President Jamnagar Gynecological Society, President Jamnagar IMA, and Member Board of Studies, Saurashtra University. Welcome, sir. Mitra Saxena, ma'am, is chairperson elect Practical Obstetric Committee FOXI 21 for 21-24, and ma'am is a senior. I think Mitra Saxena, ma'am, is not here. Okay, okay. Uma Pandya, ma'am, is not here. And our second panelist is Professor S. Sampat Kumari, ma'am, and ma'am is chief and HOD at Muthukumaran Medical College and Research Center, Chennai, and ma'am has written many chapters in FOXI textbook, FOXI Focus, and newsletter. A very learned person. I welcome you, ma'am. Then we have next esteemed panelist, Dr. Vidyadhar Bengal, India, professor and HOD Obstetrics and Gynecology, Parvara Institute of Medical Sciences, Loni, Maharashtra. Welcome, sir, on the dais. And next panelist is Dr. Pankaj B. Nimbalkar from India. Sir is Medical Superintendent, HOD in OBGYN, Nutan Medical College and Research Center, Visnagar, Mehsana, Gujarat. Welcome, sir, on the board. And I would request our moderators to kindly take the
proceeding. Good morning, everybody. We bring you greetings from Pune, that's me, and from Guwahati, now east, west, to Ahmedabad and to everywhere through all across the country, because I understand this is a hybrid meeting. And we have been given with an opportunity of dealing with understanding of the near miss cases, the unseen base of an iceberg. And that's very important, is the iceberg, the unseen base of the iceberg is what. And we are indeed extremely honored to have wonderful panelists like Dr. Deepak Bagde, very, very senior friend and philosopher and a practitioner, Dr. Sampath Kumari, always a very, very down-to-earth person and done lots and lots of work. My very dear friend, Dr. Vidyadhar Bangal, and I must tell you that he's working in our part of the state, person who has been working silently lots. He has the Bill Gates Foundation, sort of grants and associations, wonderful publications to him. And you must just go and see his labor room to believe what he's really doing there. It's a very, very impressive work. And that's something that we all must appreciate about Dr. Vidyadhar Bangal. And Dr. Pankaj Nimbarkar, I have come to know him just recently, but he also has a department and he looks after a tertiary care center. And of course, we cannot start off this panel without paying our gratitude to Dr. Alpesh Bhai and appreciating his work. Productivity is never an accident. It's always the result of a commitment to excellence, intelligent planning, and focused effort. And that's what Alpesh Bhai has always shown us. And therefore, likewise, we also have a commitment towards the maternal mortality rate in our country. And therefore, this panel is very, very well placed. As you understand, my friends, that 2030 has been set as a goal for us to reduce the maternal mortality ratio less than 70. And all of us have to be extremely aware of this goal. And not only that, while we are achieving this goal, we cannot forget that women and children have to be taken care of, because that is going to be a brewing ground for future health of this country based on the Barker's hypothesis. And therefore, we have to be looking at the women's health, and we should all feel extremely privileged to become OBGYN specialists so that we can really try to modify the future health of our society. Now, coming to the near miss situations, when you are considering a single injury, it has been found, you can look at the pyramid that I put down here, you will find that there will be 29 minor injuries associated, while there would be 300 near miss situations. So whenever we are talking of near miss situations, and if you're trying to target them, we are trying to avert those situations which can be avoidable, because we are going to avoid so many other things. Now, these near misses are not always going to restore the woman back to her normal health. Maybe they'll continue to keep her morbid. And therefore, it's very important. And what has been found, most importantly, 3,000 unsafe acts, behaviors, and conditions can lead to this condition. And therefore, we have decided to take this panel, as has been told to us by our, the organizer, that we have to consider looking at the preventive aspect more, so that we can come and try to avert this near misidentification criteria. And if you look at the WHO, it talks about cardiovascular, respiratory, renal, hematological, coagulation, hepatic, neurological. So many things come into being the moment a woman becomes a little abnormal while the course of her pregnancy. And then such kind of things may ensue. She may throw a convulsion, she may have neurological problems, she may have to go into an ICU, and she may have really, really doubts about her survival. And therefore, we believe, and this is a session on gestosis, that we don't only look at hypertension as a cause, because today there's a lot of knowledge which is telling us that even despite there not being hypertension, there can be disorder. So whenever the pregnancy goes wrong, these spectrum of disorders, ranging from already existing chronic hypertension in the pregnancy to complex multisystem disorder like preeclampsia, leading to complications like eclampsia, HELP, pulmonary edema, stroke, and LVF, including the late onset preeclampsia and the postpartum eclampsia and the disorders. We call this entire conglomerate as gestosis, because it is not only known to affect the mother, but it is also known to affect the babies now and in its future. So with this, we begin with our first case, and I request Dr. Arun to take it from here.
Very warm good morning to everyone. And before I take it over, I must say I come from a place where we have the highest maternal mortality, and thereby fully understanding well that we must be having a huge lot of near misses and a severe maternal morbidity that everyone who are practicing in that region, what we call reaching the unreached, we are all ashamed of. But we alone, gynecologists, cannot really act. But I'm sure with our knowledge, with our perspective, with our awareness, I think we can create that in a society. And today we have been able to bring it down from 412 10 years back now to 200. And we are aiming to get it down to 150 in next 2 years. I hope we need your blessings and a conference like this where we come and stand and share the podium. Feel little elated as well. And I must say, Alpesh Bhai has been really kind enough to give us a lot of support. And my dear friend, we are not friends only for now. We have been friends for more than 35 years now. I think we need support from every nook and corner to be at par, because when it comes down to India, we are not supposed to be left behind. So we are working hard. 70 might be a little difficult, but as we say, we must put our right foot forward. Okay. I think Girija has given a very nice platform, and there were some questions why we are taking only gestosis. See, hypertension is one area. If we can strike it hard and bring the near misses down, I think we'll be getting down almost 50% of the near misses. So that's why we'll just confine ourselves to that, and let us be master of one than trying to get to too many things. So the first case is 28 years, who has been married for 2 years. Look at the BMI 35. Hypothyroid, mild anemia, pre-diabetic. Her first pregnancy was 5.6 week, missed abortion. Subsequently, she has been advised to go for an IVF for some reason or the other. IVF, they have conceived with ICSI, and 26 weeks, she landed up with early onset preeclamptic toxemia, and which ended up horridly because of an intrauterine death and abruption, and ending up with HELP syndrome. That doesn't stop there itself. It continued to the postpartum, and there was cardiomyopathy. Can I ask any one of the panel, because you are all so ready, Dr. Pankaj would be the right person because we are starting from our side. The risk factors that we have been enumerating, do you think that there were reasons sufficient enough to not to go into the...
Just check the mic, please. You just try to speak in that. It doesn't show any light. Just speak.
That is also a near miss.
Check.
Hello. Yes, in this case, the risk factors is the young age. In young age, patient is obese and also having hypothyroid and mild anemia and pre-diabetic consequences.
So, okay, let us take one by one.
Yes, obesity is associated with leads to preeclampsia, and most of the patient obese are short stature. So short stature and preeclampsia is also correlated with each other.
Okay, every one of you probably agree to this, and we need to tackle obesity because obesity in this country is also catching up fast. And until unless we make that particular frame of the woman perfect for the responsibility of the next 3 generations that we are going to create, and I think we are not putting our right step forward. Okay, we move on. Yes. Anemia, 76% of the Indian women seems to be anemic. And do we need to pay any attention to rectify this before we allow the patient to become pregnant? I think this is a very important take, and every OBGYN need to put this particular step.
I think not only the anemia part, even she could have controlled her weight.
Yes, exactly.
Anemia, hypothyroid.
Yes, exactly. So important. So we all have to appreciate
that she went into IVF at this stage. I think we could have considered that.
This is a disgrace for the ART part of the country because whosoever
Yes, you get good results in fertility part, but what you end up is something like this.
I think the new concept that everyone should try to understand that erythrocyte complement receptor type 1 is the main immune complex clearance mechanism in humans, and that is being genetically controlled, and the people with PET really lack this particular thing. So we have to understand this, because science today is taking us down to the wire, and if we do not understand that, I think it is difficult for us to explain to the patients who are coming to us with Google every day, and you have to be smart enough in front of them. Yes, you are in science every step. As you rightly said, thyroid is a very important component, and we all know more than 26% of the community of this subcontinent has got thyroid disorders, and 70% of them are autoimmune. So we have good logic to control them before we allow them to become pregnant, because creating a next generation is always a responsibility we should share with our patients. And not to say of this, the capital, as you all say, GDM, it actually brings in and requesting everyone to judge for GDM at least with 3 to 4 samples during the specified time of antenatal period.
So basically, to reiterate once again that whenever we are talking of anemia, we always take it for granted. But there are receptors which are sitting on the erythrocytes, and these are known to clear complexes which may build up in preeclampsia. And that is the importance of anemia that was brought about in this particular case. And as rightly said, we are going to come to IVF, as Dr. Sampath Kumari is going to comment on that. And insulin resistance, I somehow don't like to call it as diabetes or GDM. I think we should start looking at hyperglycemia, insulin resistance, because that is the time when we'll be able to avoid this near misses. Now, we had this particular study in our center at the, and this is an ICMR supported study in Bharati Vidyapeeth University, where we decided to investigate mechanisms leading to preeclampsia. And this is a 5 years duration study. We did our interim analysis. And what was found that women with preeclampsia were older, professionals, and educated nulliparous. And percentage of women who conceived by ART were higher in the preeclampsia group. And they had higher BMI, systolic and diastolic blood pressure in preeclampsia, all time points. There were various time points you can see during the antenatal period where there were samples, and higher percent of women in preeclampsia group delivered by C-sections. And higher levels of TSH at 11 to 14 weeks and 26 to 28 weeks in the preeclampsia group were definitely pointing towards the possibility of preeclampsia. So Dr. Mitra Saxena madam is not here. And therefore, I would ask this question to Dr. Sampath Kumari, madam. Do you give merit to the history of missed abortion, and why? This patient had a history of, let's say, 6 weeks missed abortion. So what would be the importance?
So probably that was the first missed abortion. Already she had hypothyroid, mild anemia, and pre-diabetic. What I suggest is, before we have to, she's only 28 years old. So for all patients, I may be out of the question, but still the premarital counseling in all hospitals, in our hospital, we have the antenatal OP side by, we have the counseling. All patients, even it is a government hospital, we do counseling for just 30 minutes. Every 30 minutes, batch will be coming. So the hypothyroid should have been corrected, and universal screening is very, very important. Nowadays, we are not doing for all patients, but still it is important. So that anyone may be the cause, that a hypothyroid, or it can be a GDM or whatever it is. But still nowadays, even one abortion, it is an importance. After that, we have to evaluate why this, what was her BP, and previously what was the conditions. So I will give importance to this missed abortion, and after that I will evaluate her, and then only she has to become pregnant for the next.
Absolutely.
Yes, Dr. Sampath Kumari, I absolutely agree. But still, 5.6 weeks and first abortion at 28 weeks. So I would really not consider as lots of other choices. Let us put it, because at least 15 to 17% of our women aborts at 28 years in the first.
Yeah.
Yes, suppose this pregnancy was 10 weeks with a cardiac activity noted, then I would certainly put into the other vascular disease. But for 5.6, I'll be skeptical. Frankly, if you are asking me, I wouldn't really go for all the investigations.
So gestational age at the time of missed abortion matters. And I think that's very wonderfully brought about by Dr. Deepak Bagde, sir, that whenever you're trying to put the women through a lot of investigations with one miscarriage, please look at her background risk factors. And as Madam Sampath Kumari said, there cannot be any replacement for proper assessment and history. And of course, many times, as we all know, the most uncertain thing is the human pregnancy. Out of the 100 pregnancies that occur, nearly 60 die in the chemical stage and only few will reach. So don't pressurize the patient too much. But in this particular patient, in retrospection, we feel that was she probably having some thrombophilia? Why did she land up in abruption and early onset preeclampsia? And we must have a round of applause for Dr. Sampath Kumari and the Tamil Nadu state in our country. Not only for the fact that they keep on talking about prevention, this was the state which brought up the largest number of GDM screening, and that created the DIPSI test for us with a lot of confidence. Secondly, she's speaking about preconceptional optimization of health, and most importantly now, even in the government hospitals of Tamil Nadu, women are subjected to cardiac evaluation during pregnancy universally. I think that is something, and all of us have to take inspiration from all these things. So now coming back to you, madam, again, was ART rational in this woman?
Definitely, she is
Dr.
one.
Bagde has already said it was
It's not at
rational.
all necessary. First, we should control whatever the risk factors she is having. And then, but at the age of 28 years, there is no necessity for her to go for ART or ICSI or whatever it is. She has to be counseled. She can become a normal pregnancy itself without this ART procedure, and she would not have ended up with this complications.
Absolutely.
Maybe.
ART itself, I think, is.
Sunil Shah sir wants to say something. Yes. That is very important. Yeah. 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 Absolutely. Yeah. Not indicated.
Sunil, no. Sunil, okay, we'll not discuss the indications. Okay, we'll just discuss the preconditions of the patient. See, forget the okay. ART, I absolutely agree. See, if she had a spontaneous.
I'll not take this battle beyond this, because yes, we can go on and on. Yes, there'll be fights and everything with good scientific. We have to agree with what Sunil said. That's also rational, because everybody today in our platform do it judiciously for the benefit of the patient. But when we are talking of science, I think first abortion, if there's a definite indication, that should have been anyway. Let us take it beyond.
So ART IVF pregnancies are also associated with preeclampsia and abnormal pregnancy outcomes, because azoospermic oligospermic partners would have a risk of developing preeclampsia. And especially when you give ICSI or oocyte donation, then this can be further a problem. Now, Dr. Uma Pandya is not there. So this question goes to my very dear friend, Dr. Bangal. Early IUDs in association with preeclampsia, what is the connection and can we prevent it? Doppler surveillance, LMWH, LDA, what is your take? Now I'm going to tell you something. Most of the times in private practices, we get driven because of the pressure from the patient. And therefore we land up giving sometimes LMWH, which may not be indicated, which may also be indicated. And likewise, low dose aspirin is now flowing through all our pens. And now with COVID and everything and the SPREE study, we are using it left, right, and center. Plus we have come with a justosis score in our country. But this patient had this IUD very early onset. So one, how would preeclampsia associated with IUD, and would you consider giving these as prophylactic measures, or would you want to do Doppler studies?
One important point you have missed, that there's a pressure from the pharma industry as well.
Okay. Are you taking that?
No, but when you're talking about everyone, then that should also come.
Okay.
Yes.
Yeah, there is a evidence which suggests that around 11 or 13 weeks of pregnancy, if we do uterine artery Doppler with a pulsatility index 90th centile, there is definite evidence which suggests that if we do uterine artery PI values and if they are abnormal, there is definite evidence that these women are likely to have preeclampsia in later life. And also, depending upon the severity of preeclampsia, IUD can also happen. So Doppler studies do have or early predictor value in the detection or prediction of preeclampsia. So that can be, depending upon the case to case, we can take help of that Doppler study and decide whether it is useful or not. So that is one thing which relates with the preeclampsia and IUD and maybe early screening. These are screening sort of tests that can be done. So this is what I would like to suggest.
Do you like to highlight on the route of the study, transabdominal and transvaginal, because they also differ. The values also differ when you do it transabdominally and transvaginally, because that's an important component, because normally they do not mention. We have to see the plates and then take up our own calls, because transabdominally and transvaginally, the values are not identical. That's what we have to remember.
Yeah. So I think transvaginal would be more,
Yeah.
more reliable than
And with the
transabdominal in
obesity
early
coming up
pregnancy.
many times, it would be better to do a transvaginal if you are not having proper access. Secondly, you can also have the same bus be taken around second trimester. Usually we do the anomaly scans between 19 to 20
Sure.
weeks. So please tell your radiologist to do a uterine RTPI because this patient has risk factors. Yes, Deepak?
But then, starting aspirin would be very late in those cases.
Yeah.
Yes. See, basically, if the aspirins are going to work only before
Absolutely.
16 weeks, so 11 to 13 weeks scan with a
Yes.
uterine artery Doppler is a must.
Yeah.
There is no doubt about it.
Absolutely.
Yes, anomaly scan you can go ahead, but at that time I think starting aspirin would be very late. Yes,
Okay.
Madam.
Yes, please.
Yes.
Who are going to have severe onset of early
Early onset
preeclampsia. So it's less than 28 weeks. We can say that there is a severe onset of preeclampsia. So the first trimester uterine mean uterine PI is very important. Mean PI, that is both the uterine you have to screen. And in second trimester, if the PI is high, 95th centile, then you have to scan growth scan at around 28 weeks. So you have to say the patient to come on 28 weeks for serial growth scan, and that is for late onset of preeclampsia. That is after 34 weeks.
The question is, yes, the growth cancer, everything is okay. By that time, you already missed the bus. So
whole-
you got
whole
to start
import-
the aspirin before 16 weeks. Then the growth scan.
Yes.
So what he's trying to say is very important because in certain parts of a country, what happens, sir, is they're only doing sonography. Then if you have to do a color Doppler, you have to write specially, then the charges will be different. So this all
Exactly.
now it's high time that we communicated with our radiology friends if they are doing it, or if yourself you are doing, definitely we will be looking at the Dopplers. So these are the simple messages that we wanted to get across. And as you rightly said, the best effective action of aspirin would be when it is started before 12 weeks of gestation, latest maybe by 16 weeks of gestation, but before that, and therefore you must try to clinch this bus ahead. And especially, yes, Vidyadhar sir, you are saying something. You're saying? Yeah.
Now we'll just come to
We'll
that.
be coming to
We're
that. So
coming to that.
basically what is very important is that we have to look at risk factors. If you don't want to do everything universally, do the risk factor assessment as Sampath Kumari madam said with history, and then subject this patient. And as Dr. Bengal said that we can consider one thing which I'm unfortunately not put up here on the slide, but I would like to discuss. There's a recent publication which talks about, I think it's a meta-analysis which talks about thrombophilia associated issues. Now, the challenge in our country is we do not know thrombophilias in many patients. We don't do screening. But it has been found that if you are able to do Doppler serially, you will be able to analyze this resistance early and prevent IUDs by giving her low molecular weight heparin and combination of low dose aspirin, because the trophoblastic tissues and the microvessels are occluded. Now, this was all which we were saying as perception all these days, but these are definitely getting altered. And this also alter the baby's cardiac functioning, which can be studied by doing a fetal 2D echo at around 22 to 23 weeks. So that is something that we have to bring across.
Now we are coming to the hot cake now. I think this aspirin along with LMWH has become the most importantly prescribed drug in any high risk cases. The rationale of doing it has been known to every one of us, but the doses remains really controversial because the studies that we have across the globe are mostly done on the white woman, and we in this part of the country must decide what is the optimal dose for the Indian woman. Yes, there is a dose schedule based on a body weight, but we do not have a specific Indian data to say that what dose really we should go about. So we thought that 150 would be the ideal because we are always trying to copy and see the results in our country. And every one of you will agree that putting the right dose at the right time really gives us a good result. As you said, bringing this particular practice in my state and my area, we have been able to bring down the hypertensive effect to the tune of 15 to 20%. And I must say, this has been a tremendous cost-effective procedure that I'm trying to promote widely in my region, because hypertension has been one of the greatest killer along with anemia in my region.
So it's not only the platelet the thromboxane synthesis diminisher, but it also modulates inflammation. And that particular credential has to be given. And as we can see that binding of the decidual cells and extravilous trophoblasts induce inflammatory responses during preeclampsia. And they affect angiogenesis and spiral artery development. And that is why when Dr. Bagde said, start it early, that's the reason. Because before the first placentation, if you're able to start, if not at all, maybe at around 16 weeks when the second wave is forming, you will be able to help. And how does low-dose aspirin modulate placental exosome release and protein in microRNA contents? And this has been brought about by a wonderful way in which it can reduce the systemic maternal cell activation. And therefore, some studies are saying, doesn't matter. Even if the patient has come late, till 26 weeks, you can still start giving her low-dose aspirin. Maybe she'll get that little window of opportunity. And definitely for prevention, as we have been talking. And thrombophilias have to be analyzed studies. It may not be a full-blown APLA, which can give rise to thrombosis, but it can be hyperhomocystinemia also. And so let's pay attention to simple things like folic acid deficiencies, nutritional deficiencies, which can help, because we all know that these thromboses can be brought about by these thrombogenic states can be reduced by giving LMWH. What are the evidences for aspirin is something which is very effective. It is effective in preventing, given at 150 milligrams at night, initiated at 11 to 14 weeks. 16 weeks identification of women at high risk should be done early, and that's very important. And there is what is very also identifying it, it has reduced the length of stay in the neonatal intensive unit by 68%, has no evident beneficial effect in women with chronic hypertension. Beneficial effect, as Dr. Arun showed from his own practical experience on preeclampsia rates, and more studies are necessary. So all of us required to collate this data and to understand. Now you can see that the 2014 task force, and this has been reiterating again in 2020 ACOG, which talks about high, moderate, low risk factors. And most of our patients have these factors. And we have to remember that we have to start this aspirin. When do you discontinue? We do not have the consensus. But yes, we can continue till the patient delivers without any fear. So coming back to Dr. Bangal, sir, when and which ones should we ideally do the laboratory investigations in patients of HDP? Now, this particular patient presents to you with blood pressure, or whenever, like a patient has risk factors, she's come to you. When will you order the HDP justosis labs?
Yeah. When patient has presented with hypertension and we have labeled it as a hypertensive disorder, the battery of investigations are there, which we should advise them from at the very first visit. They should not be in delay. And the laboratory investigations, they are hematological, complete blood picture, including peripheral smear should be done. Liver function tests should be done. That includes serum bilirubin, SGOT, SGPT, and then we should do also very important enzyme, that is LDH, has a very significant role in prediction of the severity. Then among the renal investigations, creatinine has the highest significance. Of course, the uric acid also plays a role. And then coagulation profile, that includes fibrinogen levels, then your prothrombin time and APTT. So even these three investigations are important. When we're talking about the HELP, or suspecting HELP, then there are a few more investigations which initially we must have investigations that suggest that there is hemolysis. For diagnosing hemolysis, peripheral smear is important. We may find cystocytes, we may find Burr cells, and then as there is hemolysis, there could be anemia disproportionate to the blood loss. There could be bilirubin levels, higher bilirubin levels more than 2 milligrams, and other tests like low platelet less than 1 lakh and elevated liver enzymes. So this is a full battery of investigation, but they should not be delayed and immediately they should be advised.
Yes, we have to, the one message that sir has given is that we should not delay. And another important thing is whenever patients come to you, get in the habit of asking her, what are you suffering from? Are you feeling well today? Are you having any pain? Because sometimes we say she has gastritis, she is malingering, she is not feeling well. Not like that. She may be having liver pain, she can be having gastritis, which is actually something to do with her hepatic things. Now, one of the important things about doing this test is also trying to differentiate issues. So how do you try to look at these differentials?
Yeah, there are three main differential. One of them is acute fatty liver, which is projected, and then thrombotic thrombocytopenic purpura, thrombotic thrombocytopenic purpura, and then hemolytic uremic syndrome. So there are certain differences, we can find out from this table that certain parameters are predominantly seen in a particular disorder, and accordingly we can find out what is what, and we can differentiate between these three.
So I think it is a good practice to have these parameters always at display.
Can I do one
Yes,
thing?
yes, of course.
See, HELP syndrome, the clinical signs are very important, especially the pain in the upper abdomen, vomiting, headache. If you consider this thing, the other investigations may confirm your diagnosis, but if the three symptoms are there with you, then probably the patient is of help and you go accordingly.
So the message that we want to give is to avoid those near miss cases. Your trigger to investigations has to be fast. Don't consider both महंगा है, कब मिलेगा. It's important that you do the test so that you're everything. So Dr. Deepak, cardiomyopathy and early onset preeclampsia. What is the connection? And this patient had cardiomyopathy after 1 week after that mishap that she had.
First, why did she get pregnant?
That you can't say.
See, any preeclampsia, the volume of the blood, in the pregnancy always is going to increase. So
I would request you to hold your mics correctly because we are also having so many people.
Okay.
Online.
All right. See, the volume increase of the blood will, as such, burden to the heart. So that myopathy is there. But especially with preeclampsia, the rise is more, obesity, the more, and the preeclampsia it says is almost 4 times more of cardiomyopathy, myopathy risk. But the question is, do we go for echoes everywhere? What do we really do? And this happened after 1 week. It can happen in even a normal patient. I wouldn't say preeclampsia. This happened is a routine thing also, except that she had obesity, preeclampsia, anemia. This all led to a cardiomyopathy because the heart had to pump more. This was one thing.
I want to ask you a question. You have been in practice for nearly 40 years?
Yes.
Yeah, must be more than that.
40.
Yeah. So what have you seen as a trend changing, with this cardiomyopathy thing? I think practice was much easier maybe 20 years back.
Frankly, we never thought of cardiomyopathy.
Yeah, because we used to always think young pregnant women will never have anything. Kuch bhi ho jaye, unko kuch nahi hoga.
And probably they all survived also. You see, this cardiomyopathy are being diagnosed because of the echo. Otherwise, I'm sure lots of our patients.
But they may die, no?
I'm sure. So when there's, say, the mortality of, you consider the mortality of preeclampsia, probably whether you consider cardiomyopathy or other cause, we really don't know at that time.
Yeah.
But preeclampsia and convulsions and not really makes help has made lots and lots and lots of difference in treatment of eclampsia. Otherwise,
so driving the point across is preeclampsia is not only a disease which will cause eclampsia or damage the liver. It is a multisystemic disorder.
Especially,
it can also cause damage to the heart. And therefore, we have to be aware. Dr. Sampath Kumari wants to say
sometimes it's very difficult to make residents understand that with a normal blood pressure, she is preeclampsia.
Absolutely.
You see, that is the biggest thing.
No, normally for what I tell in our places we are doing, at least for patients whom we think that BP is increased and whether it is gestational or chronic, in that cases, it is better to go for an echo for these patients because most of the time, as we know, the heart disease is diagnosed only during pregnancy. So in these cases, if we go, we can avoid this near miss.
So now we have to move from not only preeclampsia, heart disease, but we have to also consider chronic hypertension, diabetic mothers, screen them for cardiac issues, and that's going to be important. Sir wants to say something.
As sir was mentioning, for 1 decade or 15 years there, cardiomyopathy was very less. I think rarely seen entirety. In last 1 decade, particularly in our region, I had worked in Ahmedabad, Saurashtra and this part, but in Charoto region, particularly where I am working in part, cardiomyopathy is like increasing a lot, not only silent after the postpartum period, this peripartum, it is being increased, particularly preeclampsia with high cardiac output, means the pulse rate is high and BP is also high. Those patients where cardiac output is high, we had seen rising prevalence. I think every month we are getting at least 2 cardiomyopathy. So now we are putting a SOP so that look at with your USG probe only, look at the IVC, look at the just overall idea as a screening. We may not be expert to do that as a part, but look at that part with the emergency physician or something. We are getting at least 2 per month.
Cardiomyopathy may be there,
That's
but
not
it is
may
not
be seen.
diagnosed.
Fortunately, it is not that better. So I am a member of maternal death committee review committee of the Navsari district, and I have come across cases of sudden obstetric collapse, and especially in a case of cardiomyopathy, physician cardiologist will be of extreme help. And I have seen some cases who develop thrombosis, thrombotic event after cardiomyopathy.
Right.
And that if we fail to diagnose it, then it can end up in a sudden death.
So you can keep there on the chair itself. Madam, you want to say something? Yeah. So
The
we are having, inputs from all across the country.
That's important.
Yeah, we did a case control study with preeclampsia and with the echocardiography and compared and shown that there is diastolic dysfunction as well as remodeling of heart, and we published this study in Pregnancy Hypertension Journal also. So, and I suggested a baseline echocardiography in all pregnant women with preeclampsia.
Absolutely. So I think even if we embark upon ART or any of these studies, yes, Dr. Bangal.
Yeah, one more just incident I will like to narrate. A patient of severe preeclampsia delivers and then she goes to observation room after shifting from the labor room. And after 2 hours, she suddenly starts sort of a severe respiratory embarrassment and sort of gasping. Resident observes her. She required immediate resuscitation, then shifted to ICU. And there we do echo, and there was severe pericardial effusion, which was compromising, which was not detected earlier because she came, delivered, kept, and then she started after sort of collapsed. And then it was severe pericardial effusion for which we sent it to Sassoon after she stabilized initially, and we didn't have any interventional cardiology. So after that synthesis, she recovered. So that is another thing. So whenever we have severe preeclampsia or eclampsia cases, we must look in addition to other things, whether there is any pericardial effusion.
So we must prepare the patient in totality for the ultimate. So that's why the pre-pregnancy counseling, as Sampath Madam said, is so important. The society should understand it's not only carrying the baby in, it's creating generations. And that's why saving life starts from pre-pregnancy counseling. So rightly said. Yes, sir, please. 1 minute, 1 minute. We want the messages to go down to everyone.
My thesis in my MD post-graduation was echocardiographic evaluation and calculation of left ventricular muscle mass as a single index for differentiating preeclampsia and hypertension done at any time, any gestation. So that means if the patient has come with the first trimester with the hypertension, you can just simply apply this. And if the LV muscle mass is high, then you can label her as a pre-gestation hypertension. Okay. So then, as you have rightly pointed out, when we followed up these patients with severe preeclampsia, they had many of them, like almost 70 to 80% of these patients, they had along with ascites, pericardial effusion, and especially in patients who had a sudden death intrapartum or during the late antenatal period. When these patients were retrospectively analyzed, they had a lot of patients had pericardial effusion, and arrhythmia was the common cause for death. So this was my observation from my thesis.
Thank
you.
Thanks a ton for your input. Look at Madam's duration of practice when she had written this dissertation. I think
Girija Madam, 1 point I want to say. Ramani Madam's husband is cardiologist.
So she was courting him that time.
Okay, we move on now. I think we need to move on. We have very small little amount of time left. Let us see how much we can go ahead. The missed abortion at 10 weeks, as usual, dilatation and evacuation was done. There was an associated anemia. Subsequently, there was anencephaly detected at 19 weeks, as usual, again a termination. And the index pregnancy at 6 week scan, 19 week scan, cervical length was 3 centimeter. Circulus was applied in anticipation. There was increased uterine artery resistance, and periconceptional hemoglobin was 9 gram.
This is important.
Yes. Yeah. The history is always important. And she started having seizures. And ultimately, the prescription was diazepam and was transferred to the next level of care. So, to the Pankaj sir. And not an uncommon presentation in our country.
So the question to you is she came to you at 6 weeks for confirmation in the third pregnancy. I'll go back to the history. So in the third pregnancy, you can see the events that happened. There was a scan at 6 weeks. When means she came to you.
So
and then immediately at 19 weeks and looking at the previous history of 2 abortions, a cervical encerclage was done despite the cervical length being 3 centimeters. So what would you have done at that 3 if she would have come to you here at 6 weeks to avoid this seizures and everything which she represented at 27 weeks? So this was a near miss situation which we could have avoided.
So first of all, I would like to go for anemia profile and ultrasonography surveillance time bound at 8 to 9 weeks. And second is at around 12 to 13 weeks for early anti-scanning. And again at 19 weeks. We have to advise a patient having a past history of anencephaly. So nutrition advice like folic acid and fruits we have to suggest the patients. And preventive measures we have to go for LDA and LMWH and early anatomy scanning of fetus.
Yeah. So anencephaly, yeah.
This particular case had a very interesting history. Missed abortion at 10 weeks. At that time, you got to think about EPLA and whether you would like to go for the investigation is a different thing. But uterine artery Doppler, as we have discussed, was important. Probably I would have started aspirin even at 6 weeks at this patient. Probably. Because I had a missed abortion at 10 weeks. LMWH, probably after investigations of EPLA, but aspirin certainly I would have started at 6 weeks.
Diabetes and anencephaly, so that has to be
so
done
the
as a
moment you
OGC.
absolutely. So if you have a patient who is giving such kind of a history of anencephaly, it should not be only folic acid deficiency or anti-epileptic medicine. As madam said, it can be diabetes. Look at that. It can also be hyperhomocystinemia. Because now when the history is coming to 27 weeks in this pregnancy, we finally think that she may be having hyperhomocystinemia induced by folic acid and B12 deficiency. So these small things require attention rather than going and tightening that cervix. That is the reason why I brought this case, because 2 abortions, go and do cervical encerclage. But that anencephaly, and they were at 2 different gestational ages, there is nothing related to each other, and the focus is completely lost. We have missed the focus of probable it being a case of future preeclampsia or early onset preeclampsia, and this patient was brought in. So now, madam, we spoke about this cerclage, raised uterine artery and all these things, and I think the raised uterine artery at 19 weeks would also mandate you to start a low molecular weight heparin, and at least if nothing else, keep a close surveillance on this patient. So she was given diazepam. Anybody wants to comment, Dr. Bangal or Dr. Sampath Kumari?
Yeah, diazepam used to be given in the past, maybe 20 years back. But since 1990, since magnesium sulfate is readily available, even at the lowest possible level of facility, magnesium sulfate has been the drug of choice. And we say that whenever there is convulsion during pregnancy, think of eclampsia first, and then other things, unless there is a history of epilepsy in the childhood or maybe earlier. So magnesium sulfate should have been the ideal drug for treating such a case. And the doses are already been told that maybe initial dose, bolus dose followed by a maintenance dose bolus dose, if IV is accessible, then we can give 1 gram per hour.
So
bolus dose
basically,
could be
many
4 to
people,
6 grams.
there are two things, sir, which you want us to clarify. Okay,
Yeah.
one thing is that when there is a convulsion, people feel immediately, let's give diazepam. While we have been teaching as teachers that magnesium sulfate itself aborts a convulsion. And on the other aspect, when there is severe preeclampsia, there's a lot of hesitancy of giving magnesium sulfate prophylactic because people don't know what the dose, there can be complication, I don't have magnesium sulfate. So can you just give this clarity and very clear messages? Because this is required to be understood, because we find many times you are running a referral center. I don't know what is your experience, but even in a place like Pune city, we do have patients coming without being given magnesium sulfate. And this is a real-time case. This is not at all a fabricated case, an experience which I wanted to share.
Yeah, the situation is changing. 10 years back, 15 years back, similar thing used to happen in my area also. Patient were either not received anything, any anticonvulsant, or maybe received magnesium diazepam. But since last 10 years, with better and improved education sessions for these medical officers in the primary health centers or maybe rural hospitals, and availability of magnesium sulfate even at the lower level facility, the things are changing. And now we are getting cases with magnesium sulfate, at least 1 dose, if not intravenous, at least intramuscular. But unfortunate thing is, even gynecologists are referring these cases without magnesium sulfate. Right. We can say that it's okay with the medical officers of the government hospital, but gynecologists directly sending, not even putting the basic IV line and not even giving the referral sheet. So that is very, very unfortunate, and that is increasing the morbidity and mortality. But things are changing.
Scared, sir. We are scared. So tell us how to give that 4 gram IV bolus. We are very scared of
4
giving
grams.
magnesium.
There is a standard ampule. We all know that it's a 2 ml ampule, which is 50%, having 1 gram in that. So initial dose, even if we say, if you don't want to give 6, but as per the Pritchard also, we give 4 ml, 4 grams of magnesium sulfate. That we'll have to break each ml, each ampule has 1 gram. So we have to break 4 ampules, and that 8 ml needs to be dilated with another 12 ml of normal saline or distilled water. And then we make 20 ml. This 20 ml to be pushed slowly intravenously with maybe within 3 to 4 minutes. If that we don't want to give, we are still scared. So put those 4 ampules or 5 grams into the 100 ml of NS and give over 20 to 30 minutes. So these are bolus doses. Otherwise, at least 5 or 10 grams, 50% can be given intramuscularly and shift patient to a higher referral center. So this is minimum.
So very simple thing, sir has told us, a modification of, it's not essential to give it over 20 minutes and 10 minutes and get tired. 3 to 4 minutes suffices, or you can put it through 100 ml and that is enough. Yes, Dr. Sampath.
Yes, as doctor was telling that nowadays in the primary health centers, even the BHNs are trained to do this prophylactic dose. Most of the time, if the patient is coming from the primary health center, means this loading dose would have been given. As for all patients, as he told that gynecologists in every hospital, they should keep ready the eclampsia tray, at least a 20 ml syringe, 10 ml syringe too, and 20 ampules of magnesium sulfate. Once I have seen one patient in the city itself, once a patient is throwing fits, they don't have the magnesium sulfate to give. Immediately she was shifted to the government hospital. So this magnesium sulfate, everything, it should be available in the casualty, and it should be available in the theater, and it should be available in the labor ward. Everywhere there should be a poster of magnesium sulfate, how to give 4 gram IV and 10 gram IM. 4 gram, as he told, 1 ampule, 1 gram, 2 ml. So 8 ml with 12 ml normal saline, 20 ml syringe within 5 minutes. Then each 10 ml syringe, each buttocks 5 grams. That has to be given. If you are giving 1 IV or 1 IM, we cannot reduce the eclampsia. So this prophylactic dose for it nowadays, even if it call it as prophylactic dose, it is 4 gram and 10 gram. That should be given.
I think this poster should go into every gynecologist across the country.
Every
gynecologist. That's the most important.
So we are training the medical officers, we are training everybody, but what about our fellow members? So we have to have this, reiterating again and again, and the confidence being built up that magnesium sulfate has.
It's the point, this NABH accreditation, it has to be
Exactly. That is the biggest barrier. That is the biggest barrier. Exactly.
Absolutely.
No need, sir.
Blindly and confidently, without any stress. Absolutely.
And if you really want to measure, someone says we need to, I can vouch that every Indian has a magnesium deficiency.
So Dr. Sampath Kumari madam said, be ready always. And there's a list of things here. We can also give this magnesium sulfate little more sophisticated way. If you have through the infusion pump or syringe pump, we had a wonderful workshop yesterday. And the WHO 2011, since 2011, they're constantly talking of giving preventive magnesium sulfate. We are giving it at the time of convulsion, but before even at the prevention is essential. Now, this particular patient at 27 weeks had history of feeling uneasy for the prior 4 days, preceded with pedal edema of 10 days, visited hospital twice. You know, she visited hospital, she did come to you. And her labs now, when she was sent to us, to our hospital, we immediately run her labs and they are showing CBC of 8 grams, cystocytes, LDH 2,500, liver enzymes more than 200, uric acid 12, creatinine 1, and expected birth weight of 770 grams, uteroplacental insufficiency, and schistocytes. Now, Dr. Deepak Bagde, sir, this is a psychosocial philosophical question for you. She did come twice to the facility before the seizures occurred. Can you guide us here? That is one. And early warning signs, edema, uneasiness, health symptoms, etc. That is question number 1. And another question for you is, this patient, the doctor who referred was a friend, and she said, Girija, wo pehle na Caesar kar de. Both important is that you please do Caesar because you have a wonderful NICU facility. So ye karo. So first to the academic question and then to
the social one.
Yeah, the social one.
Whether it's social or medical, we'll discuss.
Yeah.
Okay, the first, I think, a patient coming to you in 4 days twice, there's a warning sign. No patient is free of. Let us put that thing into, don't consider any investigation or any history as a trivial, especially when she's coming twice. Edema fit. Okay, edema fit we don't consider as a part of preeclampsia, but say edema fit is a sign you got to consider. I'm sure she would be having vomiting, headache, or pain in abdomen. This patient would be having that.
She was, yeah.
I'm sure it has to be. If she is so severe that she goes into fits in 4 days, she has to have these premonitory signs of pain in abdomen, vomiting, headache. If this history had been taken, I'm sure we would have caught up this patient and treated her very well before she really went into the convulsions. Okay, coming about my friend's request, or was there anything else also? Yeah.
So we discussed this, that we will make them aware and everything.
Yeah, that's fine.
Yeah.
So, okay, coming to, as you said, social part. So I would say one thing, what is the treatment of a preeclampsia or HELLP syndrome? Delivery of the baby as soon as possible. So I'm doing both. Medically, I'm treating the patient. Socially, I'm helping my friend to deliver the baby. And 770 grams in a good NICU is a good enough weight. Of course, if I have 24 hours, I would certainly like to give steroids before I deliver her. And magnesium sulfate for a neuroprotection, as well as she's severely preeclampsia, is going to help in both. So magnesium sulfate, steroids, deliver as soon as possible, and deliver by cesarean section also. I wouldn't really go for a normal delivery. I don't want to really waste another 24 hours so that she goes into more fits.
Okay. So that's.
I will do one thing.
Well, let me finish with what Deepak sir said, that yes, we will pay more importance to the fact that we can salvage both the mother and the baby and the friend and ourselves. And low limit of viability C-sections are seeing babies surviving. However, 27 weeks with the rest of the things, we are coming to that. Sampath, you can say now what you were wanting to say.
I want to give counseling to my friend.
Oh.
Don't repeat this.
Yes. So Dr. Bangal, I'm sure you're dealing with so many such cases. LDH is 2,500. Creatinine is 1. Dr. Bagde is saying do C-section. What would be you doing? And I'll tell you later what I did.
No, these levels of LDH are extremely high, and we all know that it's an intracellular enzyme that detects or depicts the cell death, whether it's a renal or hepatic or any other site. So these are very, very high levels. even number wise, if it is more than 1.6 times or 2 times the normal, that should be considered very high and suggestive of severe preeclampsia. Here it is maybe 5-6 times higher, 5-6 times higher than the normal. So it's a severe form of HELP syndrome, and immediate termination of pregnancy would be indicated without any further delay.
Okay. So then what should we do? C-section, Dr. Bagde said.
Yeah.
What would you tell?
Yeah, considering the gestational age and where we are working and what all backup facilities we have, that includes the neonatal care as well as blood bank facilities. So depending on that, I will like to see the cervix, favorability of the cervix, and at my place with this 770 or 750, I will like to go for vaginal delivery rather than C-section.
I absolutely agree to you. And even in my case, where we have the Asia's best NICU and best, obstetrician like me and the best best CCU, we still did a vaginal delivery. And I told my friend gently, don't worry, I'll save your skin, but here, let's not make this very young woman morbid. That baby in the NICU should not be able to afford. So why unnecessarily? And then we just, gave her, since she was remote from term, we just gave her 100 micrograms of misoprostol sublingually, and she wonderfully progressed and delivered without any mishap, and she required only admission in HDU. So we have to be a little on guard, and we have to remember that these patients are much at risk of so many other complications. She can be at the risk of acute kidney injury. As you said, the creatinine is 1. Yes, sir.
Okay, I mean, yes, you are a great gynecologist, but not better than me. Because I'll tell you, why do you want to take a risk with the mother?
Yeah.
And the second thing is, a baby less than 1 kilo is better delivered by cesarean section than a vaginal if you want a better prognosis.
Okay.
Is that
for
agree?
the mother? Yeah. Bangal, sir. Yes, we want debates.
So
yes.
what I'm saying that we are working in different types of setups for the same, because this is a big dilemma while we take the decision. Baby survival is also very, very important. At the same time, we are talking about the mother. So, for example, in my setup, 1,000, 1,100, maybe once in a while the babies are survived. But when I try to find out the mortality, mainly the neonatal mortality after particular gestational age, 32 or 33 weeks and 1,300 grams was the limit. Beyond that, before that, the perinatal, this morbidity or neonatal mortality was very high. So we have to decide in our setup where we are working, what is the neonatal backup, and accordingly we have to decide.
Absolutely. So we have to take a decision, and I am not a great gynecologist. I happen to be a good obstetrician because I have the backup. I have backup, and I've been trained like people like you through your experiences, and therefore I am where I am today. Thank you so much. Now, we were going to discuss with a few other issues, but I think the time has been sort of shortened. So we will ask Dr. Sampath Kumari, Madam, to do our concluding remarks, that if you want to avoid such kind of near-miss situations, what should be your best approach to the antenatal care? Please speak only exactly in 1 minute.
So since this is with the hypertension, I used to tell normally even my PGs and everyone, whenever you suspect a patient as a hypertension, BP of more than 140/90, every time when you meet the patient, even they don't tell, ask about the headache, history of blurring of vision, upper epigastric pain and urinary output. One of this definitely will be present before going for an eclampsia. So history elicitation is very, very important. And we should be prepared for everything. Once BP increase means there may be pre-eclampsia, eclampsia and everything. Thank you.
Okay.
She spoke only in 60 seconds. Okay. Yes, sir. We cannot say no to the audience participants.
Hello, not at least to me. As all said and done, as we see that we are giving extremely importance to the prevention of the anemia in the country. The time has come that we have to make aware not only the public but the obstetricians the importance of the counseling before the pregnancy occurs, because there are many points which are important. If they are not there, the pregnancy goes very smoothly. So I request the FOXI office bearers and presidents to make some very good protocols about the pre-pregnancy counseling, make it aware to the public that these are the things, and actually the public or the patients comes to our OPD once the two lines become prominent. But they should come before that, 2 months before, have the investigations completely, and then we should allow that you go for pregnancy. That can prevent many of the complications.
Yeah, I think it's an onus on every member of the federation as well to spend little time for counseling. Pre-pregnancy counseling remains the bottom line for all the mishaps or the near misses that we are going to tackle. So let us commit ourselves today that we will do that henceforth. But having said so, I think simple scores like Gestosis score, so nicely designed by our own colleagues, has a high impact in prevention of all these particular important points. So bringing this score, making it more popular and bringing into your day-to-day practice also matters a lot if we consider women a very important part of your profession. And I'm sure with all our commitment today, we will take a pledge that we will do that counseling, bringing in the scores and do all positive maneuvers so that we will try to do our best so that we can bring down the maternal mortality to even below 70 by 20330. Thank you.
Thank you.
Thank
And
you
I
so
want
much.
a round of applause to all the panelists here.
No, I think this has been an excellent one because the participation on the floor was so apt.
And the floor participation.
Yes, exactly.
Please come
Thank you.
we'll
Thank
take
you
a
so much.
picture.
And thank you, Mr. Girija.
Thank you, Girija ma'am and Arun Barua sir and all the learned panelists for this much needed discussion. And now for the next session, which is a panel discussion on acute abdomen in pregnancy. I would like to invite our respected moderator, Dr. Atul Ganatra sir and Dr. Sujata Mishra ma'am. I welcome you, sir. Please take the seat, come on the dais. No, sir, you can hear. And I think Sujata Mishra ma'am is not here. Let me introduce you, sir.
Don't worry.
Okay. So, now I would like to invite the panelists for the session. Dr. Jagdish Gohil, Dr. Jignesh Shah, Dr. Manoj Chelani sir, Dr. Mukesh Savalia sir, Dr. Nitin Raithata, Dr. Poonam Goel ma'am, and Dr. T. Radha ma'am.
Can I have this for 5 minutes?
Yes. Yes.
I want to find out who all are there.
Four are there. Jagdish Gohil sir and Jignesh Shah sir. Four are there, sir. Jagdish sir is not there. I think Jignesh Shah is not there. Manoj Chelani sir, I can't see him. But Mukesh Savalia, Nitin Raithata, Poonam Goel ma'am, and T. Radha.
Who may I have busy also? I'll also come and sit there. We can have a discussion.
Sir, shall I introduce?
Yeah, please.
Start, sir?
Sir, open the. I will.
Yeah.
Why is it
And
not like this?
let me take this opportunity to introduce our esteemed moderator, Dr. Atul Ganatra sir. We all know him. He doesn't need any introduction, but for the formality, sir is a director, Ganatra Nursing Home and Progeny IVF Center. And sir is Vice President 2020-2021, Joint Secretary IAG. Sir is Chairperson MTP, sir was Chairperson MTP Committee FOXY during 2012 and 2014. And sir is Member Managing Committee MOGS, Medical Advisory Committee FPAI, and Technical Advisory Committee IPAS. I welcome you, sir.
Who is the fourth person?
Sir is Narendra Kajjar, perhaps, but now he is not given. Sir is
Yes. Okay.
So thank you very much, Alpesh bhai, and the entire team of this critical care conference. I don't know why. I think looking at the panelists, two of my fellow moderators have decided not to come. I think they are all scared of you all. I think, but I had to come back because of Alpesh bhai. Now, I work in a tertiary hospital, and as a result of which we do see a lot of critical cases. We will be discussing some simple cases, and Dr. Radha was very worried about what cases we are going to ask you, but these are all practical points that we want to discuss. There is no theory involved in this. This is one of the quotes which I use very often. We don't grow when things are easy. We grow when we face challenges. I think challenges is something that do come to us in pregnancy. Normally, there is a very loose terminology used in many hospitals that I work in. They say gynecologists are below the belt surgeons, but that's not true. We do see a lot of complicated cases, and now in the last couple of years, we've shown them how much critical care work we do. So there has been a change in the kind of conditions. We are going to limit ourselves to patients presenting to us with an acute abdomen in pregnancy. So we know that it could be appendicitis, it could be ulcer, it could be gastroenteritis, it could be hepatitis, bowel obstruction, perforation, herniation. And COVID has taught us so many things. I think I'm going to show you one or two cases. Ovarian cyst rupture, torsion, ureteric calculus. I have a video of almost all these cases, but I'm going to limit to some simple cases. Now look at this one case. I don't want to discuss this. This is a patient I had delivered post-COVID. And about 4 weeks post-COVID, she came to us with acute abdomen, and then they thought that there was something wrong with her pregnancy. And she had superior mesenteric artery thrombosis, and look at her omentum, completely infarcted. I think these are some newer things that COVID is teaching us. So these are some situations that we come to see. Thrombosis is one thing that has happened at various levels, in various parts of the body in COVID. I mean, in fact, there was a patient of mine I've operated, and the next day after surgery, she developed a stroke. I had done a lap hysterectomy on that patient, and she had COVID about 3 months prior to that. So just simple questions now. First thing is, are we allowed to do an X-ray in pregnancy? Is the first question that I want to know, so we can step up. Are we allowed to do an X-ray in pregnancy? What is the risk? Very often a patient comes to us and says that she got an X-ray done, and then 2 weeks later her UPT comes positive.
A very rightly worried question, and many people are suggesting MTP, and I would like to say don't worry as a part. The reason we have to understand the safe limit. The safe limit is 50 milligyri or 5 rads, what we can say. Up till there is a very negligible limit. That is number one. Number two, more than 15 rads or 150 milligyri. If you are going beyond that, then the carcinogenesis or risk to teratogenicity will increase as a part. So one X-ray means hardly 0.05 gyri or less than 1 milligyri, what we can say.
Absolutely.
So single X-ray doesn't bring harm. Number two, shielding may not prevent all radiation. There is a background radiation may be there as a part, but it gives a confidence to the patient that if you are not exposing the uterus and shielding, that it gives some confidence to them. But we have to reassure.
So
and one more thing, keep in
simple
mind,
plain X-ray is equal to 0.05 gray. That's the terminology that is used, and that has absolutely no risk to the fetus. There is no reason to terminate a pregnancy. However, if a patient comes to us and says that I need 100% guarantee कि मेरे बच्चे को कुछ नहीं होगा, I think that is one thing that we cannot do if she's not got an X-ray done as well. So I think this is one slide that we must keep with us. That is the terminology. Unfortunately, is being hidden by the video there. The terminology used is gray. So now the second slide that we must all have is this slide. Chest radiography, very, very low. Abdominal radiography, 0.1 to 0.3. IVP done. A cervical spine, a lumbar spine. I think this is a slide that all of us must have in our document folder in WhatsApp. If you see the current conference WhatsApps, we can see people landing in a flight. I'm on the road, I'm on the way. I have reached here. I think I have made a folder of documents in my WhatsApp in which I keep interesting HSGs, interesting pictures matter like this. And if a patient asks me, I'm going to WhatsApp or email it to her. I email it to her because if I WhatsApp it to her, she will get my email, my mobile number. So these are some, this is a suggestion. Please keep these like a Myrina folder, copper T, OCPL rules, what we have to follow. These are simple things that we keep so we can immediately transfer it digitally to our patients. Extremity radiography, double contrast anemia, head neck, CT scan. CT scan with contrast has more than 200 gray, not accepted in pregnancy. It is an indication to terminate a pregnancy. Patient has come in an emergency with severe pain abdomen. The first thing they do, surgeons particularly, is they will do a CT scan. They will not do an ultrasound. I have had at least 5 patients in the last 5-6 years who've had a CT scan done in the second half of cycle. That is in the luteal phase of the cycle. They underwent an IVP. So that is something that is not acceptable. So mammography, IVP, if possible, should be done post-menstrual. Of course, if it's an emergency, you take proper consent, then you can go ahead and do it. Can we do an MRI in pregnancy?
Yes, MRI can be done very well.
So that is very important. So this is one slide. Sorry?
One thing is,
yeah, I'm just going to come to that.
Fast sequencing can avoid 3 Tesla, preferably 1.5 Tesla is better.
So MRI can definitely be done, but no contrast. That is very, very important. So here, this slide also is very important in the X-ray group. So what we want to say is exposure of more than 200 M gray can cause growth retardation. The most important period is between 8 to 12 weeks. That is something that we need to be very careful about. And absorbed fetal dose for a single abdominal and CT scan is definitely not acceptable. Now we go on to MRI. So FDA does not approve contrast in pregnancy. So that is why a plain MRI can be done. Indications, the most common indication to do an MRI in pregnancy would be an obstruction or a placenta accreta, but that is usually done at a much later age. I've had a patient who at 14 weeks had an intestinal obstruction and perforation. And we were worried. We did not do her investigations. We were just trying to manage by ultrasound, but we could not come to a diagnosis. Ultimately, we did an MRI on the patient. Exactly. So appendicitis is something going to be clinical. I think we definitely don't want to do an MRI for appendicitis because without a contrast, we may not be able to pick up much. You will be only be able to pick up a thickened appendix. So let's go on to the first case. Mrs. P, 29 years old, a known case of endometriosis. Laparoscopy I had done. She was grade 4 endometriosis, conceived after IVF, 28 weeks pregnant, came to us with severe pain abdomen on day 1. Pulse 96, BP 110/70, everything else, but she had tenderness in the right iliac fossa. And to my bad luck, her first cousin was a radiologist who owned a CT scan center. So the patient was brought to me after having had an ultrasound and an MRI, and the diagnosis was thrown upon to me. Okay, this is appendicitis. She needs surgery. By 28 weeks, the uterus is almost above the umbilicus, and we did not know. But since the MRI was brought to us by her own cousin, we said, okay, chalo, if you say so, we will try and give her antibiotics. But the patient was actually reeling in pain. It was almost like lying down like this. Patient has had a history of endometriosis. What would be our differential diagnosis? Dr. Dada, would you like to answer that? Right iliac fossa pain, differential diagnosis.
Okay. If it is a obstetric cause, I would still think it's a ovarian cause. But endometriosis usually they don't undergo torsion, but there might be some hemorrhage into the cyst.
Exactly.
Yeah. And if it is non-obstetric cause, it might be appendicitis because it's a right iliac fossa. The major non-obstetric cause would be right appendicitis.
What about a renal calculus?
Yeah, nephrolithiasis also can be there. Renal calculus can be there.
But okay, Bolan sir, come.
In addition to appendicitis, we might think of other surgical conditions. Say, for example, this patient might have something with the cecum, COX, and she might come with the obstruction also.
That is one. Diverticulitis, even regional ileitis. Ovarian pathology already Madam has said. There might be undiagnosed even a fibroid in the broad ligament, which might cause.
Sir,
such
MRI
type
done
of thing.
already. The radiologist says वो सब कुछ नहीं है, appendix है, आप operate करो.
Okay. Of course, we have to operate with patient condition, looking to the clinical condition also. And the major problem which I have faced, I have operated almost 10 cases of appendicitis in pregnancy, and out of 3 had fecal matter in the peritoneal cavity. So don't delay till appendix ruptures. And that is the commonest mistake made by a gynecologist, that we forget to diagnose something other than our branch. And by the time, these signs are already masked, because tenderness is different. The things patient get worsened immediately. We do not know, because the clinical picture of acute abdomen doesn't come so suddenly because of the uterus which is overlying there anteriorly. So we have to be careful and guarded, and we have to monitor this patient properly.
Sir, how long will you wait? And what painkillers would be your first painkillers of choice before you take the decision? And what investigations, apart from a CBC, would you want to do before you take a decision on surgery?
Yeah, just another 2 part is already MRI is done, so we are ruling out the gallbladder and the
Ultrasound done,
pancreas.
MRI done.
So that is we are ruling out pancreas and gallbladder. Otherwise, we have to also rule out that part, because patient is relieving with the forward bending, as you said. So
yes, she's kind of sitting like this.
So that is a sign of pancreatitis. That is one.
But the pain is here, sir. Pain
Most
is not
like,
here.
that, that is a difference.
Okay.
So we have to investigate for the basic liver enzyme, CBC, sugar, create that basic
all
safety
that done
profile.
normal. WBC count is just about 11 or 12,000. So when will we take a surgical opinion? Are we going to immediately call a surgeon and take an opinion? What are we going to do?
Give a shot of antibiotic. That is important to start with.
What is your choice of antibiotic?
Cefuroxime.
1.5?
1.5.
Okay.
Or you can loading can be given 3 grams and then followed by 1.5.
Okay.
And follow with tramadol as a supportive analgesic just to relieve it. But we have to think of surgical opinion very fast.
Sure. So once the surgeon has come into the picture and surgeon says, मुझे तो खोलना है, मैं खोल के करूंगा. Sir, would you agree with the surgeon if he says, I'm going to do an open surgery?
Nowadays, with the changing scenarios and the more and more evidences are coming up in the literature as a part, the laparoscopies are equally safe. But 28 weeks is so late second trimester. Yes, excess is doubtful. Then you can, you said endometriosis was there. So maybe possibility of adhesion. There is a debate can be there as a part, but laparoscopy is equally safe with the 8 to 12 mm veg pressure maintained and as a part.
So your choice, laparoscopy or laparotomy? Because
that
there is
depends on the skill of surgeon.
Okay.
What surgeon, what skill he has. Because if he has not that much skill, then open surgery is quite good.
No, what the surgeon has said, मुझे खोलना है, I'm going to open. Are you going to say, let us put in a laparoscope and see?
If surgeon is confident in laparoscopy.
No, surgeon is not confident. Surgeon is saying exploratory laparotomy. So would you want to do a laparoscopy or will you agree with the surgeon and say, chalo khol dete?
We'll go with the surgeon and we'll open.
Dr. Raj, what would you?
Yeah, I would open at 28 weeks. I would like to open.
Okay, so I did not agree with the surgeon. This happened to me at my nursing home. This is my own patient. And I put in a laparoscope.
That's why, as he said, it depends on the skill of the surgeon. So
No, because-
if you are confident, there is no.
No, the problem is
trial
that there was no diagnosis. And to do a laparotomy on in a 28-week size patient, uterus size, when we don't have a diagnosis, the patient is complaining of right iliac fossa pain. The ultrasound and the MRI did show some vague fluid. So we put in the laparoscope and all we saw was blood inside.
There is a spontaneous intra-abdominal hemorrhage,
As a
especially
result
with the
of
previous history of
endometriosis.
endometriosis.
So he looked at the appendix. After I put in the scope, he looked at the appendix. He says there is nothing wrong with the appendix. The patient had pain because of hemoperitoneum. So all we did was we gave her a lavage. We removed all the clots very, very carefully and we came out after putting a drain inside. So I think this is one situation which was so difficult for us. Cousin is a radiologist. Surgeon is telling the cousin, the doctor who's a relative, okay, laparotomy karna chahiye. But I mean, thank God,
But
we did not do a
pre-operative
laparotomy.
evaluation, did we miss anemia and that part of hemorrhage?
No, there was nothing clear about it. But fortunately, because we put in the scope, she escaped a laparotomy. Otherwise, this would have been a vertical incision almost from pubic symphysis to at least above the umbilicus to make a diagnosis. And I think closure of that 28 weeks uterus could have been, because obviously you cannot handle it much. Uterus you cannot handle at 28 weeks.
One more problem with laparotomy, which I have practically faced. In a case of acute abdomen with 28 weeks pregnancy, and when laparotomy was done, like the incision which you said, that patient developed burst abdomen.
Exactly.
Because uterus was expanding even after your closing abdomen. And that expansion you cannot prevent from 28 weeks, 32 weeks. Ultimately, we had to close it again. Ultimately, by the time that patient is operated twice for cesarean section previously with vertical incisions. So we have to be careful about all these things also.
So you can put an optical trocar, you can tell your anesthetist, put an RT, put an optical trocar and go right up to the umbilicus, maybe about 3 or 4 finger above the umbilicus. I have done a laparoscopic ovarian cystectomy in a 32 week size uterus as well. I'm not saying that all of us should do it, but I feel bad that I would do a negative laparotomy in a patient of this size. These are some difficult situations that we come across, and hopefully, we can escape.
I want to know, because the studies say in these such cases, the varicosities of vessels will be there on the posterior surface of the uterus. So would you be able to lift the uterus and see
You
the
can,
control the
if your anesthetist is capable enough and he's able to give you a good head low,
Yes.
you can use some amount of bipolar cautery. But obviously, if there is a vessel bleeding, you may have to open her up, because I don't think you can do extensive cautery, because I have seen 2 patients of perforation also at the level of the endometriosis fulgurated area. So if it's a small ooze, usually it is a small ooze. And in fact, I presented this in a ESG, European Society conference, and that doctor came up to me at the end of it and says, please publish it. People are not publishing. I have seen so many cases. If you see world literature, they are talking about 10, 15, 5, 6 cases of kind of endometriosis being published. And we eventually did publish this case. Let's move on to the second case.
Hemoperitoneutically, we had seen 3 cases of ruptured splenic aneurysm.
Absolutely.
Spontaneous rupture in the second trimester.
So this is another interesting patient, a female 32 years of age, which USG diagnosed 6 to 7 weeks of pregnancy. Severe pain, IVF done 2 months ago. On examination, pulse of 120, BP of 90/60. Tenderness in the in the iliac fossa, USG intrauterine pregnancy, and a right hemorrhagic mass. What is our differential diagnosis? IVF pregnancy, intrauterine pregnancy seen, severe pain abdomen, right hemorrhagic mass.
Heterotopic pregnancy must be checked as a part, because and all ovarian pathology towards it. There's 2 things, cystosis should be ruled out. The use of color Doppler can help in further.
Here, differential diagnosis doesn't make any difference, because after all, you have to put a scope. Whether it is a heterotopic or ovarian cyst or rupture ovarian cyst or rupture, say corpus luteum cyst or whatever it may be.
Would you want for wait for 1 or 2 days to see if it is settling down? Because to diagnose an ectopic, beta HCG is not going to help you, because she's already has an intrauterine pregnancy. Yeah, so the blood pressure is a little on the lower side, but patients can have such low blood pressure in pregnancy.
That shows even if you find an intrauterine pregnancy, you have to check for tubal pregnancy or extrauterine pregnancy also in such cases. So we have to examine an first trimester ultrasound.
Absolutely. So that is what it was. It was a heterotopic pregnancy. I think this is something that we must keep in mind.
Heterotopic pregnancy is more common in IVF conceiver. Normally conceived patient, usually the heterotopic pregnancy is less likely. Because here is a history of IVF pregnancy, IVF conceived pregnancy, so we have back of mind that she might have heterotopic pregnancy. Otherwise, the first diagnosis may be, if normal conceived pregnancy, may be corpus luteum cyst or some other pathology.
What care will we take when we are operating this patient? We cannot do any manipulation. What kind of precaution and what electric current would you use, electrosurgical unit, or to operate this patient?
Mainly bipolar with low part, and pressure should be low pressure so that to avoid as a part. Minimum handling, that is the main crux for the surgery as well.
Would you like to put an endo loop or would you just like to use electrosurgery? I think gynecologists are very comfortable with electrosurgery.
Electrosurgery is sufficient.
Okay, fair enough. So I think that's a good message. No monopolar cautery to be used, just use bipolar cautery, or if you have the facility, you can use a vessel sealing device.
What now? What about the non-surgical management? Would you go for it?
There is no
like
non-surgical
injecting,
management. You cannot use any
potassium
methotrexate in
chloride?
pregnancy. Let's make it loud and clear. There is no role of intrathecal, intrasac. There is no role of methotrexate. It is contraindicated in pregnancy. So this is a third similar situation here. Patient, a primary 2 months amenorrhea, severe pain, abdomen, giddiness, referred from a major BMC hospital. She was 120 kgs. This has happened just last week. On examination, she had a USG, a left ruptured ectopic, moderate hemoperitoneum, HB was 7 grams, lactate was 12. RAT, that is the antigen test for COVID was negative. We did not have time to do RT-PCR on her. Now, her blood pressure was 80/30. And she was 120 kgs. And at 3 a.m. in the morning, just about 10 days back, the anesthetist told me 120 kg hai, I will not let you do laparoscopic surgery in this patient. Sir, what would be your take? Will you open this patient up? Because with 80/30, 120 kgs.
120 kg is not a contraindication to laparoscopy. I don't think that. 120 kg doesn't only think when in an obese case, when you are introducing trocar, you might have to change the angle of the trocar, it will be straight. But I don't think that is
So fair enough. So she argued with me for about 5 or 10 minutes because the patient was admitted under another colleague gynecologist and they were on the verge of opening her up when I was called. But I says, give me 15 minutes. I will finish this ectopic pregnancy in 15 minutes. You must have the right equipment.
She's stable
A
hemodynamic.
larger, sir, BP was 70, 80, 50. Yeah, so basically we need to have larger trocar cannulas, and that is when you will be able to do this surgery. I will not waste time, but I think if you have a good team of anesthetists, this surgery can be done within 15 minutes at a good setup with a kind of backup that is required. So let's jump to the next question. Yeah, now Mrs. A, 32 years of age, primary 34 weeks of pregnancy, again referred to us in the emergency room with severe pain in the left iliac fossa, not settling with injectable painkillers, not settling with injectable fortwin finargan as well. USG in the early pregnancy showed a ovarian cyst which was query dermoid. When she had a 6-week scan, she came to us at 34 weeks, and subsequent USGs did not mention about the ovarian cyst. Sir, what would you do here? Severe pain abdomen at 34 weeks. On digging into the history, a 6-week scan is showing a dermoid cyst, ovarian cyst, query dermoid.
Ureteric stone, ruptured cyst, when it is not showing there.
So she's 34 weeks. What kind of obstetric precaution or preparation will you do before you do any surgical intervention on this patient? Will you give her steroid? Will you give her and wait for about 48 hours? Would you go in immediately?
For any surgical intervention, you must have a definite diagnosis.
Okay, so would you do an MRI or will you just go by the history of that 6-week scan?
No, not by the history of the scan.
So basically, the patient had a history of a query dermoid cyst or a cyst which kind of not a clear cyst, a solid cyst. At 6 weeks of pregnancy, the ultrasound film is showing that very clearly. And the patient is again having severe pain, which is not settling with antibiotics and painkillers, obviously.
So at least something has to be done for the cyst, whether it is there, whether it has undergone torsion. We do not know what is there. Yeah.
34 weeks, madam. What else will you see? We won't see anything much. So yes, an MRI may give you a diagnosis of the presence of that cyst, but I don't think anything else is going to help. But if she does not respond, I think we have to just give her steroids and go in and do a cesarean section and then take a look as to what else can we do. The family has to be prepared that this baby may need an ICU stay because she's 34 weeks of pregnancy. Obviously, she's not settling down with pain. And as luck would have it, she did have a torsion of that same dermoid cyst that was there. So we gave her steroids, but she was not willing to wait for 48 hours. She had severe pain. So we went in, did a cesarean, and along with the cesarean, we did a ovarian cystectomy on this patient. So these are some difficult situations where I think a documented consent needs to be taken. Now I'm fortunate that I work in a corporate hospital where all these critical cases who come to the ER, just next to the emergency, we have a video consent room where we take a video consent with our patients. With the presence of our telephone advances, a mobile phone can be easily used to take a video consent. We see so many viral videos of patients taking our videos. This is a time when we must take a video consent of our patients and the relatives that we are talking to. I mean, you are talking to the relative and somebody else, your colleague, should take a video. Because no matter what you write, we doctors are not very good at taking consents. But we do explain to our patients. Point number one, this could be a negative laparotomy, but there is a history of cyst. Point number two, 34 weeks, if I do a cesarean section on this patient, the baby will go to the NICU. NICU is going to cost. Point number three, I may have to take a vertical incision if I cannot reach the situation. That is, I will do a phalansteal cesarean, and 9 on 10 times I will manage to do an ovarian cystectomy.
And point number 4, I may have to go for oophorectomy.
Absolutely. Very important point.
Yes.
We may have to do an oophorectomy.
Because many times in pregnancy, because of so much vascularity, may not be possible to cystectomy.
But please remember, we may not write all these things very clearly. Please take a video consent and save it in a folder or relatives this, or it can go into the MRD file. We fortunately have a kind of a hard disk on which all these consents are stored. That is very, very important because 2 years down the line, you can still be sued for it. God forbid something happens to the baby.
Of course, patient has to be informed
Of
that
course,
we
you
are
have to be
taking
informed.
this video consent.
See, even if you have a CCTV in your hospital, you are supposed to write there. This hospital is under CCTV surveillance.
It is their basic right to know that they are giving this consent under video record.
If a patient is ransacking your hospital and somebody is taking a video, are they asking you? Nobody is asking you. Absolutely. So I think this is the need of the hour. Use your mobile phones for good purposes like this. Anyway, so this is, I'm thinking I'm going to run short of time. Case number 5, patient has come to my casualty with a diagnosis of a scar ectopic. Severe pain and bleeding. I want all the 4 panelists to tell me how will you manage this patient. This patient has a scar ectopic. She's bleeding and she has pain. What is your modality of treatment? Obviously, she's a G2P1L1. She has 1 cesarean section. That's why she has a cesarean scar.
You have to just reconfirm that part, the differential diagnosis of the aborting low-lying sac. That is one. Second is scar
You can
ectopic.
see on ultrasound, it is in the myometrium.
And third is a cervical ectopic pregnancy.
Okay.
So
What is your management?
Cervical ectopic pregnancy, we have to terminate, but the issue is to prevent the bleeding. So there are 3 or 4 modalities there. That is one, McDonald's suture at the level or ligating at the level of vaginally ligating the uterine artery, and then curettage and the tamponade with the Foley's catheter of 30 ml balloon test tamponade we can give as a part. Second option is giving the tamponade and locally injecting methotrexate as can be done as a part. People are also doing systemic methotrexate and putting the tamponade for the cervical part. For scar ectopic, yes, reconfirm under ultrasound guided with grades 0, 1, 2, 3, or 4. If it is grade 0 or 1, 2, we can go for a curettage under ultrasound guided with the tamponade possible part, or you can use hysteroscopy along with the removing the scar part.
Usually, sir, in scar ectopic, in this patient, laparoscopy will be a best option. Laparoscopically remove that scar ectopic pregnancy and secure the bleeding. Both of the situation, either ectopic, cervical ectopic or scar ectopic. Keep in mind that you might end up with hysterectomy. Keep in mind. Because many times bleeding and situations are so adverse, to save the life of patient, you have to go for the hysterectomy in both these cases.
I have to agree to previous panelists because cervical pregnancy, he has summed up most of the management, and scar ectopic, he has done the management.
So this is one of the ways it can be managed. Here are 3 treatment options given. One of them is hysteroscopy, one of them is laparoscopy, and of course you can do a laparotomy if you wish to. But, sorry, I'll just go back. So fortunately, this patient had a missed abortion. It was not a live scar ectopic. So we managed to do a hysteroscopic resection of that scar, and we could arrest the bleeding pretty clearly. This is one of the modalities. Of course, because it is in the lower segment, distension may not be very easy. You may need a proper endomat to do the distension, but this can be managed hysteroscopically as well. You must remember, I will show you the video, the ultrasound picture again. What is very important to note is how far is the upper level of the ectopic and how much myometrium is there above that. That is very, very important. And you can manage this hysteroscopically. Before Lucknow AICOG, 1 month prior to that, I had 4 cervical and scar ectopics. We managed them, 2 of them hysteroscopically, 2 of them laparoscopically. If you happen to do it laparoscopically, you must ligate the uterine artery. Otherwise, they bleed very heavily. If you ligate the uterine artery laparoscopically and then do the cervical ectopic, it works very, very well. But this is something that can be kept in mind. You can even through the hysteroscope inject a little vasopressin there, and then do a hysteroscopic resection. Of course, the other modalities have been explained, but this is something that can be kept in mind. Methotrexate only if there is fetal heart.
Yeah, it controls bleeding also because
It doesn't in practice, at least in the last 10, which I have managed in the last 1.5 years, I have not succeeded by giving methotrexate. Methotrexate is only used to bring the beta HCG down and create a missed abortion if it's a viable fetus. If it's a viable fetus with fetal heart there, I will do a laparoscopic uterine artery ligation and then open the scar with monopolar cautery and then remove the ectopic. But but the kind of time that you will take for the methotrexate to work and eventually give her the
circulation, whether this scar pregnancy, methotrexate, will it reach there? Will it have its action or not there? In cervical
it depends upon, it can be done, yes, because it can be done for a corneal ectopic. It can be done. I'm not saying it cannot be done, but the time interval involved, if a patient has severe pain, remember the patient's primary complaint is pain. It's not an asymptomatic. If it's asymptomatic, you have time.
Would you like to monitor this with laparoscope at the same time while you are doing this procedure?
Usually not necessary.
Okay.
Usually not necessary, because you can clearly see the sac finishing and you can actually clearly see the completion of the surgery. Your biggest challenge is distension. And there is a special instrument available by Kalelkar in which the instrument comes like this, where because you may have a lot of leakage of fluid because you are in the lower segment, you don't want to work in the endometrial cavity. We apply this particular forceps at the level of the cervix after we put in the resectoscope to get adequate distension. This is an instrument which is almost like a tenaculum or a bulldog clamp, but a bigger version of the bulldog clamp. So you can actually clamp the cervix like this after you have put in the resectoscope. Works very well for distension.
Just one word for the methotrexate. It is not always safe. Severe neutropenia even with one shot can happen. Very rare occurrence, but it will happen to us that the patient has a deficiency of enzyme which metabolize the methotrexate, and patient can succumb to that. Monitoring is most important.
So I'll just kind of sum it up faster. Patient has been diagnosed as appendicitis in pregnancy. She's here, you can see 10 weeks pregnant and severe pain in the right iliac fossa. Medical management, surgical management. That is the debate that we want to have. Whether it's going to be, sir, your choice. Would you do medical management first or would you go in for surgical management? Patient has been diagnosed with acute appendicitis, and how will you counsel the family?
All acute appendicitis do not need surgery. That is very clear. Some of them can be managed. 10 weeks pregnancy will not mask the rupture of the appendix. So that is also, you can manage this patient very well if you are observing this patient with under antibiotic cover and IV fluids, and you can keep her kneel orally. And I think she can be managed looking to the condition.
And how long will you wait? Usually in these patients, the acute appendicitis also, very rarely in today's world, you see 20,000 and 25,000 WBC count. You don't see. So we have only two modalities. You have CBC, CRP, and procalcitonin to monitor, and clinical
Clinical will be better helpful in this case.
Yeah. So basically, appendicitis 5 on 10 times can be managed medically. But very often a patient comes to you and says, I've had recurrent attacks of pain.
Surgeons.
It's a surgeon's decision. Surgeon will always want to operate.
Evidence says that we have to have a low threshold for surgery. We have to opt more in favor of surgery because fetal outcome are evidence more poor with the conservative
Our problem
management.
is the 10 weeks pregnancy.
Another thing, while going for a conservative management, keep in the mind that it may recur later on pregnancy. It may create a problem. So that also should be keep in mind.
So this is a very funny patient that we had. We eventually went and operated her. And you can see a worm coming out of the cut appendix. So this is a clinical situation that you can come across sometimes. She was about 10 weeks pregnant. But you can see that worm coming out. But you have to be very careful that the appendix does not kind of spill in the abdominal cavity. You need to be very, very careful on that. Again, the patient diagnosed as renal stone. I'm going to cut it short so that we have discussion. UV junction stone or lower ureteric stone, medical surgical management.
That depends on the size of stone.
Okay.
Which is the size.
What about the clinical symptoms? She's in severe pain, colicky pain, not responding to medication.
Then
Yeah. The ultrasound picture is there, which is showing frank hydronephrosis.
then you have to intervene.
You can't do an X-ray. You may do an MRI, but the MRI may not help because the patient is already 20 weeks pregnant. Dr. Radha, yes.
If it is to confirm, first thing is ultrasonography. And then even if MRI or low dose CT also, if you want to do, you can do, but usually ultrasound will be enough. And the thing is management, medical management means pain relieving. And if there is infection, you have to put her on antibiotics. And then medical expulsion therapy can be
Hydrotherapy. Do you think hydrotherapy
No, hydration. Oh, depends on the size of the stone. If it is between 5 and 10, we can manage. Less than 5, she may not need any treatment. Between 5 and 10 millimeters, she may need a medical expulsion therapy.
What about just going in and putting in a stent?
That's later. After if the medical expulsion therapy fails, we can go for stenting and.
Yeah, so this particular patient, the urologist decided that he will go in and operate, but there are problems of putting in a stent also. You can sometimes have encrustation of the stent as a result of the stone if the patient has a tendency to form stone. So again, I don't think this is going to be our decision. Our decision is going to be counseling of the family. Again, here, counseling is extremely important. And then you and the urologist have to sit together and discuss the pros and cons. If the patient settles with hydrotherapy, painkillers, dicyclomine, antispasmodics, maybe you can wait, but otherwise, surgical option is probably the only option.
Ideally, patient with a history of stone should be evaluated and stone should be out or managed before pregnancy. That is to be very clear.
But she has come to us only in
now,
pregnancy, so we don't have a choice.
Now the thing is, if the stone is in the pylorus, and acute pyelonephritis can be a very serious condition. So we have to keep this also in mind, and we have to give her higher antibiotics and manage it. Even that patient may require PCNL.
Absolutely.
Percutaneous nephrolithotomy. Or that if the stone is there in the ureter, that stone can be managed through the ureteroscope. The only thing is inserting ureteroscope in a pregnant because of some obstruction at the level of the pelvic brim because of the gravid uterus. That can be a problem in negotiating the scope. But still, if this patient is deteriorating or pain is not relieved, I think surgery has to be done.
I want to make one point. The medical expulsion therapy is usually earlier tried with nifedipine, and now they are giving tamsulosin, which is alpha blocker. But in pregnancy, they are not giving tamsulosin yet because the safety is not proven. This patient, I will definitely refer to my husband, who is a nephrologist.
Lucky you. So basically, there is some role of Lasix, but Lasix is contraindicated in pregnancy. You can use hydrotherapy, but most urologists don't like to give hydrotherapy because they say her frequency of micturition. She has a lot of RBCs in the urine. If you can see the report, she has about 100 to 200 RBCs in the urine also. So basically, it's a traveling stone which is kind of eroding the ureter and causing more problems. I think I will have to just sum it up. This is another case of torsion ovary. Again, torsion in pregnancy. Just one more case. Very difficult situation that I had faced. Mrs. X, 31 years of age, a known case of fibroid with pregnancy, came to us with severe pain in the right hypochondria. She had consulted me once before. She had consulted me once before she was pregnant, because she was advised IVF straight away. That was the hand-drawn picture that I have done. I told her all the fibroids are outside the uterus. I don't think, because a very senior colleague had told her myomectomy and IVF, because she's 31 years of age. She had an AMH of about 2. I said, since the fibroids are outside, I don't think you need to worry about. Give yourself 2 or 3 months. They had not even started trying for pregnancy. Give yourself 2 or 3 months. Let us see if you conceive. Let's do a follicular monitoring. And as luck would have it, she conceived. In between, I was told that she took treatment for right iliac fossa pain. She was being treated by a urologist. The patient happened to be a very big builder's wife. And she was given many painkillers, and she was treated by a urologist for renal calculus. Again, with the presence of fibroids, they could not definitely say that there is a renal stone, but there was some blood in the urine, there was some pus cells in the urine. So she was treated with antibiotics and IV fluids, and also she was treated with painkillers. Now she comes to us with severe pain once again at 35 weeks of pregnancy, 2.4 kg baby weight, multiple fibroids, severe pain in the abdomen. The urologist said that abhi mujhe kuch nahi lag raha hai. Dr. Radha's husband says no role of urologist and nephrologist. Now you manage. Yes,
Just,
sir.
counseling part is important part. MRI should help here some part and rule out the red degeneration of fibroid. That is one. Second is, I don't know about, as you picture showed, is there a possibility of torsion that we have to think of part? And there are rarely one thing, once I have seen as a rupture of feeding vessel of that fibroid creating hemoperitoneum.
So agreed. Diagnosis is bottled down to rupture of the fibroid or a vessel, but there is no fluid in the abdominal cavity. So maybe a torsion. So what is our next course of action? Straight away laparotomy, cesarean, and then take it from there. What would you want to do? I also thought this patient should go away somewhere else, but I was not given that choice.
If pain is not relieving, then no option with us. We have to go for the surgery, cesarean section, along with the video counseling and this thing. If patient is comfortable, then we may think of the steroid for some time and giving some time, 48 hours. If we have time, patient is comfortable with pain. If she is not comfortable with pain, we have no option. We have to go for the surgery, laparotomy.
Pain.
It can be preeclampsia.
Yeah.
And other,
Help. No, that is
all ruled out. That is all ruled out. There is no preeclampsia.
MRI should help here as a part.
But MRI will not tell you whether there is torsion in the fibroid. At 34 weeks of pregnancy, when the uterus is almost above the umbilicus, very close to the xiphisternum. So this is the situation that I had. When we went in, we got the baby out, we saw torsion of the fibroid. When we removed that one fibroid, we thought, why should all the others are subserous fibroids? Why should we leave the others also? A consent was already taken beforehand from the family that if we feel that the fibroids are easily removable, we may remove them. We may do either a uterine artery or an internal iliac ligation. So after we removed that one fibroid, which was the culprit of causing all the pain, we did a bilateral internal iliac ligation with proper consent taken from the family. And then we went ahead and removed all the 7 fibroids that were there. We kept a drain for about 48 hours. Patient did well. Just about 3 months ago, I have done a second cesarean on her, and fortunately, the scar is entirely normal. Again, here, preoperative consent, preoperative counseling, extremely important. You can't be impulsive and take this decision on table. The patient was under spinal anesthesia, but You cannot take these consents on table. It has to be taken beforehand with husband, wife, and whoever wants to sit with you. I told you the patient happened to be a big builder's family. So these are some important things. Do we do cesarean myomectomy as a routine? No, we don't. We do it only if the fibroid is coming in the way or it is easily removed and a consent of that part is taken. So I would have done, say, about 10 or 15 cesarean myomectomies in the last so many years of my practice. It's not done as a routine. It is a debatable question. We will probably discuss for 1 hour on that topic.
Particularly if there is a history of GnRH analog exposure prior. Then
Sorry?
if it's a history of GnRH analog history prior, it will be a difficult if you.
No, but at 8 months of pregnancy, that GnRH effect would have gone away. I don't think at 34 weeks that is going to matter.
We had seen a patient that plane of cleavage will be very difficult.
Yeah. So it's not done. At least I do not do it as a routine. I just did an anesthetist whose cesarean, the 8 centimeters myoma was just sitting about 1 centimeter above the lower segment cesarean scar. I did remove it, but it is not done as a routine.
It depends upon the expertise, experience of the surgeon also.
Sir, every gynecologist can do a myomectomy. The experience in doing a myomectomy does not matter.
Sir, 25 centimeter size fibroid with cesarean section.
Sir,
25 centimeters.
No, but that is not the message I want to convey. I'm not here to convey that message. I have just removed a 5.4 kg fibroid.
So
but
it
that is
depends
not here
upon
the message.
The
You have to be
location,
prepared.
vascularity, experience, counseling, availability of blood transfusion, and if you can save the uterus. So many things are decided.
Message is very clear one. If it is coming in the way or it is easily removable, one should remove it. You should not try hard to remove any fibroid and consent.
This is the message. Knowing yourself is the beginning of wisdom. You must know what you are capable of doing, and only then you will do what. Do not take risk unnecessarily. Do not try to be Amitabh Bachchan and Shah Rukh Khan. Thank you very much for a patient hearing. I think the panel did a wonderful job.
Thank you very much. And you have a very good collection of rare cases.
Thank you very much, madam. I get into these situations I can't come out with, so I have to face these situations.
Thank you very much for including me at the last moment.
Anytime, sir. It's a pleasure. Sir, please come.
So it was a very nice discussion. And now moving towards our next panel discussion, which is on panel on imaging in high-risk pregnancy. So I would like to call upon our moderator, Dr. Aparna Sharma, ma'am. She is an additional professor, division of maternal and fetal medicine, obstetrics and gynecology, AIMS, New Delhi, and she won many awards and she has been a joint secretary at AOGD 2019 and 2020. And I would like to call all the panelists, respected panelists, one by one. Dr. Chinmayi Ratha. Ma'am is a director and lead consultant fetal medicine resolution fetal medicine center at Hyderabad. Dr. Devang Patel, consultant at SIMS Hospital and Gujarat Fetal Medicine Center, director of Divine Women's Hospital. Dr. Neeta Sata, ma'am, she is a president of Jamnagar OBGY Society and ex-HOU and associate professor Sri MP Shah Medical College, Jamnagar, and organizing secretary SOGOG 2019, Jamnagar. Dr. Prerna Keshan, madam, consultant OBGY and infertility specialist and endoscopic surgeon at Horizon Maternal Fetal Clinic, Assam, and trained in reproductive medicine at IRM, Kolkata. And Dr. Jignesh Deliva, sir, our respected president of Ahmedabad Obstetrics and Gynecological Society. And Dr. Ami Shah, ma'am, who is a consultant fetal medicine expert at UNS Fetal Care Center in Ahmedabad. So, desk is yours, ma'am.
PPT खुला हुआ है।
Okay, full screen कर दो मैडम।
कर दिया। So, a very good afternoon to all of you, and welcome to my panelists. And I must at the outset apologize to all of you for not really providing much of the case details. So, but it would be really an interesting thing to discuss all of these issues, which I think that as fetal medicine specialists, all of us come across it in our daily lives. So we have our esteemed panelists who have already been introduced. So I'll get away straight away to the panel discussion. So when we talk about imaging in high-risk pregnancies, fetal imaging in high-risk pregnancies, I would say that the possibilities are unlimited, and all of us would agree to that, but we only have 1 hour to it. So let's try and make this count, and let's see how we discuss few of the things like growth restriction, RH isoimmunization. I would be discussing more of twins than TTTS and fetal tachyarrhythmias. So let us start with the first scenario. Here she's a second gravida, para 1, live 1 at 32 weeks of pregnancy. She was RH negative, ICT positive, and she came with the ultrasound picture showing this finding. So my question would be, the first thing is, could we have prevented this? Dr. Devang.
Yes, a very good morning to all of you. First thing is, yes, as the image showed, it showed one of the sagittal scan of the abdomen, which was showing ascites, and the other one of the thoracic cavity, which was showing pleural effusion and pericardial effusion. So this falls into hydros fetalis, and as we have RH negative, so this is immune hydros fetalis, and possibly the reason is RS isoimmunization. And this could have been prevented by sensitization of the mother by giving her NTD injection in the previous, at the time of previous delivery. Now, just giving this is not enough. Still, you can have 2% of the cases wherein the cases may be missed out. So it is always advisable to give routine antenatal NTD prophylaxis, which could be given at 28 or 32 weeks after doing an indirect Coombs test. And a routine follow-up with indirect Coombs test is also good. Again, one more thing which can be added is that this is a routine dose which will neutralize, that is 300 microgram is going to neutralize say 12 ml of blood or the fetometal hemorrhage. In cases where there is massive postpartum hemorrhage, traumatic delivery, trauma during pregnancy in a RH negative mother, then a more dose of NTD can be given by doing a KB test and measuring the fetometal hemorrhage level.
Right. Thank you, Dr. Devang. I think this is one of the most, traumatic finding to have if you have a RH negative mother who's walking in with a hydrops fetalis, which can be absolutely prevented, as you said, by antenatal and postnatal NTD, and we can actually bring down the incidence to 0.16%. Now, suppose now anyway, so this mother, she came with high drops, but essentially we have given her NTD in the previous pregnancy, but in this pregnancy, she turns out to be ICT positive. So I would request Dr. Jignesh to talk a bit about it. So right from ICT negative, now we've moved on to the situation where it is ICT positive, and now we again talk about the role of ultrasound. So I would like to start from the critical titer and how to go about it once the ICT is positive.
So we have to repeat the titer, and if it is increasing in trend, then we should go for the Doppler ultrasound. for the middle cerebral artery peak systolic value.
Right, sir. Thank you, sir. And very briefly and nicely mentioned that we need to have. So once ICT is positive, so there is something called a critical titer, which normally I would say is 1 in 16. But if it is once 1 in 16, there is no point in repeating ICTs any further. And now we go on to the next step and the most important aspect, which has actually revolutionized everything in the management of RH pregnancies, and that is by doing middle cerebral artery peak systolic velocity. So if you look at this chart, once we reach the critical titer, then there is no further ICT. So once the titer is more than 1 in 16, we do not do any further ICTs, and we measure by MCA PSV. And if it is more than 1.5, we would need a delivery or intrauterine transfusion. Right. A bit more about MCA PSV we'll be discussing because we're talking about imaging. So a little bit more about MCA PSV in the context of this particular patient who came to us with a titer of 1 in 64 at 24 weeks. So when she came to us, her MCA PSV at 24 weeks was 92, which was more than 1.5 MOM. So now I would like to ask Dr. Neeta, why are we focused on MCA PSV, and how come it has become such an important tool for us in the management of RH? In fact, when we start doing MCAs, we actually forget that it has also got a use in fetal growth restriction. But somewhere we are so focused on MCA PSV. So why the MCA PSV is becoming very important, and what is the technique and interpretation of MCA PSV?
Basically, MCA PSV is one of the most important non-invasive tool to diagnose fetal anemia. And the best technique to measure it is like you to take an axial section of the head, and then ultimately you are supposed to find out the circle of Willis, then put a box on the middle cerebral artery just at the origin, and take the angle at the level that which should not need correction, and then measure the MCA PSV. You have to measure it thrice, and the highest measurement is to be considered as MCA PSV. And whenever you are finding MCA PSV 1.5 MOM, it is to be considered one of the most significant marker of fetal anemia and manageable.
So I would just like to ask here, why MCA PSV only? Why did we find out in the brain? Why not any other vessel? Anything, doctor? Anybody? Yeah.
See, in anemia, there will be hyperdynamic circulation in all the arteries, but MCA is one of the most accessible and reproducible, and we can easily get zero angle.
Right.
And we are routinely doing it. So
Right.
we are very well.
So I think when we want something to be universally acceptable, the technique also becomes an important point, and it is so easy to actually scan the brain, and because of the position and all, it's easy to insonate, and you get an angle of 0 degree. So it is reproducible also, and that's why MCA has become so important. Now I'd like to ask Dr. Chinmay. So now we have a situation in which the MCA PSV is more than 1.5. What will be your next step? And I think it's not just the imaging that we do with the ultrasound, it's the therapy also that we are doing with the ultrasound. So I would just like to ask you, what will you do next?
What is the gestational age now?
So it was 32 weeks. So this was 24. The first,
Yeah.
this is
So if
20.
it's 32 weeks, I'll first give the steroids and then
Yes.
plan my management.
Right.
If it's 24 weeks, then I think we have to move on to plan an intrauterine blood transfusion, because when the MCA PSV is increased, that indicates fetal anemia, and the correction of anemia is replacement of hemoglobin. The thing is, when there is a hyperdynamic circulation, there is already hypervolemia in there. So we want to replace as much as possible with as little volume that we give. So we give very strongly packed RBCs, about 80, 85 hematocrit. And this RBC has to be of O negative blood group. Whatever the blood group of the baby, this has to be O negative. And it's leukodepleted, gamma irradiated with a very high hematocrit. So that's a special preparation that's done. So the lab has to help you with that. Ideally, we should get small packs. I don't know if they're able to do that in AIMS. We have this problem because the commercial packs have about 300 ml. And the replacement is never 300 ml that's required. So actually you waste a lot of that.
No, we are actually asking for 50 ml, 100
Yeah.
ml.
So in institutions, it's possible, whereas the commercial labs have a little problem giving that. So anyway, we get about 100 to 200 ml at max. And then the sensitivity of the MCA, as just spoken by our co-speakers, is so good that you don't actually need to do a pre-transfusion invasive procedure to establish the anemia. You can prepare for the transfusion, and the needle goes into the umbilical vein. You can access the vein either through the placenta at the cord insertion or in the intra-abdominal portion. And after the first insertion, you aspirate some blood, which you send for blood group typing, DCT, and hemoglobin estimation. By the time that hemoglobin report comes, you can start your transfusion, because you have to keep on transfusing at least about per minute, about 5 ml or so. And then once you start the transfusion, you get the report from the lab, what is the hemoglobin. Based on that, there is a formula that you can calculate with the estimated fetal weight, the gestational age, and the hemoglobin deficit to correct it to at least reach about 14 or 15 to get a hematocrit of like 45 as a target hematocrit. So all the time you're monitoring this on ultrasound, you're seeing the heartbeat of the baby. If there's any bradycardia or anything, you stop in between, and then you continue the transfusion. Ideal transfusion is intravascular. Like here you see the needle is going in and piercing the abdomen, and you are accessing the umbilical vein in the intra-abdominal portion. If it's a posterior placenta, you will have to do this because it's not easy to access the placenta through the baby with one rigid needle. And if it is an anterior placenta, then you can look at the site of the cord insertion and put the needle in the umbilical vein. So that would be the plan.
Right. So thank you, Dr. Chinmay. I think you've mentioned all of the points. And what we also do is that, as soon as we take a pre-sample, we immediately use the HemoQ to immediately give us the value of hemoglobin, so that earlier we used to wait for lab reports, but now it is immediately available, so we can decide the amount of transfusion. So this is how, and through this is like intrahepatic. Before that, it was anterior placenta, posterior placenta. So depending on the location, we might have to do. And at the end, as you suggested, we take a post-transfusion hematocrit. So I would just like to know, how do you follow up? So now we have given a transfusion. Say, suppose she's 24 weeks, we have given her a transfusion. So is there a role of imaging again? How do we follow it up? Now we've given the blood to the baby. We have changed the blood in the baby. So how do we follow it up? Dr. Prerna, you want to answer? Yeah. Or if you're comfortable.
So basically the first follow-up is immediately after the procedure. While we're doing this, before we finish, we check the MCA at that point and make sure that it's come within that normal limit. Thereafter, because the patient is usually admitted, so we have a habit of checking before we discharge the patient. But otherwise, you could check after 1 week. There is an expected fall in the hemoglobin of at least 1% per day. And that could keep on decreasing depending on, suppose you brought it to 15, you'd expect it to be around 8 after 7 days. And the MCA PSV of 1.5 MOM works good before the transfusion. But after the transfusion, you may have to raise the bar to 1.6 or 1.7 because you've now put in adult blood cells inside. So, the tolerance for hypoxia is different now. And then after 1 week, we keep on looking at it. So either the MCA increases further beyond 1.7 MOM or the signs of hydrops persist.
Right. So that's absolutely correct. And what we target is around 45. What we target, the lower threshold for transfusion is 30. So from 45 to 30, we assume that it will take 15 days to fall. So possibly we take it around that time. But yes, if suppose it has not responded, sometimes even up to 2 IUTs, MCA works. So we do see MCA after transfusion also. So that is how we monitor. And so Dr. Amy, when will you deliver this patient? Say she came at 24 weeks, we did 4 transfusions. And then when do you want to deliver this baby? And how do you do the fetal monitoring?
The fetal monitoring, as was previously mentioned, the MCA PSV can be used up till 2 transfusions. After that, it becomes really difficult for that. And we have already mentioned how the hematocrit falls 1% per day. So that is how we calculate. But we also have to look at the fetus as a whole. We cannot just go on treating anemia and forget about other parts of the fetus.
I think that happens very often with us.
Yes,
I mean, we see 5 patients together and we forget that, what's happening to the growth of the baby.
Yes.
So we just focus on RH.
So we have to take into consideration the fetus as a whole unit, not just the anemia. The anemia part we're already covering. So we monitor the fetus as we would other fetuses, not forgetting that baby can have something else as well. And the delivery, usually we would prefer to take it as far as possible as 36 weeks. And Madam mentioned earlier that if it is around 34 weeks, we give steroids before doing the procedure itself. And even if we are like going on and it reaches a critical value of 34, we give steroids, then we might take into consideration the pediatrician, the parents, whether we want to transfuse one last time or deliver and then transfuse it. That is a matter of personal choice.
Yes, so I think this is a huge culture change which has come in our practice also. Earlier, we used to transfuse last at 32, deliver at 34. Now we transfuse at 34 and deliver at 36. So that, that maturity is achieved. So I think this is what we keep an OT ready, but we do transfuse at 34 plus 2
I would
weeks.
also
But
like
for
to add, sorry, ma'am.
sorry.
Oh, sorry, ma'am.
No, for the obstetricians, one thing, don't get very sentimental about the weight here.
Yeah.
Because usually the hydropic fetuses, the biometry will be different after the transfusion.
Yes.
Once the ascites settles down, you may actually get a lesser weight on the ultrasound calculation. Don't get panicky with that.
Yes, I think that's a very important point because the half of the weight is the hydropic weight, which is happening. The liver is so enlarged. So I think here we don't give much importance to the weight of the baby. It's more of gestation, which is important.
I would also like to add, ma'am, just like in all other high-risk patients, please have a pediatrician or a neonatologist who has dealt with such babies, because after transfusion, there is also bone marrow suppression.
Right.
So not only anemia, we also have to deal with thrombocytopenia.
Platelet counts,
Yes, and all the other complications that come along with it. So
Right.
if the pediatrician or the neonatologist is not well versed, it becomes very difficult. We have done our job, and then later on the results
No,
won't come
completely
back.
agree with you because this is a serious problem and our babies have actually received platelet transfusion after birth, and even we have given with IUT also because they would bleed so much from the cord that we did a cord platelet and it was less, and we gave platelet transfusion in utero also. But that's very rare. But yes, this is something which is very important, that there is bone marrow suppression which is happening, which might take time to come back.
The mode of delivery, madam, most of them, there is no indication for a CS as
No,
such,
they
but
have
yes.
so many pregnancy losses that they actually deliver normally. They have like term pregnancy losses, they are vaginal. So in these group, their vaginal delivery rate has been mostly okay.
Most of the times the parent do opt for elective CS.
That's there.
You can't refuse them because it's such a
Right,
high
right.
risk pregnancy.
So just to conclude this case, so this baby received 4 transfusion and we delivered her at around 36 weeks with a healthy baby and received phototherapy, not required exchange transfusion. So with that, we conclude the first case, which is RH. And I think this is the bread and butter of, a lot of fetal medicine people, because there's so much of, and in fact, very recently when I presented my data on an international conference, they asked, all of this is fine that you have done 300 transfusions, but the point is, why are we doing so many transfusions? Right? So that is a sad part of it. But yes, of course, intervention is exciting, but it is sad that we are not able to prevent it.
I think one important thing about prevention, other than timing the transfusion, the injections, is giving it in the deltoid and maintaining the cold chain. Those are the 2 places where I think we miss it. Most people
And
give it in
also
the
medical
gluteal.
abortions.
Medical abortion.
So I think medical abortions are something which are causing a lot of chaos, and those ICTs becoming positive because after delivery you have probably given it. So that is something which is important. Now I come to the second topic, which I think is even more prevalent, and I think we do this every day. So this is growth restriction. So this lady, she came to us at 32 weeks with moderate anemia and stage 1 FGR. This was a late onset fetal growth restriction. All her past obstetric history was normal, and there was no significant finding except the fact that her hemoglobin was 9.1. Now, when we did the biometry, her AC was on the abdominal circumference was on the 3rd centile. Right, overall estimated fetal weight was normal, but the abdominal circumference was 3rd centile. Now I'm actually discussing this because I'm sure everybody faces this day in and day out. So let's just take this case and discuss a little bit in threadbare that Dr. Devang, how do we identify the baby as a first step, as a small baby, as a first step to diagnosis of fetal growth restriction? Because the first step is to identify the baby is small and then see whether it is growth restricted.
So first of all, before labeling the baby as small, we need to know whether the dates are correct or not. Whether, as it is mentioned in the history, that the dates are correct. And if we have a early scan, then we should correlate it with CRL. And if it is corresponding, and then we see that the gestational age is corresponding and still the growth is falling below, then we term as a small for gestational age baby. But small for gestational age baby is not equal to a fetal growth restricted baby. And for that, we need to have a clear-cut idea of the multi-vessel Doppler, as well as all the parameters on the growth chart, which will tell us whether the baby is small or not.
Right. Thank you. So this is a very good point that not every small baby will be growth restricted. So first of all, but the main important part that we all struggle at is to find the correct dating. And that is happening because we are not dating in the first trimester. So it's an ideal situation and like a chicken and egg situation. If we date correctly, we'll diagnose the FGR correctly. But for that, the ultrasound has to happen in the first trimester. So yes, I mean, that's a vicious cycle, but let us just work with what we have. Yes, sir.
To interrupt you, another point is delayed conception. What sometimes patient may come with a delayed conception. The dates are accurate, but the conception may happen in the later half of.
Very valid point,
so, you have to maintain the growth chart.
Yes.
So if it is falls between 10th and 19th centile, then we have that concept also.
Right, so very, very valid point that, so that is very important that we do the dating in the first trimester. So if we have a CRL dating in the first trimester, then we are, well set to monitor this pregnancy for growth restriction. So if one single intervention which can actually help, diagnose or maybe not diagnose, overdiagnose growth restriction. So yes, as we discussed, so there is a difference between small baby and a growth restricted baby. And with that, sir, we come back to, for that question to you, Dr. Jignesh, that how do we differentiate between small for gestational age? A bit more in detail, I would like you to talk about how do you differentiate between small for gestational and growth restricted baby?
So that is I was mentioning that the small for gestational age babies are, they follow in the growth charts as we are doing scan serially, but the restricted growth of the baby can be plotted on the chart that baby is growing small. So once the growth chart, previous growth chart shows that it is a 15 centile, then 10 centiles, then that is the concern for that this baby might go into the small growth restriction.
Right. So
the growth chart is very important.
Yes. You want to add something? Anybody wants to add?
Yeah, as sir has already mentioned that we need to see the dates that the patient is mentioning, but sometimes the dates are they are spoken like she mentions the right date, but then we see that she has irregular periods. So my point was that with rising PCO cases, we are having this problem on the very forefront. And just recently, I had a patient just 2 days back. She came to me at 33 weeks, and she was showing a 28 weeks fetus. So everywhere in all the scans that was done beyond 25 weeks, she did in 2-3 centers. They had mentioned it's a small for gestational age baby. So we again dated it, as sir had mentioned. And we saw the first trimester scan. And then we had
I think very important point that whenever we have a suspicion of FGR, go back to the first ultrasound. Go back to the LMP. Does LMP correspond to the first ultrasound? If the discrepancy in the first week is more than 5 to 7 days, we follow the ultrasound. Dr. Chinmay, I just want to add one thing here, ask one thing from you here. We come across a very commonly 34 weeks ka baby hai, 28 weeks dikha raha hai. Dr. Chinmay, I want you to comment on that. How should we go about it? Is that a right thing to?
The first thing you do before you scan the patient is look through her records. And the very important scan that we want is her 6 weeks or 8 week scan, at which time all fetuses have almost the same parameters. So if you have a scan at the 6 or 8 weeks, whatever is the expected date of delivery at that point, we take that as the starting point. And you date it by the EDD of the early scan, and then find out what is the gestational age. So before you take the patient onto the bed, you should know what is the gestational age of this fetus correctly, because that can be established without ultrasound. Then you do your biometry. If the biometry is not matching, there are 3 main parameters of the biometry. One is the head circumference, one is the abdominal circumference, and one is the femur length. So head circumference usually matches. It's the abdominal circumference, like the case which you showed us. The overall baby was 17th centile, but the AC was 3rd centile. So that is like impending SGA. It's not SGA, but it can go into SGA because the abdomen is smaller, which means the baby is not storing enough food, but otherwise it's growing well. If everything is symmetrically small, first think of dates.
Yes.
If your dates are corrected and everything is symmetrically small, then think of growth restriction. And if the Dopplers are normal and still the baby is small, think of fetal causes like, infections or chromosomal abnormalities, genetic syndromes. If the Dopplers are abnormal, baby is small, Liker is less, then think of placental causes of growth restriction. Right. So by the end of the scan, I think you should
we have some idea that what is happening. The other thing that I just want to say is that every time we fix the EDD once, and every time we don't date it. I think that is something that we have to understand. And once we have fixed the EDD, we will talk about centiles. We don't talk about weeks again. We talk about at this gestation, she's 10th centile to what is expected. So every time the week doesn't change. It is only once that we have fixed it. So
That
now
is what I was going to add.
Yes.
See, we have a machines with enough storage capacity.
Yes.
So whenever you are doing an ultrasound, when you are entering the first LMP and you are finding a particular gestational age or a size of a fetus, it is ideal to enter your finding when you are doing second ultrasound in the same
machine,
so that you can find out the growth chart perfectly.
Ma'am,
I completely agree with you because we have 4 machines and we ask the patient, "Tumhara kaun si machine pe scan kiya tha?"
Yes,
So that we do it on the same machine so that you get the graph. So it's very important that you actually, take the correct graph. Yes.
Ma'am, can I add something?
Yes, please.
I would like to add that Indian growth charts in this scenario are very important. I think because what we have in our
We are
machines.
going into controversy now. Growth charts. Yes, please carry on. So I think
most of the machines that we have, they have either the shepherd or the
hadlock. Yeah.
So whenever, especially later in gestation, initially it doesn't matter much. Later on in gestation, practically every fetus
everybody
is
is yes. So regarding that, I would say I think most of us are following intergrowth. Now your machine will have intergrowth, but whatever said and done, even if you're doing hadlock, if you're following it up, if your trajectory is okay, then it's all right. But if the baby is falling down in its own trajectory, that becomes difficult. So growth chart is a topic where I think the discussion will never end. People have different views on it. Yes, so this is again, so I will ask Dr. Neeta to comment upon it. I have to ask you 2 questions. I mean, there are 4 questions here. So maybe people can take a few things here. But what I would say is that, do you, from the audience also, I would like to know, would you like to suggest a growth scan for everybody at 32 to 34 weeks?
Yes.
Yes. So this is a very evolved population, I must say, huh? No, but in obstetric conferences also, we get like people who say, no, ye bakwas hai, kyun karna hai? Right. So this is something. So that is one thing. So all the panelists do agree. I think we'll just hurry up on one of these questions. But all the panelists do agree that there should be a universal scanning at, say, 34 weeks. The POP study also showed, right? Now, my next question to Dr. Neeta would be that what is the optimal parameter? Like in this case, AC was less, but estimated fetal weight was all right. So should we be worried? How much should we be worried? Like yesterday only I worried a lot about my senior resident whose AC was less and she was like completely stressed out. So tell us, should we be totally worried or what should we do about it? Which is better?
See, we already mentioned that when AC is less than 3rd centile in this particular patient, we are predicting impending growth retardation. So AC is less than 3rd percentile is definitely worrisome, but we do have to consider both the parameters for confirmation.
Yes.
That is EFW and AC, and even I would say FLAC ratio is one of the very important.
So till recently, actually, the American Society did not actually accept AC as a parameter, and they would say that you look into the estimated fetal weight. But the recent studies have found that, okay, even if the AC is less, there could be an outcome which might be a problem. So we have to be on the lookout. So we can't ignore abdominal circumference at this stage, and we have to keep a watch out on that. And the third question would be that reduced growth velocity. Is there a role of reduced growth velocity? Like, for example, the patient was on some centile, came down to the other centile, not growing properly. Would you give it importance?
Very much. Because this is the group which might go into catastrophe without a justified, reason, which we used to call as unexplained stillbirth.
Right.
Because if a baby was growing at, say, 65th or 70th centile and is now on the 17th centile, actually it's not SGA, it's not IUGR, but by our traditional definition. But now this is a case of what we call as the late onset IUGR, where the baby has just, started going into the IUGR curve. The Dopplers will be very minimally affected. So umbilical will be normal, but around the 90th centile. MCA will be normal around the 15th centile. So MCA and umbilical might be normal, but if you look at the ratio will change. That is the group where you should be very, very careful and diagnose what is known as the late onset IUGR. And there, if the CPR changes, that becomes a surrogate marker of hypoxia, and this is the group which is at risk of stillbirth.
Yes, so very true. And I think with so much of focus on stillbirths, I think this is one of the biggest group that we have to target. In the 3rd trimester, suppose you have done the scan for her for the first time, you might not be able to detect it. But if you're seeing that it is falling the centiles, it's crossing the centiles, then something that we have to take care, because these are the patients who might land up in a stillbirth. Sir.
So this is a late onset IUGR, have a mild placental disease.
Right.
And they are very sensitive to hypoxia.
Yes.
So immediate hypoxic damage can cause sudden IUD. So these are the patients are very much serious concern for
Yes,
us. So
yes.
early onset IUGR is safe for management. The problem is management.
Right.
But the late onset is the problem of diagnosis.
I completely agree. And that is why we are coming to this definition of early and late onset. And Dr. Chinmay, I would like to ask you that these two different forms, like sir has just brought out the point that I'm going to ask next, because it's very important. Because early onset IUGRs are like the third world babies. They have been hypoxic forever. So their resistance is also better. But the late onset are like, those sensitive babies who would not tolerate hypoxia. So Dr. Chinmay, I would like to ask you about the difference between these two and how do they do eventually?
See, early onset is when problems have started early. So that's usually uteroplacental insufficiency very early. So these placenta are small. They do not have enough villi, and the capacity for the baby to grow is small, which starts pretty early. An arbitrary definition is 32 weeks. If you can establish growth restriction before 32 weeks, it's because placenta is small, the Doppler changes happen earlier. The umbilical artery is a marker of placental resistance. So placental resistance will be higher. When placental resistance is high, mother may also have preeclampsia. So you will have more maternal disease, you will have more fetal growth restriction, and you'll have more Doppler changes in the form of umbilical artery abnormalities. This is easy to diagnose, like sir said, but what to do if it is 26 weeks, you're stuck. 28 weeks, you're stuck. Management is a challenge, but you know what's happening. You've told the parents, they also know. So your counseling, video counseling, all that comes into place. Late onset is difficult because you did a scan at 22 weeks, everything was spick and span. You did a scan at 32 weeks, it was still okay because it was 18 centile, you reported it as normal. And suddenly 36 weeks, she has a stillbirth. So in late onset, it's the diagnosis which is a problem. So if you have diagnosed at 32 weeks that there is a change in centiles, there are problems here, keep her on a biophysical profile check, keep her on an NST check, keep her for other things. Maternal disease won't be there. Doppler abnormalities won't be there in that stark manner. There will be small changes like ratio changes. Individual Dopplers may be normal. So you will keep her if you manage it well, you can have a good outcome. These are the ones who you may have to deliver by 37 weeks.
Yes.
But if you don't diagnose it, then there's a problem. So in early onset, like sir said, diagnosis is easy, management is difficult. In late onset, diagnosis is difficult, management is not so bad because all you have to do is give steroids and
deliver the baby. So yes, sir.
When you are doing anomaly scan at 22 week scan,
yes, sir.
And if you measure a mean uterine artery PI, which is
Yes.
more than 95th centile, then these are the patients may go in
Who need more surveillance.
That
Yes.
these are the patients who we may have to do a close surveillance.
Right, sir. So, and again, like you're saying, prediction of late FGR is very difficult, whether, it's a first trimester or second trimester. So yes, uterine artery is a good measure, but again, we see that, it is more that the resistance is probably not very predictive, but yes, of course, we should be looking at it. So that's a difficult part. So quickly, I would like to ask Dr. Prerna about the Doppler. So we have already been talking about the Doppler. So we have this very clear concept that there are 4 Dopplers. There is uterine artery, umbilical artery, MCA, and DV. So can you just tell us, what is the application of each of them, early onset, late onset?
Since we have already discussed that the Dopplers are a revolution in fetal growth monitoring, and it's the most beneficial non-invasive method that we can adopt. And as per the umbilical artery Doppler is concerned, if there is some fetal growth restriction, then there'll be some increased resistance at the very beginning, and then there might be a reversal of flow, which might correlate with perinatal mortality. And that is for umbilical artery. If we come to the middle cerebral artery, because of fetal hypoxia, there increased blood flow through the brain, and there can be, this is more so in early onset FGR, and there's a brain sparing effect in that. So for early onset FGR, we can use ductus venosus, which is more pertinent in such cases.
Right.
So ductus venosus, loss of A and R wave as a very pertinent finding which we can
Yes.
take up.
So thank you, Dr. Prerna. I think the very basic concepts are that the umbilical artery Doppler shows a progressive change in early onset IUGR. We are conveniently know that, okay, if this is going to become absent, we have to deliver by 32. And if it is reversed, we deliver by 30. So it's a plain, simple Doppler to follow. But once you go to the late onset, you have to look at what is known as the cerebroplacental ratio, because as Dr. Chinmay said, the progress is not linear. You know, there might be umbilical artery which is normal, but MCA which is abnormal, and that's why these ratio become very, very important. Yes.
The CPR is also abnormal in early onset IUGR. Somehow we are now finding a lot of interpretations where people say, because CPR is abnormal, this is late onset IUGR. CPR is umbilical and MCA ratio. In early onset IUGR, the change is already there. So there will be CPR
Yes,
abnormal.
Dr. Chinmay, very good point. But the question is, do we manage CPR in early onset?
No.
So
No.
that is why it is important that the management is not decided by CPR in early
Problem is
onset.
the moment CPR is abnormal, they label it as late onset IUGR. That's not the case. When umbilical and MCA are normal and CPI is abnormal, then you think of late onset
yes.
IUGR.
So, and still the risk of stillbirths would be there. So surveillance again becomes very important. So yes, so with that we come to the next point, which is to Dr. Amy. What about the modalities of surveillance? You know, there's so much about growth being done every alternate day. The liker, you know, oligohydramnios deliver. So how do you, I would like you to comment about, because MCA CPR we have discussed. So just comment about the growth and liker.
This is a very, very common problem that the patient will also see every time the weight that has been checked. आपने तो बोला था 2.5 है, फिर आप आज 2.3 कैसे हो गया? How is it decreasing? So please don't do growth, don't measure the biometry again and again, not at least before 2 to 3 weeks, because that change will not be there. There is always an intra as well as an inter-observer difference, especially later in gestation, when you are measuring the biometry, especially the AC, because the section might not come exactly perfectly as it is intended to, especially when you have oligoamnios and there is FGR. So don't go on measuring the biometric parameters once you diagnose FGR every 2 or 3 days. No change will be there, and the patient and you both will be in a panic mode. Don't do it before 2 to 3 weeks.
What is your comment on oligohydramnios?
Again, the same thing. Oligoamnios, everybody presses a panic button. So when you don't have anything other than oligoamnios, you just have a growth restricted fetus and oligoamnios. Actually, this was a question which was put to Dr. Edward Gratakos, who is the person behind the Barcelona protocol. The question was addressed directly to him, that why have you not included oligoamnios in your management protocol? Because it has not been shown as an individual parameter to affect fetal outcome. So if you do not have anything else other than oligoamnios, please do not push a panic button and deliver the baby just because it has oligoamnios. It doesn't affect the outcome.
Right. So thank you. I think very important point. So 32 weeks oligohydramnios, Dopplers are, if they are just right, we'll continue the pregnancy and not terminate a pregnancy till 36, 37 weeks.
Management is on Dopplers.
Yes. So management is on Dopplers, and also probably biophysical profile becomes very important. So just before I end, yes, sir, please.
Liker is why it is important, because these babies are chronically hypoxic because of oligohydramnios, and these babies are in the neonatal period may suffer the complications of necrotizing enterocolitis. And
yes,
one of the baby of my when all the parameters are normal, Doppler is normal, but the growth is reduced, that is growth restriction and severe oligohydramnios, and then we be delivered by cesarean section. The baby got a perforation in the stomach because of stress ulcer. So that baby was expired because of that complication.
Yes, definitely the monitoring, overall monitoring becomes very important.
I too have an experience to share.
Just surveillance by doctor.
All right.
Confirm that the baby is good.
I too had a similar case. She was delivered at 30.
So what I want to know also is that, see, I completely understand, and we should deliver, monitor very, very closely with Doppler and biophysical profile. Yes, Dr. Prerna, you're saying something.
Yes, she had oligoamnios, but she was having normal Doppler parameters, as ma'am has said. But then we went to the pregnancy till nearby 35, 36 weeks, and we delivered her. But then the baby developed convulsions postnatally, and
so I think we need to really see on, how much of a critical point that you have to take. I mean, I would not say in my routine practice that I would deliver oligohydramnios before 36 weeks if the Dopplers are all right. So you don't know how the baby would have done if you had delivered her preterm also. You know, so that's why the evidence, we believe in what the evidence says, right? So even if you had delivered her preterm, it is not because you took her to 36. The baby might have had some bad outcome even before that. So those are the things that becomes, you know, little.
No, ma'am, it basically because of the hypoxia, the kidneys are, the blood is being diverted from the kidneys, but it has not reached that point where there
you
are
need to
other
deliver.
changes. Yes. So basically what happens is once there is oligoamnios, everybody panics. That is the only thing that, yeah. Yes, we are always
We
aware
need to
that
monitor.
this baby
Yes,
needs
yes.
frequent monitoring.
Right. I think oligohydramnios is becoming a sore point here.
But see, basically, like all the babies are going to behave differently.
Yes, yes.
So one of the very important point in Liker amount is how fast the Liker is reduced from your prior examination. If there is a remarkable faster reduction in the amount of Liker, then naturally the next point is going to be problems in the Doppler studies.
Right.
So at that particular point, you have to decide, even if it is oligohydramnios, even Doppler is normal. At that particular point,
I think the
if at all it
panelists
is a
don't
faster
agree to the
reduction,
oligohydramnios, so they
then
leave it at
you
that.
have to
So I think
decide.
we have a divided house here. But yes, I mean, a lot of people, Dr. Devang, could you just quickly tell us, because we have one more
The
case
only
to do.
thing
Yes.
is the concerns of a fetal medicine specialist and the obstetricians are different.
Yes. No, the concern is the
Yes,
baby. The concern is the
I
baby.
can say because the guidelines say that the oligo does not have any problem. The obstetricians have faced such issues
No,
in
the
the past, so
concerns
they
are
are
not
more
different.
vigilant.
No, I don't agree that the concerns of obstetricians and fetal medicine specialists are different, because we want the fetus and the mother both to be healthy. Now, what I think you are aiming
It is the
at
experience.
is we don't get anxious with oligohydramnios, because that is not the only parameter we are looking at. Like you said, there are many things. So why do we need Liker? We need Liker for the baby to move. So if she's having good fetal movements, that job is done. We need Liker for the baby to have breathing movements. So if we can check breathing
Gestational,
movements, that job is done. We need Liker as an indicator of hypoxia. So if the Dopplers are still normal, that job is done. So when all these parameters are being taken care of, then whether the Liker actually is there or not there is not such a big deal. Again, how do you look at the Liker? If you do an AFI, you may say there is oligohydramnios, but a single deepest pool of 2 centimeters is enough. So really our concerns are the same.
Yes. So I
would
think
like to
we
ask
will
you,
close
what
this
is there at the
discussion
end
here
of the
on
report?
oligohydramnios, Dr.
Just
Devang.
last point.
Yes.
Last point. What is what?
You know, my report will not be, I completely.
What will the advice or follow up?
See, what I am going to write is I am getting a deepest pool. Suppose I'm not getting 2 centimeters. I'll say my single deepest pool is 1.8 mm, but I can see good movements. I can see breathing movements. I can see the the Dopplers have not changed significantly. And we do not consider this as an urgent indication for delivery. She can be followed up with a daily CTG, and I can monitor this after 3 days.
Yes. So this is what, so Dr. Devang, suppose 32 weeks oligohydramnios, single vertical pool is 1.8. What will you do?
I'll do the steroid coverage and follow up with Dopplers.
Yes, you will still not deliver. You will still not deliver. You will give the steroid and follow up bi-weekly. I mean, see, bi-weekly follow-up is mostly all right. So bi-weekly follow-up with biophysical profile, right? So that is what we are doing.
Very small point. Yes, very important.
Yeah, biophysical profile includes both Manning and CTG.
I would see that patient as a whole clinical
Yes.
picture. I would see her blood pressure. I would see her reports. And as a whole, I would decide the timing of delivery.
So I think we can drop this topic here. Please, we
hypertensive,
have to move on. Yes.
Even
One more thing I
albumin
would like
plus,
to add.
Yes.
then we should deliver.
Right.
One
Not
more
wait.
thing I would
So,
like
doc-
to add is a very, very thorough counseling with the patient and her partner.
yes.
That's a very, very.
That is,
very-
I think fetal medicine people talk more than they work actually. So that's a given that counseling. Talk is the work. I must completely agree with you. So with this, this is the last aspect that with this we'll end the FGR case, is that she's actually a different patient. She was a high blood pressure at 24 weeks, and she had a previous preterm IUD, known case of APLA, right? And she had early onset FGR. So this was 23 weeks, less than 3rd centile baby, typically early onset FGR. So just by this, I want to ask Dr. Chinmay, that how do you time the delivery in such cases, and what is the stage-based protocol of Gratacost? Just a simple thing.
She's 24 weeks.
Right now, she's 24 weeks.
So I'll do a two weekly follow-up. If her Dopplers are normal, we'll do a 2 weekly follow-up, because at 24 weeks, we can't save this baby. I mean, our
Yes.
NICU is going to
So
refuse.
what is, so my simple question is, what is your critical decisive factor for delivering a baby? What gestation, which Doppler?
Yeah. So 26 weeks is the first critical point, because the terminal alveoli develop by 26 weeks. Prior to 26 weeks, our neonatologists give up. 26 weeks is still touch and go. We give a very good prognosis after 650 grams and 28 weeks. But suppose we get a lot of patients who are like 40 years of age and a lot of IVF, and then 20. At 26 weeks, I would do the entire jing bang of the Dopplers. If the ductus venosus is normal, then
continue.
we won't bother at 26 weeks. We call her back at 27 weeks again. And if it's like a very bad case, then maybe, and they're very keen, then every 3 days we do the Dopplers till the ductus venosus is abnormal. The ductus venosus is a continuation of the umbilical vein coming into the baby. So that is the oxygen supply. The moment the ductus venosus becomes abnormal, IUD is expected in the next 72 hours max. And the ductus venosus, once it's abnormal, the baby will have acidosis.
Yes.
So we don't want acidosis, because that leads to irreversible neurological injury.
Right.
So maybe every 3 days,
Yes.
and then pull it. Once she's 28 weeks, if ductus venosus is abnormal, deliver.
Right.
If ductus is normal, again, keep on monitoring. If she reaches 30 weeks, then I would go by the umbilical artery reversal maybe.
Yeah.
And
So it's just simply here, 26 is ductus, 30 is ADF, REDF, and 34 is AEDF.
because
So-
as the gestation age increases, our,
The
we are a little
cutoffs.
loose with the Dopplers. We don't want that level of compromise. We can salvage them better.
Right. So anytime after 34 weeks, we have AVDF, we deliver. Anytime after 30 weeks, we have REDF, we deliver. And anytime after 26 weeks, we have
It's
absent
just
ductus.
like, if you have to go to some very difficult journey, or you want to explore that room which no one has gone from a long time, you'll ask a friend to go with you. So when you have to deal with this, please get the neonatologist next to you. Both of you together counsel the patient and tell them exactly the same
outcomes.
things. Patient will also feel better. You will also feel better. Because you deliver and the neonatologist says, "Arey, badi jaldi nikal diya, nahi to hum kal bacha lete the isko." That's the end of the story.
And the other end is, ma'am, if that reverse end has to flow, is that gut perfusion is not there. So yeah,
In
you
fact,
would have
some of
delivered
the
earlier.
cases which you were
Yes, so 30
discussing-
weeks. So 30 weeks is a time when you would actually think, but of course, it also depends on your nursery. But definitely REDF, we do try to take till 30 weeks by a serious monitoring. And anybody has an experience with the computerized CTG, STVs, short-term variability. So we are now routinely doing short-term variability, and it's actually very good in the sense that it is available in all of the CTG machines. You just have to take a trace for 10 minutes. And at the end of the trace, it will give you automatic finding of short-term variability. And the short-term variability, as has been described here, is that if the STV at less than 33 weeks is less than 3.5, it is abnormal, it is indicative of hypoxia. So DV, you might not have somebody who's able to do DV in your setup, but STV anybody can do through a normal CTG, which is available in our country. Any new company which is selling you a CTG will have this STV. So if it is at less than 33 weeks, if it is less than 3.5, after an REDF, you deliver. Because the Truffle trial actually said that STV and DV are mostly similar. So this is a method, and we are routinely using it now in our setup, and we find it very useful and very, very, reassuring if the STV is normal, and we take it forward. So I think that is, we discussed the second case, and we have, I think, 12 minutes left. So we'll just take quickly the third case here. So initially I thought I'll talk about the twin-twin transfusion syndrome, but I think that's a core fetal therapy topic. So I thought let's discuss imaging in twins. Right. So simple questions about imaging in twins, on where all imaging becomes very important in a twin pregnancy. So Dr. Devang, how do you date a twin pregnancy? Because there are two babies. They might have different CRL. So how do you date a twin pregnancy?
So the bigger baby has to be considered for dating. And if there is any discrepancy, bigger baby CRL has to be considered, because there are no chances of large for gestational age baby in early pregnancy.
Right.
So that is more accurate. And you, in case of IVF pregnancy, you can also take into consideration the embryo transfer date and then date.
Yes, that's very important. And discrepancy in the early pregnancy in a monochorionic twin, would you be worried about something when you're doing?
When in early pregnancy, if there is, then there are chances that we need to follow up these babies even more closer than a monochorionic, because there are chances of selective discordancy for growth as well as twin transfusion syndrome.
Right.
So they need to be keep in close watch even at 2 weekly follow-up also.
Right, right. So very simple thing, as you have said, is that we should always date a pregnancy because we can give only one date by the bigger twin, so that there is growth restriction, we detect it. So that is the important aspect. So Dr. Jignesh, what about chorionicity? Why is it important and how do you do it?
Determination of the chorionicity is very, very important, and it should be in the first scan also, that is in the first trimester also, in the first trimester scan. So because the later on the dichorionic, to differentiate between dichorionic and monochorionic is sometimes difficult. So it is very, very important to determine the chorionicity in the first trimester scan.
Right. So as shown here, it is the lambda and the T sign, which is very important. And why this is important is because now we say that there is no diagnosis of twins. It is either monochorionic twin or a dichorionic twin. If you're not mentioning that, we are actually missing out on a lot of stuff. And we are getting a lot of cases where we have to give the benefit of the doubt and make them monochorionic, because we have absolutely no previous scans. And sometimes later on in gestation, it's very difficult to find out the chorionicity. So the next question, Dr. Neeta, would be, how do you do aneuploidy screening in twins? What is the role of NT alone versus NT with combined screening? Would you do it? Patient has come to you in the first trimester. What would you tell her?
So in prenatal screening, first, as we know the chorionicity, either it is dichorionic or monochorionic. When monochorionic is there, we have to give a pregnancy specific risk with the our NT as well as the combined screening. When we are talking about dichorionic, those two baby are just separate and they are just sharing the womb. So they have a separate risk for Down syndrome, and that can be calculated by their separate CRL, NTN, as well as combining the serum biochemistry.
Right. So, and currently the standard of care is that we offer combined screening for all twin pregnancy, NT plus the dual marker that we are doing for a singleton pregnancy. It is no different, and it is almost as good as a singleton pregnancy. And this is our standard practice for twins. So I would just like to ask the panelists, are you doing NIPT for twins?
Yes, we do NIPT for twins because the recent ACOG guideline says it performs well. We don't do it as a primary screening. We do it as a triad situation. If
yes, yes. So suppose there is intermediate.
The only
risk.
thing I have a problem here is quadruple test in second trimester.
So that's what NICE says. Actually, 2019, we are not doing that, but this is a compendium of the guidelines. So I have put it, but quadruple in the second trimester is not being done or advisable for twins. We don't do it. We are doing the first trimester screening, and then if it is not there, then we just do a level 2 ultrasound to see what the risk of aneuploidy is. So that is what, and as Dr. Chinmay said, NIPT can be offered if there is intermediate risk or patient does not want to do an invasive testing. NIPT can be done in twins. Now, most important part, Dr. Prerna, is that, twin pregnancy, somehow I think the clinical aspect of monitoring of twins is actually a thing of the past. We don't monitor a twin pregnancy by fundal height. So just want to talk, want you to talk about it. When do you want to call a twin pregnancy for monitoring?
As the doctor has said already, that we'll start from the chorionicity, termination of the chorionicity at 12 weeks, and then we'll call the client at 14 weeks and do the serial scans and start doing 2 weekly scans from 20, 22, 24, 26, and up till 28 weeks. And then to detect early onset twin complications like early TTTS and IUGR or in discordancy there. And then from 30 weeks onwards for late onset TTTS and all those late trimester complications.
Yeah. So here important is that, like you said, monochorionic is 2 weekly and dichorionic is 4 weekly. So every month the twin pregnancy has to have a scan. There is, like earlier we used to have every month a clinical visit only. So now we have twin clinics where we do antenatal and we do scans also at the same time. So that's the purpose of monitoring the twin pregnancy. Dr. Neeta, what are the complications which are specific to twin pregnancies? Monochorionic twin pregnancies.
The commonest one is twin-to-twin transfusion syndrome, which may occur in monochorionic pregnancy. The second one is TAPS, and I think the congenital defect.
Yes, so congenital malformation also become very important, and there is TRAP here, which is an acardiac twin where one of the twins is a parasitic twin. And these are actually 20% of all of the twins are monochorionic, and within the monochorionic twin that these complications do occur to a range of 15 to 20%. So it's a significant actually problem which we need to really see. And congenital malformations also, they occur more commonly in twins and even more commonly in monochorionic twins. So all of these we have to see. Now, yes, sir. Yes, I think that's a very important thing of single fetal demise. So we'll just quickly discuss that at the end, although I have not put it here. So Dr. Chinmay, I just want you to summarize on when would you like to intervene in a twin pregnancy with, say, any of these problems that we have discussed.
So in a twin pregnancy,
See, with monochorionic
twin pregnancy, if you've already had the fetal demise, there's very little that one can do.
Yes, I think this is a very important point to bring up. Yes.
So what happens is monochorionic twins are connected by the placenta and both are pumping their own hearts. If one of the babies stops pumping the heart, that means there is a death. Suddenly the blood pressure in that baby becomes 0. So whatever the intertwin connections are there, there is a spontaneous exsanguination into the 0 blood pressure area. So that happens immediately at the time of death. In the next 10 minutes, the nature understands that things are not working well and the circulation reverts. So the hypoxic damage to the surviving twin happens as soon as the IUD happens. So if later you want to do some kind of cord coagulation or all, it's not going to help. So the time to intervene in these conditions is at impending demise. So if it is a, say, trap sequence, you measure the trap, you see in trap that baby is an acardiac twin. So it's a mass, but it doesn't have a heart. The circulation of that is being supported by the pump twin, the one which has the heart. So that is actually at a risk of high hemodynamic excess and the hyperdynamic circulation and hydrops. So you intervene before the hydrops occurs. If the trap size is increasing or the Dopplers are changing or this one is developing anemia, then you do what is a cord coagulation procedure, either by radiofrequency ablation or a bipolar cord cautery or an intrafetal laser. Whatever you do, you ablate that trap. Similarly, if there is a twin-to-twin transfusion and you've reached stage 3, you either go and separate the vessels in the placenta by doing a fetoscopic laser photocoagulation, or you ablate one of the twins' circulation by doing a radiofrequency ablation or bipolar cord cautery. And the third is selective growth restriction. Again, you know that after the ductus venosus IUD in the growth restriction baby, impending IUD, when the heart is still beating, that is the time when you go and do an ablative.
We have one patient in which there is a 22 weeks pregnancy, twins, monochorionic pregnancy, one
fetal demise.
So we have counseled the patient that we can go for, there is a, that you showed that 25% chances of neurodevelopmental delay.
Yeah.
So on positive note, we have counseled her and we had done a fetal MRI at 27-28 weeks to see the neurological damage as a on paper documentation, and that MRI was absolutely normal, and that baby was delivered at full-term pregnancy, normal vaginal delivery, and that baby is at now it is at 3 months of age.
Yes, absolutely
normal. Neurologically, all the reflexes and all that normal. So that kind of
so yes, when we say 30% neurodevelopmental delay, there is 70% chance that the baby will be normal. So I think it's also how we counsel them and give a positive outlook on the patients. Otherwise, with the changed MTP law, everybody is coming in for a termination at 24 weeks for every single thing. So I think as fetal medicine specialists, we also have to show the positive side, like you have completely mentioned. So as ma'am is saying, Dr. Chinmay said that indications would be a pre-terminal baby. The baby is about to die, but not yet he has the fetal heart. So these are the techniques like bipolar cord coagulation and radiofrequency ablation that can be offered to these patients who are for intervention in twins. So complications, of course, there could be IUD of normal twin. So the red flags in a twin pregnancy would be a dichorionic with discordant for anomalies. Monochorionic itself is a high-risk pregnancy with a growth discordance, Oli-Poly sequence, or a Doppler abnormality. So a quick word of this thing about the single fetal demise. So I think we have just 1 minute left. So I'll end and we'll not do the fourth scenario, which is actually not very common. It's a fetal tachycardia scenario. But here I would like to just ask, what is your opinion on a single fetal demise in a dichorionic twin at say 24 weeks? What do you do and how do you manage? Because I think this is a very common thing.
See, in dichorionic twins, there is no placental anastomosis. So there is no crossing of any circulation. So if the one fetus is demised, then it is not going to affect the other fetus. Only thing is that if there is a theoretical risk of DIC. So one of the things what we do is we do a coagulation parameter and we repeat it.
Yes.
If there is any discrepancy, then, but most of the time we have seen that we have never faced such issue. As far as monochorionic is concerned, as Sir told, that neurological sequelae, along with that, there is multisystemic ischemia also. So not only neurological, you have GI system and other systems also, wherein you can get the affection, and that has also to be concentrated.
Right.
Third thing, that if MRI is normal, that does not rule out neurological sequelae.
Yes.
And earlier the demise, there are less chances of neurological sequelae and as compared to the later gestational single fetal demise in monochorionic.
I completely agree with you. And I think whatever, so some patients do come to us that one demise has happened, please deliver. So I think that is not the point here, whether it is monochorionic or dichorionic. I think our neonatologists have drilled into us that no preterm delivery. So we are, every baby we try to take, even one single day we are giving to the baby, it is to the advantage of the baby. So I think, Dr. Amy, you wanted to talk about your experience with TTTS.
I just wanted to ask, like, the patients are very difficult to counsel. Madam said that before the demise actually occurs,
yes,
you are giving an option of terminating that other baby.
Yes.
And people ask questions.
Yes.
Like, how can I kill my own baby when it is, we might have another few days? That dilemma is always there, and the counseling is very difficult to the patients and the family. They say you are killing the baby. That same complication that you are asking, that hypovolemic and hypervolemic changes are
But we
there.
are preventing that,
Yes,
right?
that-
By
but
doing this, we have to
I
understand
think
this.
that counseling has to happen on the first day when you
Yes, so
meet them.
counseling,
You
I
give
think,
them
is
a
very-
timeline. You give
Yes.
them a timeline and you say, this is what is expected. So if we don't do anything, we may go in this path, and then all the problems of the single fetal demise. If we do something, we can still risk this. So it's a difficult situation.
So, and also I would like to say that when we are doing the demise or we are doing the cord coagulation, the main anastomosis or the transfer is occurring through the umbilical cord. So we are actually stopping that, feto-fetal transfusion. So that is what, so our causing a demise versus a spontaneous demise has, like a lot of difference. So this is what I think we need to keep counseling, that this is going, like she said, make a roadmap of what will happen if we don't do anything. Number one, don't do anything, what will happen? Number two, single fetal demise, what will happen? Number three is you give both survivors, you do have the option of laser where both the babies can survive. So definitely it is tricky, and they come to you again and again. One day they come to them themselves, next day their parents come, next day some other doctor calls, what is the plan? So this is what happens, and we have to keep talking that this is the plan of action and this is how we do it.
Madam, cost is also an issue. Cost is also an issue, madam. You are taking.
So fortunately, cost is not an issue for us.
But in private sector, madam, it is very difficult to
Yes.
counsel that we are going to take money. We might lose one fetus, maybe we might lose
I
two
completely
fetuses,
agree with
and
you.
we
That's
might
why
we might end up with nothing. So
Yes.
it's a very
Yes.
difficult counseling
I understand.
problem we face.
Yeah, I completely agree with you. And I think with that, we come to the end of this panel. And thank you very much
Thank you, ma'am.
to our panelists for this panel discussion. Thank you very much. Thank you. Thank you so much.
So we are ending this morning session, panel discussion, and now we have to move towards Hall A, where it is a beautiful oration by our Foxy president, Dr. S. Santa Kumar.
Check, check.
Check.
Hello, good afternoon. After the post-lunch session, we are beginning and now we are running out of time. So we make the next sessions 40 minutes. So I would like to call upon our next session's moderator or panel discussions moderator. The panel would be of critical complications in mortality, unexpected excessive bleeding during DNE and unsafe abortions. And our moderators are Dr. Bharti Maheshwari and Dr. Richa Sharma. Ma'am, please come on desk. And I would like to introduce Dr. Bharti Maheshwari. She is a professor and head of Department of OBGY and IVF in Muzaffarnagar Medical College. And our next moderator, Professor Dr. Richa Sharma. She is a professor in OBGY Department, University College of Medical Science and GTB Hospital, Delhi. And I would introduce, okay, you introduce? Okay, sure. Thank you.
A very good afternoon, everybody. So now we are going to have a panel discussion on critical complications in MTP, still a reality. So moderators are Dr. Bharti Maheshwari, Madam, and myself, Dr. Richa Sharma. So now I take the opportunity to invite our panelists, Dr. Archana Sharma, Dr. Meenakshi Patel. She is a director and consultant of Sunshine Global and Baroda Hospital and immediate past president of SOGO and current IMS treasurer. Our next panelist is Dr. Narendra Gajar. He is the practicing gynecologist at Ashirwad Hospital and Akash IVF Center, Chikli, since the last 37 years. And he is also the president of Navsarai Gynae Society. Next panelist is Dr. Pratibha Singh. She is a consultant and laparoscopic gynecologist and IVF specialist and director of Healing Touch Multi-Speciality Hospital and IVF Unit, Bhagalpur. Next panelist is Dr. Pushpa Jhungre. She is a professor and head of the Department of Obs and Gynae at PG MMC Amravati.
Good afternoon. Namaskar.
So as we are here for a panel on the MTP related issues, we all know. And all of you, I think we have done some academic sessions for MTP with all of you and in last 3 years. And we also know the developments in the MTPs in our countries in form of amendments and as well as especially in the amendments what we are trying for last so many years that have been done in 2020 and 21. So it is really very important years for all of us. And as we have started late, so we will finish it. We were given 1 hour, but I think we will try to finish it in half hour so that the things can be done properly. So that we will shorten it because of so that next speakers are also here. So we all know, so we will come just, we had made a very different panels. It is because it is given related to critical care. So we have focused mainly on the critical care. And this introduction or this background that why we are, because in downstairs also in the hall, very good panel was going on. So many of us, we are asking that in MTP, we are doing many programs. But why it is still important? Because we all know that around 15 to 16 million pregnancies, they are terminated every year in India. And every day, still 13 women die due to unsafe related causes. And MTP is different from other clinical issues in the way that it is not only a clinical problem, it is social, social as well as medical-legal issues. So MTP is different for the clinicians in many ways. It's not only just treat the woman or just give the clinical services. We have to follow many norms, but we can't escape. It was the time when we don't, obstetricians, they don't prefer to do MTP. But it was, message was given that MTP should not be jeopardized or safe abortion services should not be jeopardized in preventing unsafe abortions or in preventing sex selection. So we have to do, and we have to face the challenges also. And this is, we all know that the biggest challenge for us, that instead of legalization of MTP since 1971, 80% population, they don't know that MTP is still legal, and as well as still many larger populations, they take abortion services outside the government services. So this is the important issues, that awareness, and though we have services, but the women and public, they are not aware about that when they should take the services and how. So we all know that we all know that the amendment, it is the most burning issues related to MTP. So I invite Dr. Richa. She's a current MTP committee chairperson. We all know, to cover this issue, MTP Act amendment.
So MTP Act amendment, it is a big milestone, a great achievement which have been achieved. And we all know that the newer amendments, they have been notified since 12th October 2021. And there are 4 major amendments. So one is that the gestational upper limit has been increased from 20 to 24. So 24, it is increased for the 7 category of the women, which includes rape, victim of incest, minor, physically challenged or a mentally challenged woman, and in the cases of disaster, and also if the woman is a widow or divorced. And then regarding the opinion, now the 1 registered medical practitioner opinion is needed till 20 weeks, and 2 registered medical practitioner opinion is needed between 20 to 24 weeks. And after 24 weeks, it is the medical board approval is required. And that also, it is only for the fetal congenital anomalies. And then the breach of women's confidentiality, now the punishment is fined, and with and without 1 year of imprisonment. So now the new form which has been introduced is Form E. This has to be filled if we are doing the medical termination of pregnancy between 20 to 24 weeks of gestation. Then this is the Form D. The medical board, they will give the approval in the Form D. Either they will allow or they will deny. And now the board will give the opinion within 3 days of the receiving the request for MTP. Also supervise that the MTP is done within 5 days of the receipt of the request for MTP. Now the slight change in the Form A is also there. Now Form A, it is a form of application for the approval of a place for MTP, and this is to be filled by the private setup. So the clause, the B clause, now it has automatically to be read as 24 weeks. So those who have got the approval done, so they don't have to get the registration, but they just have to communicate to their CMOs and to get their certificate updated. Initially, it must have been 20 weeks. So now we go to the case 1.
So that is very truly, Richa has highlighted. Now we esteemed panelists are with us. So we will do 2 or 3 cases discussion. So first case, that is very common case, that is any panelist they can have. That is a woman, a 29-year-old, and she is gravida 2 para 1 and previous 1 cesarean section 1 year back. But common situations are many patients, they come to us and she is having the 11 weeks pregnancy and she is willing for termination of pregnancy. And she is saying that she was using some contraception, it is failed. And so now I wanted to ask the panelists that what are the important, in this case, is any high risk issue? Or it is the simple case? What is the important issues related to the counseling? This case seems simple, but what are the important issues? And how you will select the site for this case, pre-procedure workup. This is a very important, and how methods of terminations and complications in brief. What is the specific for this case? Dr. Archana Sharma is not here. So anyone, yeah. You can have mic.
Yes, sir, this patient is 29 years old. She is having a previous, am I audible?
Yeah, you are audible.
She is having has a previous cesarean section and 11 weeks pregnancy she has. So first of all, counseling of the patient is to be done. This is due to the contraceptive failure. So history is important. Which contraceptive failure, which contraception she has taken and it has gone for the failure. Another thing, previous cesarean section, so always go for the sonography also, so that the implantation of the placenta, scar, ectopic or anything has to be ruled out in this patient, because his history is there is a previous cesarean section. That is most important in this type of patient. So placental lacunae and all these things has to be taken care. Third thing, regarding whenever you do the pre-operative, pre-procedure workshop, totally the hemogram, blood group and everything has to be explained. Along with that, if you are doing this with a suction evacuation, in that case also you have to explain there may be the chances of perforation in this case is high, because there is a previous scar is there, the scarring of the uterus is there. Third thing, the another method for the complication termination, you have to prime the cervix. As such, it is less than 12 weeks, but 11 weeks is there. So cervical dilatation may be difficult in this case. So you have to prepare her for the cervical dilatation misoprostol before the procedure, 3 hours to 4 hours, 400 micrograms, so either vaginally or sublingually. If it is sublingually, then it is 3 hours. And if it is vaginal, it should be 4 hours prior to the procedure has to be kept in this patient, so that the dilatation, during dilatation, it will be, during the procedure, it will not be having any problem.
So very beautifully, in fact, you have focused and all very specific highlighted you all things. And it is very true that ultrasound in pre-procedure workup is a very important in all previous scarred uterus, because though it is not mandatory, but in these cases, yeah, you wanted to say something?
It is very nicely elaborated medical aspect. But at the same time, I would like to involve legal aspect of MTP, counsel, fill up the form, opinion form, form C, that is very important as far as MTP Act is concerned. Relate signature of the husband of the patient may not be needed as per law, but at least one relative has to be there while you are taking this patient for termination. Because suppose patient has come alone and then she ends up in a problem, then it can make trouble for us.
So this case is prone for may have complication. That's why you have done that. So this is okay, that attendance should be there preferably. One question that regarding site selection, though it is 11 weeks. So of course, till first trimester terminations, sites approvals, those there normally till 12 weeks, they don't require the OT facilities and all. So in these cases, will you like to prefer? Might be.
No, we are listening.
In these cases, will you like to prefer in a where the OT facility is not available, or you will prefer the where it is available?
Of course, OT facility has to be available. Even when we advise medical abortion, there has to be backup for evacuation in case the patient needs it. So it is out of question. Site should be where all the facility available with even facility for emergency laparotomy, it is there. Blood bank facility is available. It being even if it is 11 weeks, she can bleed.
So what are the important complications this patient may have?
Right from anesthesia complications. So there might be some anesthetic complication or time of dilatation of the cervix.
So 11
perforation of-
weeks, she is saying that you prefer the method of termination, ma'am, in this case. At 11 weeks, she's
It will be
11
suction
weeks.
evacuation with prior priming of the cervix.
Okay.
Surgical method only.
And
not,
what
medical
anesthesia
alone.
you will like to give, or pain management in this particular patient?
In this case, patient can be given general anesthesia. If there is any contraindication for general anesthesia, then we can go ahead with paracervical block. In case
Other panelists, yeah, one by one, every panelist, because these are the very important issues.
In this, we can also go for the medical termination. You have all facilities. You can go for misoprostol also.
Yeah.
Mifepristone and misoprostol, and that can also be tried for this because she's just 11 weeks and cesarean section is not an indication, contraindication to go for medical termination. So,
In a scarred uterus, you can give medical method. No, yes, we can give.
yeah, we can. 11 weeks we can give.
Dr. Pratibha is trying to tell it is according to WHO.
Yeah,
less
11
than
weeks.
12 weeks and more than 12 weeks they have divided. So
Yeah.
we can give the medical
Medical,
method.
but-
if we follow the NHM guidelines of Ministry of Health Family Welfare, so they stop at 9 weeks medical management.
but-
And 9 to 12 weeks is a gray area.
Yeah.
But I think we can follow what
We can-
WHO has recommended.
Yeah, it has been
Yeah.
recommended.
Because even in
And you should
Risha-
have a backup at your hospital for the management of such cases. That's
So, even we in the after 12 weeks, we also use WHO method, misoprostol method. We all use, and this method is mentioned in our government guideline, also compressive abortion care 2018. Because
it is likely to be incomplete. And majority of the patients they are going to need evacuation.
this is a very important thing. That's
One
why we are
important
having this panel
thing-
discussion. That's why we are having this panel discussion, that many are giving the medical method, but it is incomplete. Many are giving, they are having complications. Many are giving, but it is not so. So that's why we must know that for last so many of years, MTPs, you in such cases, because this is the 11 weeks, though it is said that it is the first trimester, though it is a scarred pregnancy, you think that you should, agar ye scarred nahi ho, if it is not a scarred, then you will like to give medical, or you will like to do MVA or surgical. Many of us will like to do medical, even in 11 weeks. You know, how many of you know?
Up to
No.
7 weeks, you should.
So many of audience, they do only till 9 weeks. You do only till 9 weeks.
Up to 7
Up to
weeks,
7
we
weeks
don't
only?
admit the patient and give the medical management. But after the 7 weeks, patient should be admitted into the hospital.
No, that is a different thing. That is a different thing. Yes, sir. Dr. Girish. Yes, so that is the different thing. But Doctor, क्या कह रहे हैं हमारे Dr. Ajay sir, आप what you are saying? ये बहुत बड़ा confusion है कि WHO method का भी use करना
Let's
है.
make it very clear. Beyond 63 days of pregnancy, you are not officially allowed to use the medical method.
Mike,
You are not allowed. You may write you have used misoprostol for cervical ripening and then do a MVA. But on paper, you are not allowed to do medicated abortion
The
beyond
reason is-
63 days.
the reason
Full
is-
stop. There is no discussion to it.
Yeah.
The reason may be as
She
atrocious as
might have a
possible,
rupture
but that is the
uterus,
law of the land.
And then Yeah, she can have any problem.
No. Whether she has a complication or no,
Yeah.
whether you can terminate at 65 days with the medical method or no.
No.
Just I'll give you a simple example. Before the current amendments came, for an unmarried woman, we could not write failure of contraception.
Yeah, that is
The law was idiotic, but it is the law, and we have to follow the law. So please do not do medicated abortion beyond 63 days of pregnancy. Full stop, no discussion.
Even about 63, there is some confusion. They say it is allowed till 7 weeks. It is allowed till 49 days. And if
No,
you are
I'm
giving,
sorry, I'm sorry that 49 days.
No,
They say
just
you
listen
can-
to me.
1 minute, madam. You can use it in a combi pack. That is what the earlier guidelines says. The current guidelines says you can use it till 63 days. That 49 days is in the old CAC guidelines, the 2010 CAC guidelines. Please read the current CAC guidelines of 2018.
So if you are using a combi
Abortion
pack,
Care guidelines of 2018 says you can use medicated abortion up to 63 days.
So, okay, very clear message by Dr. Atul that what law says we have to follow. Even your personal experience is whatever is. So that is the very clear message. So of course, the handling, because handling critical complication is different in MTPs than other cases, because it is related to lots of medical legal issues. So now we will, this is the important issue. That's why we have taken time. And then next thing that is very related, that you are doing the evacuation or you have given the medical method. We are not giving medical method. We are giving the evacuation up to, in this case, 11 weeks or what. And suddenly severe hemorrhage started.
Yeah.
Yeah. So Dr. Pratibha, how you will handle and what you will do?
Now, she's bleeding. So first we have to monitor her vitals. If she's in hypotension, so her foot end can be raised and IV fluid should be started. And you should see what type of bleeding she's having. You should see the whether you can, she has to be, vitals should be maintained first. And after that, if the BP is controlled, then you can see the bleeding. If the os is open and the products of conception are lying outside and she's stable, then you can just evacuate that. And you can start with oxytocin and prostaglandins for this patient, and IV fluid should be started. And if her vitals are not, if she's not stable, then you must see for the per abdomen, you can see whether the uterus is atonic or it is Golgi feeling is there. If there is some products can be taken out, it can be taken out along with the prostaglandins and this oxytocin cover. And then if there is cervical lacerations, that also can be seen. If there is any tear in the cervix or vagina, if it is more than 1 to 2 centimeters, you can stitch also. Then you should also think for the incomplete abortion, sometimes that also causes. Then abnormal placentation sometimes causes irregular or torrential bleeding. Then also you must suspect about the perforation. So that all should be kept in mind. Perforation, when it becomes more, then only there will be a torrential bleeding. So that all should be seen and it should be managed accordingly.
So this is very important, and because any woman, she's 1 year back, she is having the cesarean, and if she is having the bleeding, so your pre-procedure counseling and your pre-procedure workup, that is very important, and all documentation that everything should be mentioned in the file, and you must have preparation to handle such situations. That you are having the resuscitative measures and immediately simultaneously you are seeing whether it is incomplete or there is something. Yeah, you want to say something?
You have to inform the family also regarding the condition of the patient. So repeatedly telling the condition of the patient is also important in this type of patient.
So such things should be informed to the family or whatever in the before also. Because if you don't do proper counseling and you start up, then you tell, then it is. But if everything is properly mentioned in the file and documentation is there, so you can handle situations better. So I think we all know how to do this, and that's why the patient should be admitted high risk cases. It could be because of perforation, it could be because of incomplete evacuation. So you can manage properly. Now another situation, Richa, she will discuss this.
Now we go to the case 2. So now this particular patient, she is 28 years old, Gravida 3, Para 1, Living 1, and Abortion 1. And she has come at 11 weeks gestation for medical termination of pregnancy. Her last childbirth was 3 years back by cesarean. And there's a history of cryotherapy done 2 years back. Now her gynecologist has posted her for surgical evacuation with some pre-op and post-op, pre-op and intra-op preparations. So Dr. Narendra, can you tell us what could be the anticipated problem in such cases?
Because of two factors. One is previous cesarean section, and another is because of some cryotherapy done on the cervix. I think so. The cervical dilatation is likely to be difficult in this case. So that we should anticipate well in advance, and we may take appropriate care for that.
Okay, so so we anticipate cervical stenosis in this case. So cervical stenosis, if we are not able to pass 1 to 2 mm diameter of the probe into the cervical cavity, usually the cervical canal, it is 5 mm diameter. So there are various risk factors for the cervical stenosis, which includes congenital, it could be congenital, or any previous cervical surgery, which could be conization, LEAP, Manchester, or DNC. So whenever we are handling such case, we have to be very careful. So Dr. Pushpa, now can you tell me how will you manage the case of this anticipated cervical stenosis?
As cervical stenosis is already anticipated because of cryosurgery, plus she never had a vaginal delivery. So that adds to the problem because she is having a scarred uterus as well. So in anticipation of this, we should be doing this by proper priming of the cervix with the use of, there are many mechanisms or many drugs. That is, one is misoprostol. It can be given sublingually 1 to 3 hours prior to the procedure, or vaginally or buccally. And I would add to this that we can give it orally also, just 15 minutes prior to the procedure. And the reason behind this is the surface area of the mucosa of the stomach, it is largest as compared to vagina or sublingual area. And the onset of action and peak action is also much earlier.
Okay, anything
so they
else?
give equally good results.
Okay.
Then other things are, we can use osmotic dilators based in cervix 6 to 24 hours. This is almost now outdated. Lamivudine, they are no more available also. Dilexine, lamivudine, we have used it. But now we can use Foley's catheter. They do the same job, that is they separate the membranes and they cause local release of
So what size
prostaglandins.
Foley's catheter will you use? Now the cervical stenosis is hardly 1 to 2 mm hardly. Or at times we are not able to negotiate anything.
Even
So-
10 mm with the artery put in the cervix, this Foley's catheter we can introduce. That means we
Anyone
can
else?
attempt. Especially with this patient, I will not attempt insertion of Foley's catheter or any osmotic
Okay, so you will
dilator.
stop at pharmacological method. Dr.
Yes.
Narendra, sir, will you contribute anything?
Anesthesia would make some difference.
Okay, that we will come to later, anesthesia part. We are just,
I'm not
let us
talking about
concentrate about the cervical.
complications of anesthesia. I am talking about dilatation part as far as anesthesia is concerned. Because the reason is, suppose patient is cooperative, paracervical block, well sedated, there may not be, still there is some resistance. But on the other way around, if you are doing it under anesthesia, then also, going easily.
Atul sir, you can sit here only, I think. You're answering from there.
Not encountering any resistance, so increases the chances.
We have to negotiate through the
Yeah, but
cervix
that-
first.
that-
Antiverted,
That
retroverted, the
issue
thing
can be
comes
very well
next.
solved. The reason is you have to do first per vaginal examination. You have to assess the direction and size of the uterus very well. But even
Whether you do ultrasound or see the patient initially, but before you attempt the dilatation, you have to do PV examination as
Sir, you want to add something? Dr. Atul sir is wanting to say something. Yes. So you can sit here only, I think.
The most important
Yeah,
part here is to visualize the internal and the external os. If it is a case of previous 2 section or previous cervical surgeries, sometimes you may not be able to put a speculum inside. The speculum will not show you the cervix. You have to do a PV, use an Alice forceps to hold posterior lip of the cervix, put 2 speculums, then you get the anterior lip of the cervix. Once you have held the cervix, put in a Foley's catheter, distend the bladder by about 200 cc. Once you distend the bladder with a good machine, you will be able to see the external and the internal os. And trust me, you can always dilate after that.
But
200 ml of saline into the bladder. Haji.
yes, sir.
And you will be able to distend it.
If the direction is corrected, definitely dilatation will occur.
200%, put 200 cc saline, put in a Foley's catheter, clamp the catheter. You will be able to see. We have done a study of 1,000 cases. We have just done a study of 1,000 cases. You can always negotiate 1 section, 2 section, 3 section, fibroid, no fibroid, you can negotiate. The last possibility you made, if you really get stuck, you will use your 1.8 millimeter scope with the 2.9 millimeter sheath, and you will get the direction. Once water flows through that canal, you will be able to dilate it.
Okay, sir has already answered everything. So I just wanted to highlight, as the Dr. Pushpa has said about the Foley's catheter. So we have to pick up the smallest Foley's catheter, that is 5 French, that corresponds to 1.5 millimeter. But at times, yeah. No, ultrasound guided you can do, but at times we are not able to negotiate even the 5 French Foleys. So at times you may do the ultrasound guided lacrimal probe, or the dilators also help. And nowadays we have the lacrimal balloon catheter also. So the size is very small, 0.5 mm to 1.2 mm. So that can be negotiated under ultrasound guidance. So that is the option. And if you are thinking that intraoperatively you can dilate the cervix with the help of a Carmen's cannula or easy grip, it is almost not possible, because the smallest size is 4 millimeters. So it will not work in the cases of cervical stenosis. So next thing, what Dr. Pushpa was talking about, laminaria tent. Okay, laminaria tent, it is obsolete. So now we have a dilapen. So the smallest size is 3 millimeters. So that can also be negotiated. And if nothing works, you should keep ready the hysteroscopy and your micro scissors and the needle electrode, what Dr. Atul has already mentioned. So then, but when you are putting the dilators, it is very important. Even the insertion of the dilator and the overnight increase in the diameter of the dilators also causes pain. So you may have to resort to the paracervical block or the NSAIDs or opioids when you are considering all these things. So now this Dr. Archana is not there. So I will ask Dr. Meenakshi now, can you tell us, do you routinely use cervical priming agent, not this particular patient, but otherwise before a surgical abortion in other case?
That depends whether the patient had a previous cesarean section or not. If there is a history of previous cesarean section, then in that case is 100% sure we will do the cervical priming with a misoprostol 400 microgram,
Okay.
either sublingual.
So you will do only in the high risk cases. What about Dr. Pratibha?
I'm using in all cases.
What is your opinion, Dr. Pushpa?
I am also using in all cases beyond 8 weeks.
Okay, Dr. Naren sir, what is your opinion?
Nothing wrong in using, provided
Yes.
patient wants to go late. Because
Okay,
it
that
will
is
take
our
3 hours,
experience.
another
Okay.
3 to 4 hours.
Okay, so this is our experience, but as far as the recommendation goes, now mechanical dilatation alone is safe in first trimester. It is not recommended. The routine cervical priming is not recommended for first trimester, and only it is helpful in the anticipated women who are having the high risk, like who had undergone the previous cervical surgeries, or they have the anticipated cervical stenosis. So it is helpful in those situations only.
Not recommended.
It is
Still,
not recommended.
It definitely reduces the
Exactly.
dose
So
of
that's
anesthesia
why I'm
exposure
telling
to
that is
anesthesia.
your experience, and what the evidence says is this. So there are so many meta-analyses, RCTs has been done, and they have proved that although there is a significant decrease in the risk of incomplete abortion rate if you're using the cervical priming, less than 1% compared to 2% if you're not using, but then the side effects are frequent, as in abdominal pain and vaginal bleeding if you're using the cervical priming methods, and also it adds to the cost, complexity, and time to abortion. But in second trimester, the routine cervical preparation before DNE, it is recommended, and the choice depends upon the gestational age and availability and the timing of procedure. And even the Cochrane meta-analysis, they have also said that cervical priming before dilatation evacuation between 14-24 weeks is if you put a overnight osmotic dilators, as in Dilapen, it provides a better cervical dilatation as compared to prostaglandins, and this decreases the procedure to time. So that is the option. So Dilapen, it can be the option in the second trimester, but in first trimester, it is not recommended. So now next case, will you consider antibiotics in all the cases in induced abortion, medical method or surgical method? Dr. Pushpa, what is your view? Sorry, Dr. Meenakshi. Yes.
regarding the antibiotics in medical methods, usually we don't prescribe antibiotics, but when there is a patient gives certain in surgical method, we always give antibiotics, but not as a prophylactic during the procedure, just one, and after that 5 days. Usually we give the antibiotics.
Dr. Narendra, same. Dr. Pushpa, what is your opinion? Will you consider antibiotics in all the cases?
No, not in medical cases. We don't intervene, so there is no need.
Dr. Pratibha, any other opinion?
No, same, yeah, medical one.
Okay, so the routine use of prophylactic antibiotics, it is not indicated. According to Ministry of Health and Family Welfare, it should be given only in the cases of presence of vaginal infection or in the nulliparous women. But if we look into the ICMR guidelines 2019, they have clearly said that induced abortion, either you are doing surgical or method, you should give the antibiotics against the chlamydia, Neisseria gonorrhea, and anaerobes. So the regime which has been recommended is same. Tab doxy with metronidazole at the time of abortion, or you can use azithro with metronidazole at the time of abortion. So these are the two guidelines. Then we come to next, what will be your choice of anesthesia now in this particular patient who has the cervical stenosis? Anesthesia, analgesia, and then you can enumerate the steps of paracervical block also.
Again, in this patient, we are anticipating that more time will be required for dilatation of cervix. Once it is dilated, then the time required for evacuation is going to be same. So in spite of giving anesthesia, whatever, whether it is general anesthesia or even saddle block, anticipating the long time it might take, still paracervical block will definitely help for the local pain that might be caused. So we use lidocaine 1% in 10 ml syringe, and there are multiple sites where we have to inject. One is at the site 12 o'clock position where we are going to hold the cervix either with falcellum or tenaculum. Then at points 2, 8, 4, and 10 o'clock position. And we have to inject 2 ml of this 1% lidocaine with 22 to 24 gauge needle. And it has to be seen that if we do not inject into any vessel. And maximum dose is 4.5 milligrams per kg or 200 to 300 milligrams. That is 20 ml of 1%, not exceed 20 ml anytime.
Okay, so any other opinion? Yes, in the cervical stenosis, definitely we have to use the general anesthesia and the paracervical block. I think there is no controversy in this.
First of all,
yes,
you have to ask patient. Suppose even if we are doing this procedure with paracervical block and giving some IV sedative, even though some of the patients might complain of pain, and then later on they may put a question that why didn't you suggested us anesthesia? So we should counsel patient about the route of anesthesia.
Yes, exactly.
There is no need of guard.
There's no need actually. It is just a 20. Yeah. Yeah. Yes. Okay. So can somebody tell the steps for MVA? Now MVA, it is a one technique which is almost phasing out. Although it is a boon in the low resource setting, and the procedure almost is similar, either you do a manual or you do a electric. The only thing is that we should know how to charge the MVA syringe. And that is very simple. You just have to depress the buttons downward and forward. And then you have to pull the plunger back until the arms, they open against the cylinder. So that is the small thing. But this technique, it is very, very useful, especially in the low resource setting, but most of us are not using. So now we go to the next.
One input that I would like to put in this, that was suggested by my student, Dr. Pranjal, she is here. When we put the plastic cannula, you have to rotate it through 360 degrees.
Yes.
So that when you're putting that negative pressure, it peels off the product.
Yeah, you have to rotate 180 degree, 360 degree anti-clockwise or clockwise. It is same as we do in the electric also. Next question, Dr. Bharti.
Very nicely, Dr. Richa has and all panelists has discussed this, and to keep the MBA always in the panel is very important. And it is not only good for low resources setting, even WHO recommend is the gold standard in every place, because it is very safe, feasible, and very cost effective also, of course. So now we come to the next, and even in COVID, most of us used this MVA, because really it causes less pain, so less analgesia and less anesthesia. So, and another case, that is a woman with retroverted uterus has an evacuation procedure, and exam suddenly you have noted that the instrument passed a little further than expected. However, you presume this is due to shape of her uterus. As she is recovering, her heart rate become rapid and her blood pressure begin to fall. You also notice that the bleeding pathology is more than expected. So what is your provisional diagnosis or you are suspecting for, and how you will manage her? Dr. Naren. Yeah.
Instruments passing a little further than expected
Mhm.
means size of the uterus, weeks of gestation, that is also important. Because then a person who is performing termination must have an idea that this size of the uterus is this weeks. That is one. Second thing, without resistance, if it is going, that is also to be clear. The third thing is which instrument has been passed, because that makes some difference as far as the management is concerned. Because the dilator has passed, you are sure that now there is perforation and some sponge holding or a home or forceps has been passed, and you are bringing something.
So cannula is passed because electric vacuum
then
aspiration
it can bring
procedure.
something down. And at the same time, that pulse has become rapid and patient blood pressure means patient is going into the shock. Means you are perforated.
So suspicion of the, of course, doctor has very clearly mentioned that pre-procedure workup is very important to even diagnose complications. You can suspect. And second thing, suspicions of uterine perforation and management. Of course, this case depicts the suspicion of perforation, but you have to confirm it. So what is the management or suspicion, further confirmation of perforation and management? Anyone? Yeah.
For the, if there is a suspicion of the perforation, you have to look whether the patient is stable or not stable. If the patient is stable, you can keep the patient under the observation, and you have to maintain the blood pressure of the patient and all the vital signs. If you have to look for whether there is a tachycardia, hypotension, and increasing pain in the abdomen. You have to look all for these symptoms. Along with that, X-ray per abdomen, plain X-ray of the abdomen has to be done. Sonography has to be done, whether there is a collection in the gutter or not, pelvis or is there or not, gas under diaphragm is there or not. You have to look for all these things. And hydration is to be maintained in the first 6 hours. If the patient is not stable, then you have to send all blood samples regarding the electrolytes and liver function test, coagulation profile and everything, along with circulation, breathing, and all things has to be maintained. And fluid should be given, ringer lactate or normal saline, and maintain the blood pressure. Blood pressure has to be maintained between 9 up to 100. And then you have to look for whether the patient is worsening or not. If she is worsening, then you have to make an preparation for the laparotomy, guarding rigidity and all distension of the abdomen. All these things is there, then you have to look for that also. And if you are in the PHCs, then you have to refer that patient for the further care management.
Dr. Naren, you want to add something?
I have come across few cases where the moment dilator has been introduced, it will come out at the entry point of uterine artery. So the way in which, it's some sort of sputter. You can recognize the way in which she is bleeding, like this, arterial bleeding. And if you do PV examination, you will find a large hematoma on the side of the uterus. And at the same time, you will ask your anesthetist, blood pressure will be 80. So in such thing, do not wait, because you are going to end up in a very serious trouble. So arterial bleeding, patient going in shock, and a large hematoma is an indication to open immediately, even without resorting, except blood transfusion and everything. Do not wait.
Yeah, you want to say something? Yeah.
Facility for the laparoscopy, you can put the scope also inside and you can check out whether the perforation, what has happened. And
so basically things depends whether patient is stable or unstable. If she is in shock, deteriorating, so you have to take decision immediately. You don't have time to do so many of investigations. So here your clinical judgment and your skill and your experience matter. So next case, dear Dr. Richa. You have to listen fast because
So now we are going to the case 4. Now this patient, she is 29 years old and now she has come with fever, tachycardia and abdominal pain since 3 years. At 9 weeks gestation, she had failed medical method and then had undergone surgical abortion. She is passing stools and urine normally. So Dr. Pratibha, what are the options after the failed medical method? Now failed medical method, basically if the person doesn't bleed after 24 hours of misoprostol intake.
So in this case, she has not bled. So first and foremost, if her ultrasound has not been done, that should be done, because sometimes it is not an intrauterine pregnancy, or you have to confirm whether it is intrauterine or extrauterine. One thing we should keep in mind. And secondly, you can do the cervical priming and then go for dilatation and evacuation for this patient.
Okay.
And she is having fever and tachycardia and abdominal pain. But actually she had had a failed medical method, and when surgical abortion has been done, maybe that time she must have had any sepsis infection, or there may be also a chance of perforation that could have been happened during dilatation.
No, she has gone failed medical method. You just have to tell what are the options. So options are quite simple. Dr. Pushpa wants to say something. So if there's a continuation of the pregnancy, we do the aspiration, and if there's a non-viable fetus or is a missed or incomplete, then we repeat the dose. Now quickly, Dr. Pushpa, what are your DDs at this particular level and how will you confirm?
Now that the infection might have set in because of this surgical abortion carried out with without asepsis, or it can be incomplete abortion which has become infected, and that is how she has come here. So it is labeled as septic abortion at this stage.
But
this might be directly during the evacuation procedure, or some other related sepsis might be pre-existing, which has become exacerbated.
Okay, so other things also we have to be keep in mind also. She may also be having a UTI or appendicitis. Okay, so whenever patient comes with such symptoms, we always have to triage the patient, and we have to understand what is sepsis and septic shock. Now sepsis, now it is defined as a life-threatening organ dysfunction caused by the dysregulated host response to infection. And organ dysfunction, it is defined as an acute increase of 2 or more points of QSOFA, that is a sequential organ failure assessment score. So quickly we can just see her mental status, whether she's having then tachypnea or hypotension. If the patient is having 2 or more than that, that means she is in frank sepsis, and we have to be very quick with that. And to see whether the patient is having a septic shock, we have to, patient will be having a persistent hypotension, which requires vasopressor to maintain the mean arterial pressure of more than 65 millimeters of mercury and the serum lactate of more than 2 millimoles per liter. So that means the patient is in septic shock. So we have to triage the patient whenever patient comes with symptoms and then treat accordingly. So now this particular patient, the ultrasound picture shows there is a 35 millimeters of a highly vascularized mass within the uterine cavity. So Dr. Meenakshi, what is your diagnosis now?
This highly vascular mass can be a retained products of conception is the diagnosis in this patient.
Okay.
And in that Gutenberg's classification, type 0, there is a no vascularity, only the hyperechoic mass. In type 1, there is a part of the vascularity seen and part of the different echos. In type 2 and type 3, vascularity is there. And in type 3, there is a endometrium is also highly vascular. This is the Gutenberg.
So we have to we have to differentiate this with GTN. That is very important. We should not suspect GTN. Now in GTN cases, usually the picture will be either hyper or hypoechoic or homogeneous or heterogeneous. As you can see the picture here, that will represent the anechoic cystic spaces. And if you put the color Doppler into that, so the vascularity will be within the myometrium and usually not in the endometrium. So that is how you differentiate. So now can you tell us quickly what drug regime will you follow for incomplete abortion? Dr. Archana is not there. So Dr. Pratibha, can you tell us?
We can go for, she's how many weeks?
She has already gone.
Yeah, so we can go for, we can go for misoprostol, and dilatation and evacuation can be done if it is not done.
Okay. So how will you manage this patient now? Her QSOFA score is 2. Dr. Pushpa, quickly the management.
She is having septic abortion, and she should be treated with that SOFA square of 2. She in fact requires ICU management with all the due investigations which are required, CBC, serum lactate, and of course ultrasonography has already been done. So she will be given high doses of antibiotics, and before that we have to take her sample for culture and sensitivity, and then put her on IV fluids And after stabilization, then we have to go ahead with the completion of abortion. There are different antibiotics regimen. Any of this we can choose and go ahead with the evacuation.
Okay, so these are the
And at the
antibiotics which
same
are
time, we have to
recommended by
treat
the ICMR. So, okay, just a last, do we have to wind up?
Yeah.
Okay. Then we'll go to the. So this is the last question. Now, this particular patient, antibiotic cover, vacuum aspiration was done. Patient is afebrile, but then tachycardia, pain, and tenderness was there in the lower abdomen. And day 2, the ultrasound showed this picture. Now, what is the probable diagnosis? It is a left teoma abscess. Yes, just finished. So, how will you manage, Dr. Pratibha?
This is teoma, so you have to examine under anesthesia, and then you can go for the broad spectrum antibiotic, and IV fluids can be started. And if you have to also go for the imaging like CT scan or MRI can be there if, to rule out just abscess or it is something else. And then accordingly, you have to treat that patient.
Okay, this is just an audience question. That's all. This is the last for the audience. Now, this patient had undergone laparoscopy. Intraoperative findings showed 30 cc of pus and left tubo-ovarian abscess. Rest of the exploration was normal. Salpingo-oophorectomy done, lavage done. During post-operative course, patient was improving. But on day 3, then she started developing palpitation, anxiety, and crying episodes. Quickly, what is the diagnosis? Audience. One word diagnosis and one word answer. Last question. Last slide. Anybody? Atul sir. Yes. So this is a post-abortion syndrome. So I'm not going through the detail, but just quickly, if I discuss everything on MTP and I don't touch about the contraception, it will not be a fair thing. So I will just ask for the audience one question. Okay. Just last. Yes, just last question I will ask the audience. So audience will have to ask within 3 seconds once I stop the question. A 24 years old, para 1 living one, known case of epilepsy on phenytoin and diabetic on insulin, HIV on ART since 2 years, has come for the temporary contraceptive advice in your OPD. What is your answer? Quick. The answer is WHO Contraception Tool app. So please download in your mobile. This is very, very easy, very handy. And I think most of you all know it, but believe me, if you are sitting in the OPD and you are very busy, you can arrive at the answer. Okay, thank you. Take no photograph. And thank you, our esteemed panelists, co-moderator and all audiences that they make this panel.
And on behalf of all the panelists, I thank Dr. Maheshwari and Dr. Geeta Sharma madam.
Thank you. So these are the yeah.
So thank you very much. And I think now in last 3 years, we have lots of literature to read on MTP. So you have, we have developed FOXY Focus. So all of you can have it and lots of FOXY MTP bulletins. Thank you very much. Now coordinator for next session.
Hello. So our next session, I would like to invite panel on contraception and critical care, the confusion. So I would like to invite our moderators for the next panel, Dr. Basav Mukherjee and Dr. Parikshit Tak. And the panelists for this panel are Dr. Asha Jain. Is she there, Dr. Asha Jain?
Panel wala na sir.
Yeah, Dr. Chirag Amin, Dr. Kruti Deliwala, Dr. Nivedita Vaja,
1 minute, sir.
Dr. Ritu Joshi, Dr. Susma Bakshi.
First.
May I please invite Dr. Atul Ganatra to join us? We are missing two panelists.
No problem. Okay, sir. 1 minute, sir. जाओ तो मैं दे देता हूँ. हाँ. एक मिनट कर दो. Thank you.
Dr. Asha Jain, Dr. Chirag Amin, Dr. Kruti Deliwala, Dr. Nivedita Datta, Dr. Ritu Joshi, Dr. Sushma Bakshi, and Dr. Atul Ganatra. Locum. Emergency contraception.
ये थोड़ा टेस्ट तेरा ही रहेगा.
So, welcome all the panelists and the delegates. It's a pleasure to be here in Ahmedabad, and really, it's wonderful to meet all the friends. It's been such a long time since we've had physical conferences. So we are supposed to conduct a panel on contraception in critical care, clearing the confusion. But first, Basav and I were confused. Why is that? Because if somebody is in critical care, do they need contraception? So first, we thought we should clear our own confusion. And we came to the, diagnosis that we should talk about medical disorders, which are potential critical care situations, and how to deal with contraception in those kind of, those kind of women. So broad overview with considerations for contraception in medical disorders. Then we'll look at some case studies. Hopefully we'll have some good take home messages and practical points for, routine day-to-day practicing clinicians. So let me start this panel by asking.
What contraception which leads you into critical care?
Yes, that could also happen. And we'll probably touch upon those aspects as we go along and the panel gets going. So let me begin with Dr. Bakshi. Ma'am, do you think contraception affects women's health in general? I mean, we are not talking about any one particular group, but in general, do you think it's important or it's all right? I mean,
it does affect, according to me, because the choice is of having a child is in her hand. So that gives and that empowers a lady. That is one. Pregnancy in quite a few cases at a particular point is unwanted or it would be risky. That is a second point. So she can choose the safety part of her health and the interval between two babies can be managed by way of contraception. So it is definitely a boon.
So there's a lot. Yes, of course.
Another thing, one is that contracepting is affecting her physical as well as mental health. And secondly is the contraception we give her may also be affecting her.
Yes, absolutely.
So
there
one
can
more
be
thing
positive
is
effects as well. So
that 50% of pregnancies are unwanted. So contraception is a very basic need. 14% of maternal deaths are attributed to abortions. So yes, so contraception is the need. There is no
Yes.
if and but about it.
Absolutely.
I mean,
There is a
basic,
major effect on the psychological health also, because when she has an unwanted pregnancy, in India, they are very much disturbed because of their even social aspects. And
but I wanted to add that there are two sides of the coin. Once again, it is beneficial also, and then we'll have to see the risk part of it also.
Of course, it has to be a balanced decision, but I think by far and large, the provision of contraception is an essential part of healthcare. I think let's put that as the cornerstone for today's discussion. And now let's move to the point about which I want to ask Dr. Deliwala. In general, care providers will generally shy away from discussing contraception in general and in women with medical disorders. Why do you think that could be? What could be the reasons for that?
Actually, in our society, the women also, they feel shy for asking the contraception to the doctors also. Healthcare providers are always ready. Sometimes we are giving the tips to the patients too, but still they feel shy. If we suggest one method to them, then if they do not want to accept that method, then they are not free to ask what is the
So there's not
alternative
much
for
of
me.
a dialogue.
Yeah.
Yeah. So I want to ask Dr. Joshi and Dr. Ganatra, in your practice, I mean, in day-to-day settings, what are the big challenges, for offering contraception, especially when women have medical disorders?
See, Parikshit, Basab, you, Atul, you were all part of that select study which we had done, if you remember that well, through Foxy, the Family Welfare Committee. And we had, two questionnaires, which was, one questionnaire in which we asked her, what does she use? And then we told her about, and in that we found out that there were a lot of women who were taking the wrong contraceptive method for that medical disorder which she was having. So we explained to her, and when she came back with the second questionnaire, we changed her contraceptive method. So, basically counseling and making her understand with her problem is something, which we all should do. And that is really a very big challenge.
I think initially in practice, about say 28 years ago, when I started practice, contraception was not chosen by the patient herself. I think the mother-in-law or the husband or the family members chose the contraception. We've come a long way from there. And I think one of the factors that is very, very important is that we need to offer them what is called as a cafeteria approach. Show them all the modalities of contraception. In fact, at our clinic, we have a poster which shows them a condom, an IUCD, a Mirena, OC pills, implant, and everything. And then discuss each option with them. If possible, give them written pamphlets. Let them understand the pros and cons of each method of contraception. And then she comes back. We are not lawyers. We don't charge by the number of minutes that we spend with our patients. But this is a moral responsibility as an Indian citizen and as a service provider.
There could be people who are taking part in the next panel who might take objection to that, But anyway, we leave it for that. Yeah. But I think what we are coming to is the point that the challenge is the counseling and the communication.
Absolutely.
I think that could be.
Care providers shy away. It is because I think most of us as care providers, we are not aware, we are so scared about the cardiovascular and the metabolic effects of a contraceptive procedure that we shy away from that. Secondly, we're probably not also scared of the litigations which could occur if we give a wrong contraceptive.
Yes.
So
yes.
that is why we are probably shying
So
away.
I think the
situation is there is a dilemma situation overall. That on one side we are telling that it's a over-the-counter medicine, and you can worldwide it is prescribed like that. That's a
Correct.
OTC product. And on the other side, recently one litigation occurred, and the person was given compensation.
A very heavy compensation.
Heavy compensation for what? For giving a oral contraceptive and having a DVT.
Correct. Correct.
So how do you?
Yeah. So that's where the hesitancy might come in, and that's where a good documentation, a good knowledge base, a very protocol based approach to the whole situation might come in useful in these kind of. So we've established the
So
need
one
for
more thing
contraception,
is-
the issues that we need to address, and the challenges that, on the side of the clients, there could be misconception, myths, their own personal beliefs. And for providers, it's not really very glamorous. The rewards and returns aren't that high. And advice is rarely, rarely appreciated. And potentially, you could look at litigations going forward.
So
So,
one more thing is that in a very busy OPD, there is usually no time.
counseling and
So
giving time.
you need
Yes,
a dedicated separate counter for that.
absolutely. So, Basav, I'm going to bring you in for discussion on the modality and.
I think, yeah, just a few things. I think we're having very interesting discussion. I think one important point is that, there are guidelines on the first prescription of OC pills. So the first prescription of OC pills, there are guidelines where they point out what all pertinent medical history and pertinent family history needs to be elicited. So I think, but again, you don't take consent for OC pills. When you're giving, you don't take consent. You verbally say that this has been discussed. Again, now, when you're giving pills for contraception, vis-a-vis when you're giving pills for AUB and PCO, now that you don't always discuss there. Now that comes into the question of why don't you discuss here? Why don't you discuss there? Ideally, you should be discussing everywhere, because it's after a pill is a pill and a DVT can be a DVT. So I think those are some things I think we don't have clear answers to, but I think it's just to bring in some more thoughts and some more dimensions to the discussion. So what we are discussing is contraceptive leading to serious medical disorders or serious medical disorders where you're using contraception. So general approach to offering a contraceptive modality, do you usually evaluate with the WHO MEC? So last presentation, Dr. Richa, in the last few slides, nicely put out the WHO MEC, which once upon a time used to be a blue wheel, which used to be given by a few companies, and sometimes UNICEF used to have them in their programs. We used to pick it up from the conference and use it. And now it's developed into an app. The last 3 years, you can download the app free from the all Google Store, app stores, and then you can put it in your phone and you can always find out what you do. Just one question about the WHO MEC. We do discuss about it. Atul just brought about the ideal cafeteria choice, which a lot of us in our clinical practice, putting our hand to our heart, do not do. We give one or two options and we leave it there. Again, due to the several reasons, Dr. Asha Jain said paucity of time, and one is of the reason. And Dr. Nivedita said sometimes you always also fear about litigation, or you may be wrong in what you're giving information when you're not sure of the information you're giving, especially in a setting of a medical disorder. Are we getting this is all thing? So WHO MEC in routine practice, if you can give us some idea, we want to hear from the panel. I think we'll start with Dr. Sushma there, and then we'll move up. WHO MEC, do we use it in routine practice, madam? How much do you use it? And do you think it is a useful tool when you're giving contraception, especially in the setting of medical diseases?
It's said that, but I have not been using it, WHO MEC, in my routine practice. I just rather depend upon my knowledge on contraceptives and the patient's general behavior.
Yep. I think that's a lot of us do that. Any other different opinions? Any other different comments? Dr. Kruti, yeah, Atul, yes, Dr.
I
Atul?
do use the MEC criteria whenever I get stuck.
Yeah, when you're stuck.
If I'm in a fix, I'm not sure as to what I should be talking, because I work in a corporate hospital and very often we have patients with multi-organ problems. And whenever I'm stuck, I definitely use the criteria, and it does solve your problems most often. Though with the kind of reading that we have done over the last few years, 99% of the time,
You know it means you
what
know it, and so you would
absolutely. So you can actually hit the nail on the head most often, but very often at Fortis, we have a very good system where we have a joint discussion with multiple faculties involved. And that is when we actually need some evidence. And that's where the MEC criteria is of great use to us.
Yeah, I think
I'll just add one more point here.
Sure.
I think for the last 25 years of my practice, Madam was talking about litigations. I mentioned in my panel, which I did in the morning, that video consultation is important. Wherever I write a hormone prescription, I have a stamp in my clinic, which is put on that paper, wherever, whatever hormone is written. It says, inform if there is nausea, vomiting, leg cramps, headache, and giddiness. My residents are not allowed to give any hormone prescription without that stamp.
So menopause hormones, infertility hormones,
Any hormone.
any hormone. Okay, yeah, now I'm
Any
just
hormone, they are
okay.
not allowed. For example, now I do IVF thanks to
No,
Parikshit.
but that's you're just taking care of the immediate side effects. Do you think that's good enough for you? That's good enough? That saves a few phone calls or what?
See, most, if you're talking about hormonal prescription, what I have said, these 5 or 6 things covers most of it. Nausea, vomiting, headache, giddiness, leg cramps. It covers most of the things. It's very, very seldom do I come across something away from that. Report to us immediately, and there is a telephone number at the end.
Sure. I think that's. So this is the app that they were showing. So WHO medical eligibility criteria, getting down a lot of app stores we know. So this is the digital tool. I'll just come to the first clinical case. I'll invite Parikshit to deal with it.
Right. So now we have some case scenarios. Yeah. So maybe this one we'll do in 7-8 minutes, and then 23-year-old unmarried girl and a boyfriend. They are in your clinic for advice about contraception. Currently, they are using nothing. I mean, just coitus interruptus. And she has a history of rheumatic heart disease. 4 years back, she had to have her mitral valve replaced, and now she has a mechanical valve. She's on warfarin. Her coagulation profile is good. Presently, she's quite fit in terms of her cardiac status, no other medications. And this couple are going to get married in a year or so, but they don't want children for the foreseeable future. You know, at least for the next few years, they aren't interested in having children. So let me come to Dr. Joshi with this first couple of questions. Would you advise this couple to rely on condoms as a means of contraception? Because, you know, this is almost a reflex for any busy gynecologist obstetrician. What should this type of a couple use? Let them use condoms. So is it fair to send them off with this advice?
Do that. I'll certainly tell them that this is one of the method, but this has a very high failure rate.
Yeah.
So as they have already been, I mean, they must be using the coitus interruptus or whatever. So failure rate is very high. So I would first and foremost, you know, she's had a mechanical valve replacement. Now there are 2 types of valve replacements. In mechanical, we have to be more careful.
Yeah.
So we have to look into that. The second, just go back to that slide. There was another point which is important over there. Is she is on warfarin. You know, she's stable though on her medical, so there's no harm in even actually giving her the oral contraceptive pills.
We'll come to that. We'll come to. My question was just to address this very common reflex tendency about just prescribing them or advising them to use. Yeah, yeah.
I just needed to ask one more question to my patient. If she is on warfarin, is her INR normal? Is her hemoglobin
low?
I mean,
good coagulation profile.
Yeah, so, because she could have heavy menstrual bleeding. No, she could have heavy menstrual bleeding.
Okay, along with as one of the other
warfarin
problems with, fine, fair enough. Let's, for the discussion at the moment, let's presume her periods are okay. Dr. Datta, what methods are category 3 or 4 for this woman? You know, the ones which you would like to really avoid or not do at all.
At the present moment, category 4, there is nothing because everything is favorable for her. However, estrogen in a higher dose, estrogen would be a category 3 thing. Otherwise, nothing is category 4 for her.
Yeah, that's one of the most common things that one would get stuck with, you know, in terms of prescription, that would she be eligible to use combined hormonal contraception, which contains estrogen or not? Dr. Jain.
Sir, I would not advise her an intrauterine device.
And intrauterine, no, combined hormonal contraception.
Combined is okay.
An OC pill which contains 30.
I don't know what methods are category 3 or 4.
Yeah. So
that is a copy that I would not advise.
You don't want to use an intrauterine device.
We'll come to that discussion.
Okay, we'll just come to that because that's an interesting take. Many people would think along those lines, but yeah, Doctor.
Low dose oral contraceptive pills can be given, or
Okay, so the
progesterone
20
only pills.
microgram pill
Yeah,
Yeah.
or the progesterone only pills could
or
be
the
given.
progesterone only.
Yeah.
Okay, so basically what we are looking at is trying to avoid or minimize the dose of estrogen. Yes, Dr. Bakshi.
Basically, in cardiac disease, our main concern is water retention, arrhythmias, and so COC will be definitely category 3, 4. I would rather avoid giving that to the couple unless her cardiac status is very much stable.
But she's
in-
got this mechanical valve, that's
So
where the concern
I
is coming
would
from.
not give
Yeah,
COC.
yeah,
That
probably,
is
yes.
what I would think.
So, this girl is complicated valvular heart disease because she's got the valve and she's on warfarin. So, according to the WHO MEC, it's probably category 4 to give her estrogens. You might want to probably avoid even low dose estrogens because of certain risks. The progesterone ones are okay. And you can think about the intrauterine device also as a possible means of providing contraception, which comes to our question of the intrauterine device. Dr. Ganatra, such experiences might be common in a multi-specialty hospital where there's a good cardiac surgery unit. What are your thoughts about an intrauterine device for a girl who's got a mechanical heart valve? Is it okay, not okay? And your experience?
Most of the patients referred to us after a valve replacement surgery who are on warfarin come to us with menorrhagia, heavy menstrual bleeding. And that is when a copper-based IUCD is ruled out, and I would be a little more partial towards using the intrauterine progesterone device.
Great. Okay.
Because most often the cardiac surgeons want to keep their INR between 2 and 2.5. They don't like the INR to go to less than 2.
Yes.
And that is why the first thing in my mind would be to use an intrauterine device. If she doesn't want the intrauterine device, if she accepts amenorrhea, I may even give her a DMP.
Fair. Perfect. So I think intrauterine devices are okay, but prefer the progesterone device over the copper device in this kind of a situation. Any precautions to be taken while insertion, long-term antibiotic prophylaxis, anything of that sort?
So now we started this by saying that this is an unmarried patient.
Yeah.
If it's an unmarried patient, I would want dual protection. I would also want the husband to use the condom because she's a rheumatic heart patient and STI is very, very common. So I would counsel the partner to say that please use a hormone, barrier contraception because she's at high risk of developing an infection. Now, obviously, we'll do our basic investigation, see that her CRP is normal, give her prophylactic antibiotics, and then insert the device.
Perfect. Perfect. Aseptic precautions, just like routine, and those things are very mandatory for every woman, and especially for her, we might consider using antibiotic prophylaxis because of the mechanical valve. Yes, absolutely. Yeah, that's true. That's true. The insertion might not be that. No. You're right. You're right. She's unmarried till now. And for the last question, I'm coming to a little future situation that she has her second baby. The child is born. Everything is fine. And now she wants to undergo a puerperal tubal ligation. So how would you approach this situation? What are your thoughts? Ma'am, let me start with you.
This is a bit tricky because I remember my teacher saying generally we most of the females undergo tube ligation because that is the choice of doctors as well as family also. But our teacher used to say that the husband should undergo vasectomy because it is less risky a procedure. But one catch over here is that the wife is having cardiac disease. Her lifespan, we do not know. If she dies and the husband has undergone vasectomy, his remarriage is a problem.
These are important considerations. Yes, of course. Fortunately, today cardiac care has improved a lot, and lifespans are pretty good. So anesthesia is also safe. So I think a lot of complexity which goes
Yes,
into this
I mean,
kind of
this
a
was-
situation.
This was 25 years back when my teacher used to say, just I mentioned it.
Yes.
But I agree that these days heart disease patients, they live longer.
They live,
So
they do live long.
tube
Yeah.
ligation can
So
be.
we
Yeah. Dr. Joshi wanted to add something.
I actually still would, I mean, knowing that anesthesia is good, this is good, we can agree to a tubal ligation, but I still believe more in counseling for long-acting reversible contraceptives.
Okay.
And
Okay.
LNG is-
So maybe a good choice for a postpartum intrauterine device insertion. Yeah. So it's a great lark. There are alternatives that we can present to the couple and then see where implants also. So yeah, lots of options are there. This is not the only thing. Any other inputs for this woman, and then Basav will go. There's another slide which. So yes, I think we already spoke about this. Why the estrogen should be avoided, because of the arterial thrombosis, and if at all you use it, then very low dose. Progesterone is okay. It's category 1, and there's no increase in the endocarditis risk. That's a good thing. That's one of the worries which is commonly there in people's minds, but actually nothing like that exists. You don't need to do long-term antibiotic prophylaxis, only at the time of insertion. Basa, please.
This was a mechanical valve which was there. But in biological valves which we've started putting now, we don't need to put them on warfarin. They will not be on that.
That's a different consideration.
I'm just ending that.
Yeah. So
After all such counseling,
yeah.
if still the patient and her partner are not willing and they are willing
Yeah.
for condom, then we can always insist on using a chemical contraceptive along with this. Nonoxynol 9 plus condom gives excellent contraception.
Fantastic.
If the
Yeah, I
combination
think-
is there, failure rate is very less.
Yeah, just talking about condoms, I think it's important to say that the last NFHS survey, 5 survey published last month, 1920, they showed the increase in of all the family planning methods. Everything has increased in use. Condoms is the maximum. It's from 5.6 to I think 8.5 or something. Everything has increased. The IUCD has increased. It's reached nearly to 1.53%. OCPs has increased. Everything has increased, but not. Condoms is the maximum. Yes.
But it has been noted that if a condom is
Even,
used,
even sterilization has increased.
Condoms are being used such a lot is because of the transvaginal sonographies that we are doing.
But see.
They does not ask whether you had a TVS. They ask whether you're using it for contraception.
No, they don't ask about it. They won't go by sales.
Just give you the condoms.
They won't go by
No,
sales.
They just go by the numbers.
No, they won't go by sales. Nivida, they won't go by sales. Okay.
asking for use.
IIPS, I think we'll have to talk to IIPS people to find out exactly what they do. But it's, I don't think it's like that. Otherwise, it'll be even much more. I don't think it's that. But definitely. But again, yeah. But again, all said and done, I think there is a group of people, irrespective of however much you counsel, will stick to condoms, will stick to emergency contraception and nothing else. So I think you need to respect everybody's choices, and whatever they do, they will have to use what they need to use. So I think that's important. We just move on to the discussion. We've got around 13 minutes left. So this is the next case which we are bringing up here. It's a 31-year-old nulliparous lady. She wants to delay childbearing for a year. She is married a couple of months. She was married, is married a couple of months ago. I think that's wrong English. She informs of an episode of DVT 10 years ago when she was prescribed medicines for PCO. Atul, we'll start with you, Dr. Atul Ganatra. So this is possibly the medicine you're talking about is a hormone, and possibly we're talking about an estrogen. We don't know, but possibly that's very likely. But she describes it exactly the way a DVT would be described. So that's what the situation is. So past history of DVT, let's put it there. A woman who wants contraception, at least for a year, what are the birth control methods you can offer?
So here, first of all, I would investigate her for why DVT. She's probably a very good statement by my mentor, Dr. Shariar. All pills are safe, some women are dangerous. This is comes into a dangerous category of woman. She needs to be investigated why she had the DVT. Maybe she has thrombophilia.
So you'll do the thrombophilia screening, putting it very simply.
Absolutely.
So that would be include just if you, for the audience, if you want to just line up what are those, that's protein C, protein S, anti-thrombo,
IgG, IgM, ANA, and lupus.
and lupus. I think that would be the full, I think they have packages of the entire thing. So you've done that and it's shown it's normal. And how do you go from there?
I would still ask her to, if possible, to undergo intrauterine device insertion.
Yeah,
That would be
so-
my first choice.
So estrogen is in a way out, right? Mane, I think most of us would agree with that point that estrogen is out. What about progesterone? Is progesterone out also? Previous
I would-
DVT?
Intrauterine device, progesterone, I don't think there is a problem in that.
Yeah. Progesterones are okay, but only the, like you have to gulp the thing about irregular unscheduled bleeding, for which a lot of women are not happy. So as long
Because
as
she already has PCOS, as
she-
you mentioned.
yeah, she already has
She already
PCOS.
has irregular cycles.
So,
Will probably
so,
worsen it.
so that's another thing. I think those are the discussion points which most of us would bring up. Anything else? So here there's a chart again, the WHO, we're looking at this from the estrogen point of view. If it's a history of DVT or PE and acute DVT or PE, it's a no. And also DVT-P and established on anticoagulant therapy, that's not the best choice. And also the other risk factors of VTE in general have been all listed out here. But if it's a progesterone only method, except for acute VTE, you may be considering it. But otherwise, it's of course, it's IUCDs are all safe
I
and
would
very
also
safe.
want to know whether she's a lean PCO or an obese PCO. What is her BMI? And those
How
are
would
factors.
that influence your things? Like if
Her
you,
menstrual pattern will probably be understood by that. That's about all, nothing else.
Again, if she's an obese PCO, still it would.
okay.
I think the first choice is always going to be intrauterine devices.
Any other thoughts from the panel? Any other difficult? I think most of us do agree with what we said. Just moving on, another case on the same lines. She is a 35-year-old para-2 living to previous 2 sections, wants to birth control for spacing. She doesn't want to have a operative procedure, so she wants to have some spacing. She's got a BMI of 34 and hypertensive and dyslipidemia on medication. She's got a family history of cardiovascular disease. She's 35 years old. What are the birth control methods? Dr. Ritu, can we start with you? Then we'll go to Dr. Nivedita, Dr. Asha here.
Use the method birth control for spacing.
Yeah.
You're
Spacing me, okay, limiting. I think limiting. But again, you keep it open, nah? You don't know what will, how you'll think later. So limiting spacing, okay, means you don't know. Like,
her BMI is 34.
so we're trying to make up a case where she's a high risk thing.
And so I wouldn't give her any contraceptive pills. First and foremost, I'll counsel her for a husband's vasectomy.
Okay, but if you think the family is complete, if the family is complete, that's a way to go forward. That would be one logical way of discussion.
Contraceptive device would be far better in her case than to take her up or even doing her surgery.
Again, we're moving on to intrauterine contraceptive device, hormonal, non-hormonal. Any thoughts? LNG, are you? Non-hormonal. Non-hormonal. The LNG, little bit that's released from the uterines, you would be concerned with that in this sort of a setting. I don't know, that's debatable, but I think
It can means see it can be given. It is category 2,
yeah.
but the one is property.
No, not our choice, her choice. I think. I think yeah, we'll have to put that. I think that's a nice way of putting it. Yeah. Yes, Atul.
The first choice is a copper IUD.
Okay.
You can also put in an LNG IUS or a mini pill and barrier contraception.
Barrier will of course
or
be there.
the implants, whatever. I mean, the progesterone only things you can give, which is category 2 in her case.
Yes, Atul, you want to make a point? Yes, Dr.
So
Atul.
IUCD 0.1, IUCD 0.1 on the other side, vasectomy. If they don't agree to both, I'll go ahead and do a lap PL on this.
So you start with your chart and then you start crossing off a few things on your chart.
I'll do a lap
Your
PL on
chart
her
in your
if
clinic, it's there. So something.
She just
so,
wants spacing. She doesn't want
So the
Not
cafeteria,
spacing, obviously.
doesn't have a few things in the list. The cafeteria for her has got less things on the shelf.
No, if she's spacing, obviously IUCD and
Okay. Yeah, I'm just pulling the leg. Yeah. Dr. Chirag, yes. Dr. Kruti, Dr. Shushma, yes.
With dyslipidemia, one thing we need to avoid is DMPA injection.
Okay.
That is category.
Yes, DMPA would not be a good choice to use. So here, so we're just bringing in some cases of multiple risk factors for cardiovascular disease. whenever a woman is on the heavier side, a lot of us are a little hesitant to use hormonal contraception and estrogen, sometimes for very good reason. So multiple risk factors for arterial cardiovascular disease would include older age, smoking, diabetes, hypertension. And again, if the weight is more than 30 kg per meter squared BMI, then again, there are increased risks with using estrogen, but again, not as great a risk, but at the same time, we need to be concerned because there may be other factors together. So they have to be put into picture together. Same for hypertension. We are seeing here that if she is a hypertensive, then you need to know what level of control the blood pressure is. If it is under good control, then also you see it's a category 3 for estrogen containing pills. If it's without control, then obviously it's not a choice. Progestogen is reasonably okay. And then of course, the rest of the things. I will just give over to Praksha.
I think we are coming towards the end of the panel, and I think we share mentors probably. So as they say, most contraceptives are safe, but some women are dangerous, and we need to be on the lookout for such risk factors, which either can be modified or the choices can be modified, and we can still provide contraception to most women in an effective and yeah, sure. So before we go, I would like all the panelists to share 1 or 2 take-home points, in terms of contraceptive practice.
In critical care.
Yeah, in terms of medical disorders. Don't land up with critical care.
Remember what Richa said, everything in MTP was critical care in MTP. So we are
Follow proper contraception, you won't end up in a critical condition.
Yeah,
Increasing the
absolutely.
mortality of the country.
I think it's counseling. You need to counsel. You need to document, you need to counsel, spend enough time with your patients. I've had 11 patients of DVT and arterial thrombosis with CNS thrombosis, with OC pills. One of them was my own resident who was on the ventilator for 11 days.
just 1 point, Atul, like when usually there's a thought that if a woman with OCPs has a DVT or a PE, it usually happens in the first few weeks or
Not necessary. Not necessary. That is what is by the book.
That's why I'm asking you.
By the book, they say yes, they have in the first 3 or 4 months they will have a problem. But I've had a patient who came to us with cavernous sinus thrombosis in the 6th year. 6th year of OC pill, and the only thing that saved me was my stamp. She was lost to follow up, and I told her.
The stamp was for the side effects, you said. Okay,
Yeah, but she had headache.
Okay.
So medically,
she neglected.
So
But-
documentation that's your
Is the
documentation,
key.
because documentation is not usually done as a standard.
No,
Means you do have a verbal discussion, but you don't document.
there
it.
is no, in the court of law,
I understand that, but
there is no this to verbal discussion.
Yeah, I know that, but the point taken. But how many people take a consent for giving OC pills or
No, we don't take consent technically, but
yeah, that should be all informed. Dr. Chirag.
yeah, one point I wanted to highlight was that many general practitioners sometimes opine and tell the patients or relatives that you have taken it for 1 year or 2 years. So you stop in between and then again restart. So we need to highlight them from the beginning that the risk of DVT will go on reducing over a period of time. No doubt it can happen anytime, but it will definitely go on reducing. First duration is more important, where there is high chance of DVT. And if you stop it and again start it, the risk will again start as usual. So the risk is equivalent as you are starting for the first time. So that is one point. Second thing, there were some reports which were telling that drosperinon, if given beyond 40 years of age, would have more incidence of DVT rather than levonorgestrel, which has not been substantiated much over a period of time. But most dangerous combination I would put is 35 plus and smoking. If smoking is a history, I would avoid giving OC pills to that patient. We don't even ask sometimes that whether you are smoking or not. We assume that women are not smoking.
Yeah, that's very correct.
Just about 2.5 years back, just before the lockdown, we were going to do a IVF and oocyte donation ICSI on one of our patients who was 41 years of age. And I had given her simple estradiol valrate, proguanil as 2 milligrams, and she had nausea and vomiting, and she and obviously we write an antiemetic on all our prescriptions of hormones. And she didn't come to us in the first 48 hours. And by day 4, her headache became so severe that she had projectile vomiting. And then luck would have it, it struck me that this is not right. She was due for a transfer in the next 4 days, and she had a cavernous sinus thrombosis. I think Parishita discussed that case with you.
Yes, I remember.
I still remember the patient also.
Some points from your end. Yeah,
Dr. Jain and then.
So what I would like to say is,
Take-home points, yeah.
one take-home message is that we need to be cautious about writing hormones. We are gynecologists. We write them right and left. But breast cancer is on the rise. Breast cancer is on the rise. And after one episode in my family who had OC pills for dysfunctional bleeding for 4 years in her life, and we lost her to metastatic breast cancer, I would still say be careful, have your breast scans and prescribe the lowest dose of hormone for the minimum time required. Use an alternative method. We have a whole bouquet. You don't have to go on giving hormones for 10 years, 20 years, because these days people don't want children.
I think everything is the benefit risk ratio. I think that has to be always taken into consideration, but there's no blanket.
No, sir. What I'm saying is that the cancer was a metastatic breast cancer with nothing in the breast and all bones involved. And it was a bone biopsy that said it is ERPR strong positive. No genetic predisposition.
No, I think
Actually,
point
sir,
taken
we
that
don't know. We
these
don't
things
really
can,
ask.
yeah, these things can
don't
happen,
ask.
but that should not deter us from offering the routine,
Yeah, but sir,
choices.
they have to come on time for follow-ups.
Yes, absolutely.
And whatever follow-up is required, whatever
point taken.
checkups are required has to be
I
done.
think the take-home message for me from this panel has been the refreshing change, what I'm hearing of offering intrauterine devices to nulli gravidas. So I think this is a shift which has happened in the thinking over a period of time that I've been attending conferences, because at one point, it was almost taboo to talk about intrauterine devices for nulli gravidas. And today we are really looking at these methods as a premier choice. So I think that was the take home from me. Sorry.
Yeah, I think in low risk group, we can prescribe contraceptives with ACE, but in medical disorders and critical conditions, one has to give enough time to patients and think themselves before prescribing.
Absolutely. So I think we would like to thank the panelists for all their inputs, and on behalf of Basab and myself, thanks to gender bias. Only the women will use contraception. Yeah, that's very true too.
I think that will be another discussion another day. It's not critical care, I guess, but it's a critical discussion. I think it's a critical discussion.
So our thanks to Dr. Alpesh Gandhi and the whole team for putting this conference together and inviting us. Thank you very much.
Happy. आज चला होनी चाहिए आप ही दो एज आउट आप ही दो
નહીં પણ એના વિશે છે જ નહીં કોઈ છે એટલે પછી હું આવી ગયો હા પણ છે નહીં ને કોઈ એટલે મેં સમય ના બગાડીએ આપણે હોય તો બોલાવી લો આમ તો કોઈ અમારે જરૂર નથી ये स्लाइड कर दूं so coordinators are busy with some other duty so we are we are here only so may I please request Dr. Gitendra Sharma to join Dr. Gitendra Sharma and myself Dr. MC Patel we will moderating a panel and so ના રે નહીં અમારે તો બે લોકમ પણ જોઈશે હમણાં ગ્રીટ નહીં કોઈ વાંધો નહીં બધા લીજેન્ડ જ છે અહીંયા so greetings from Statue of Unity and we all are proud of that statue it is tallest statue of world warm welcome all the delegates and wishing you a litigation free practice. At the outset, I would like to thank organizers and Dr. Alpesh Gandhi in particular, inviting Dr. Gitendra Sharma and myself to moderate this panel. Medico-legal litigation issues in critical care in obstetric, carrier, nightmare is the title. So may I please invite a learned panelist, Dr. Ajay Mane from Aurangabad. Dr. Dilip Walke from Pune. Hemant Bhatt, Jariwala, Manish, Nikhil Datar, and Dr. Sanjay Gupte. નથી શાયદ મનીષ નથી હેમંત નથી જરીવાલા નથી दो लोकम चाहिए एक नरेंद्र गज्जर will do yes our pleasure to come no problem TK Shah
as an expert sir
अरे हमें एक लोकम चाहिए Dr. Ajay Mane from Aurangabad, past sexual committee of Foxy chairperson. Dr. Dilip Walke, past chairperson, ethics and medical legal committee Foxy. Dr. Sanjay Gupte, past president Foxy. Dr. Nikhil Datar, good medical legal expert from Mumbai. And Narendra Gajjar, president Navsari, very senior gynecologist and very useful persons in district of Navsari as far as any medical legal problems are concerned. He is always there to guide our friends. Which are the areas for litigation? A very simple question and any panelist can take. in our day-to-day practice, obstetric, gynec, we are dealing in our practice, day-to-day practice. We take utmost care of our patient, and many a times accident may happen, something goes wrong, and we are end up into any kind of litigation. So, which are the areas where we can be trapped into litigation?
आपने हमारे पेशेंट का केयर बराबर नहीं लिया.
बराबर.
So now we are, since we are into a critical care conference, so whenever we are managing a critically ill patient and there is a mishap is the basic reason why there is litigation. So today maybe we'll only restrict to mishaps occurring in our practice. But these are the.
This is just to summarize which are the area. Then we will.
When it comes to
specifically,
consent, when it comes to protocols of management, when it comes to mishap, there are n number of things. And for any reason, patient can go
yes,
against.
Yes, Sanjay Gupta sir.
Simply anything that any interaction with the patient about which the patient is unhappy can lead to litigation.
Yes.
It's a simple thing.
And as such, there is no definition of happiness. When somebody is happy, when he will be not happy. And yes, yes, Nikhil.
I think it's a risk that we are taking as a professional. So every patient is a potential litigant.
Yes.
And unless we keep that in our mind, we won't be able to take care of our own selves. I'm not necessarily trying to say that that's why one should be scared while practicing, but there is a fair bit of tension that needs to be there in the mind, because unless and until that happens, otherwise people will be very complacent and they will land up into traps.
So in past, when this National Malaria Control Program came, there was very common dictum. Each and every fever should be taken as a case of malaria unless prove otherwise. As each and every patient is potential litigant unless proved otherwise. Yes, Narendra Gajjar.
Dissatisfaction on the part of the patient, maybe because of any reason.
Yes. So again there is a vague term, dissatisfaction. How to define? So if we summarize very quickly like this: delayed in diagnosis, investigation or treatment, wrong diagnosis, no consent taken, staff not qualified, infrastructure issues, unnecessary investigations, emergency services not up to mark, communication failure, delayed in transfer, major congenital anomaly, and if you have missed, complications, morbidity either maternal or fetal, mortality either maternal or fetal, and overcharging. So these are the area anywhere you can be trapped as far as litigation is concerned. Let us see, this is real case happened in city of Ahmedabad, and any of you might be knowing this gynecologist also. It was case of lower segment cesarean section, bilateral uterine artery tear during cesarean section. Patient was RH negative, blood was not ready, cross match was not done. During shifting patient to municipal medical hospital, patient expired on the way. Notice was served, case was filed. Defense on part of doctor was she had advised elective cesarean section, but patient and relative refused. Patient and relative left the hospital. After 3 days, they came in emergency. She tried to manage blood, but as it was RH negative, so she couldn't manage blood, and ultimately what happened is a history. Inference held by the court was like this: postmortem examination showed intra-abdominal hemorrhage following negligent surgical procedure, no blood kept ready, medical record not to be believed. Why? Report of gynecologist and anesthesiologist was contradictory. Because in report of gynecology, she wrote that vitals were within normal limit, and anesthesiologist wrote that vitals were compromised. So these were the inference held by the court, and ultimately compensation of worth rupees 2.35 lakhs in 1997. At that time, this amount was very big amount, was awarded in favor of relative of patient. So where thing went wrong in this particular case, we will discuss one by one. Say for example, patient and relative refused. When she was advised elective cesarean section, patient and relative were not ready to give consent for the same, and they left the hospital. Again, they came after 3 days in an emergency. So what is inference, or what is your expert comment in this type of situation? How we should be vigilant enough not to end up into litigation for this ground?
First of all, it should have to be, if patient refuses, it should be recorded. There is something called as, consent of sort of refusal note also. So you have to explain it to the patient. We have the consequences of the refusal, and you have to mention on the paper that all these consequences are told to the patient, and in spite of that, the patient has refused. Then after that, the doctor can't do anything about it.
So would you like to go for negative consent?
Yes.
Yes. And if patient or relative refuses for negative consent also, then what to do?
Then you have to note it down. You have to get a witness to say, anybody who is available, maybe other patient, that I have told this to the patient, and patient is not ready to listen, and patient is not ready
So
to sign
any
also.
co-patient or any visitor of the hospital, so he may write like this: before me, it was explained to the patient and relative, and they refuses for consent and even for negative consent also. Yes, Nikhil, anything to add?
I think corroboration in terms of record keeping, that's between the anesthesiologist and the gynecologist, probably is very crucial, because in this kind of a scenario, the opposite party and the judges are only going to pick up points from what you have supplied to them. Now, if you have not supplied things correctly, then you are keeping the door open for them to pick up points and then kind of, decide against you. So I think that's very important, that contemporaneous and corroborative records need to be created from amongst all the team members in that particular hospital.
Yes. Nay, I am coming to that. Once they have refused to go for consent, they left the hospital. And again, when they had been to hospital in an emergency, can you take that ground? We had advised elective cesarean section and they had refused. Once you accept in an emergency. Jitendra, you can also give your comment, expert comment.
See, once you are even in an emergency, if you accepted, you can't take that ground.
Yes. Once you accept to treat, then that ground you cannot take. That I had advised already, they had refused. Because once you accept, you are under obligation to treat. Yes. Yes, Nikhil.
I will just like to highlight one specific point. Now, see, life-saving conditions you can't refuse, whatever
Agreed.
the case may be.
Yes.
Emergency and life-saving situations need not be the same. So if it's not a life-saving condition, then I would go ahead and document on the paper that this is what is the patient's condition. There is a corroborative evidence that patient is not in a life-threatening kind of a condition or a scenario, and that's why I do not have the infrastructure to take care of this patient, and that's why I'm refusing to take care of this patient. That's point number one. Second question that I want to really highlight, and that's a challenge that we are going to face down the line. I mean, so far we have not had any such kind of a scenario. But when you are trying to take a negative consent from the patient and patient says, sorry, I'm not going to sign, I'm just going to be non-cooperative, I'm just going to walk away. And when you are involving some third party, ideally it should be an inert third party, but then the issue of confidentiality may come into picture, that you have violated the confidentiality of the patient. Okay. So these are few gray areas which we do not know how the law is going to evolve. But one thing is for sure, that there needs to be created a constant effort to highlight these points in front of the bureaucrats, in front of the courts, that if you do this way, you are in fault. If you do that way, again, you are in fault. Okay. So you can't have that kind of a mechanism going on. That is not the way by which people can continue to practice in their small boroughs called nursing homes or clinics or hospitals or so on and so forth. So these issues need to be highlighted in front of people.
Sir, basically, whatever you have said is perfect. That may amount to breach of confidentiality. But let us understand the case decided by the Supreme Court. That was the Common Cause Action Group versus Union of India. And in that case, it is specifically mentioned that no right is exclusive. No right is completely your right, and right to confidentiality is a right, but there are definite restriction on it. So if doctor is in the situation of in such situation where patient is not ready to give refusal consent, then definitely doctor can take help of independent witness and take signature. There is.
Not trying to, if it's misunderstood that I'm trying to say that I am contravening what Gupta sir said, that's not what is the intention. I will also
Possibility.
want to involve a third party, forget whatever the consequences are about confidentiality, but I will first safeguard my own self. So I will want a third party to consent or to be a witness. So I am in complete agreement with Gupta sir as well as what you said. There is no doubt about that. I'm just highlighting a possible area which needs to be streamlined, because this particular, the correct sentence from the judgment that you are quoting, it is the contour of the right that needs to be defined. That is the Honorable Supreme Court has said, but this has not yet been defined. It is only said that it should be defined. And that's why these areas need to be highlighted.
The importance
Yes.
of documentation,
Yes, sir,
one recent case I'll tell you, there was a deep transverse arrest, the induction, everything. It was difficult to take out the baby. And so the gynecologist tried her best, tried to take out the baby, but baby came out with zero Apgar. That baby was managed by the neonatologist, but there wasn't some 25-30 minutes ventilation and all was required, and then the heart came up, and it was decided that this baby is going to have severe problems. Yes, this thing. The other party, the patient was actually, both of the couple was doctors. They told the neonatologist, if this is going to be the situation, that we don't want that baby to be given oxygen or resuscitation, and so that was left. But after some time, when the family came, they changed their view and then said, no, now we want the resuscitation. And now the baby has suffered and they have gone against the doctor for 9 crores case. The thing is, all this episode is not documented anywhere. So now the court is saying, now you thought of it later on, now you're putting it in. So, what is the proof?
Yes.
So documentation of all these issues is very, very important.
Yes. Narendra Gajjar wanted to.
I just wanted to ask, just to give a new dimension to this, is it really important that you take a consent, a written consent by a bystander? Supposing in this particular case that Dr. MC Patel was asking, if I had written myself that the patient refused to give a refusal of consent, and that's it, is it necessary that I always take a written consent from a bystander? Will the court not accept whatever
The
I have
court will
written?
definitely
Because
accept, but it will be more authenticated if it is signed by
you say that
independent
that will be
witness.
for abundant caution that you take somebody else's signature.
Don't use
However,
that word.
if I just write it on the paper, it should be enough.
See, in medical legal field, this abundant word was introduced by Dr. Dilip Balke.
Now she is your
We have had a lot of fights on
she is your registered
while we were
patient.
having all this panel discussion on this topic. But that's the reason why I'm deviating from abundant
Yes.
caution. And I'm
So-
asking you, if I write that, is it not enough?
If you write, it should be accepted.
So,
But- But
She is
when-
your
when
registered
there is a
case.
case, you are also one of the party. So if it is authenticated by third person, then it will be more
valuable.
Sometimes
The
what
most
happens, it
important,
is-
sir, one Bridge Candy Hospital's case, you all know Amri Hospital's case of Kunal Shah. So in that, whatever doctor had documented in Bridge Candy Hospital, everything was believed by court. And Bridge Candy Hospital and Dr. Udwadia was only saved because of good documentation. He was removed even as a party by the opposite party, by the complainant. Because if Bridge Candy would have been put as a party, then decision would have gone against them. So what Udwadia doctor has documented, that patient Anuradha Shah's husband himself is a surgeon. He is continuously interfering in the treatment. He is asking me to give this treatment, but according to me, this is not required at all. And there may be side effect. Same way, another treatment advised by the brother of Kunal Shah, who is also surgeon from some USA, and he came with certain medicines with him, and he was asking to give that medicine. So he documented that although this medicine is not required, but there is no side effect of these medicines. That's why I am considering their request. So everything is to be documented, and whatever you will document will be believed, 100% believed, sir. But particularly in such cases of refusal of surgery, where patient may land up in a complication for which we are answerable, it is always advisable that if independent witness should sign, it will become more authenticated. Moreover, even above that, we always advise that even one of your colleague you should call, and in the presence of your colleague, you should explain everything to the patient. And two gynecologists, if possible, can document the same thing, that we explain the patient such things.
Thank you, Jitendra,
so
for
that is-
accepting abundant caution for once at least.
Now trying to refer this
Yeah,
patient
yes,
to somewhere else.
yes.
Means you do not want to accept this patient. So that also reason should be recorded, because in the emergency, I am not able to manage this negative blood. And that is why, in the interest of the patient, I am referring her to such and such place.
But in this
The blood group is not done, no, previously.
in this condition, after 3 days, Dr. Gajjar, after three days, patient had been again to that gynecologist only, and she went for cesarean section. Then this happened.
But blood group was not done previously.
Yes.
It was shown
No,
like
it was
that.
done. It was done. But basically that negative blood was not available in city. Advertisement in different newspaper, news channels on radio and everything was given to get negative blood, but it was not available at all in the city. But whether he should have taken in advance or confirmed the availability of negative blood group, and if negative blood is not available in the city, then he should have shifted that patient to general hospital in advance. Yes.
Yes. So again, the same question which we discussed, should this type of cases should be managed in small nursing home when it is a case of RH negative?
I am so happy today you accepted that you should do grouping and cross matching for every patient that comes in labor.
We are
This is
coming
the
to
first time, I mean, I must put it on record. This is the first time that Jitendra Sharma has accepted that grouping and cross matching for every patient in labor is a good idea.
So again, the same question,
At least for negative blood group.
so in this type of situation, can one refuse to treat?
Yes. If it is not life-threatening condition,
Yes. One more, very simple question. Can one select patient, not for this patient, in general, can one select patient whether to treat, whether not to treat?
But Dr. MC Patel, your selection criteria cannot be on creed, on caste, religion, and things like that. So when we say that we can select patient, we cannot select on these aspects. Select patient meaning in terms of the patient's
On medical grounds,
condition.
we are talking of medical
grounds. Yeah, you can refuse a particular thing because you are not in a position to manage. You are not expert enough to manage that. But if you start selecting patients on other things, then it will be a problem.
So
Now-
can we, yes, sir.
MC, I will ask a question to all of you experts that now this patient has been coming, forget the refusal part of it, coming for 9 months to a particular doctor. And she finds that last minute that negative blood, which otherwise would have been available, is not available, one thing. Or, she just doesn't want to accept that patient for whatever reason. Can she refuse the patient who has been coming to her for 9 months? Somebody
Sir,
is coming to
definitely
you
yes.
for 9 months.
Definitely yes. Because if negative group is not available,
Okay,
that is not
okay,
in the
now-
hand of a
No,
gynecologist.
but always this is the question asked. Okay, somebody is coming to me for 9 months. For some reason, our wavelength don't, match. And I decide, now I don't want to accept that patient. Can you do that?
Yes, definitely you can do it, sir.
Is it anywhere documented?
So you have to document the reasonable reason why you are refusing. Suppose some patient is registered at your place, continuously coming for 8 months. But at the end of 8 months, husband comes with the patient and he behaves with you very badly. So document that thing, that this is the reason I am not going to take this patient now on.
What
So
about-
if you have reasonable reason, you can definitely stop your treatment in between.
Agreed.
But if patient is admitted then by putting the reason, you can try to transfer that patient, but you cannot stop the treatment for indoor patient. It is ethics only. In our guideline MCI, it is clearly mentioned that you can stop
Now
treatment
then-
by giving reasonable reason.
You remember the case which went against senior person like Dr. B.N. Chakravarti. So what do you think was your interpretation of that case? You can mention that case to people.
So basically, we don't believe in case laws much. The reason is that case laws are individual case, fact-based case. And the decision of case comes on many other reasons. How you have represented, what points you have put properly or not, what is the mood of judge, okay, whether judge is always against the doctor. So these kind of things come into play, okay. Even advocates also, what they put. I will give you one example. The case of Dr. B. Ramesh, okay, in Bangalore. In his case, what happened? Patient died on table while doing hysteroscopy. Now, the senior most lawyer represented his case, Dr. Jogarao. You all know, yeah, in Ahmedabad also he came multiple times and talked about criminal liability. Now, in that case, what happened? Representation was done separately, differently by him. First question was asked, sir, what you were doing? Why patient died? He said, patient died while doing hysteroscopy, patient died of pulmonary embolism. The second question came, sir, pulmonary embolism is a known complication. The answer came, textbook references by doctor was given. So he told that, okay, yes, it is a known complication written in this textbook. It is a known complication. Third thing they asked that, what is the treatment of pulmonary embolism then? So he said that in pulmonary embolism, we have to give positive pressure ventilation. So patient has to be put on ventilator. Okay. So the fourth question came that, did you keep ventilator ready before doing hysteroscopy? Because this is a known complication you are telling. And case was decided against him. Now, in appeal, the same thing was represented differently by different advocate. The answer was, sir, patient died of pulmonary embolism. This is a known complication, but this is a very rare complication. In every delivery, there are chances of amniotic fluid embolism. That doesn't mean that we cannot deliver patient without keeping ventilator ready. So if you will represent in this way, the judgment will come differently. One of our presidential candidate multiple times, Dr. From Calcutta, okay, near Calcutta, Tamara Mitra. So in his case, the case was decided in one court in Calcutta. They said that for obstetric hysterectomy, doctor was held negligent. On table PPH occurred and he did hysterectomy without consent on table to save the life of the patient. But that case was decided against him. Now, can we give example that this was a correct judgment? Because his case was not put properly. So judgment comes according to your representation, according to your documentation. See, multiple times doctors say that we did this, that, but when we go to the document, nothing is written in that document. So there are multiple reasons. So that's why we don't believe in case laws much.
Correct. What you're saying is absolutely
unless
right.
it is ratio.
Right.
So
what Dr.
in
Gupte was trying
Chakravarti's
to
case,
ask
there is
was-
no such ratio. That was the case decided on facts. So something decided on fact cannot be become precedence. But if
Dr.
it is a
Gitendra-
ratio decided,
fine.
then it can
Fine.
become precedence.
Dr. Gitendra, what you're saying is absolutely right about case laws, some cases not being represented properly. But what Dr. Gupte was trying to ask, and he wants that clarity from every one of us, is once we take up some patient for antenatal care, does it mean that we have taken up the responsibility of delivering her also? Which
Sir,
means-
in that case
Yeah,
also,
that's
in
what the
Chakravarti sir's
discussion-
case, he had not documented the reason why he had refused at a particular time. So if you will document it properly, then the case will become different.
Even if you have taken somebody for antenatal care, you can at some point of time, giving proper reasons which are documented, refuse that the treatment of that patient too.
So in this regard, in Parliament, this question was asked on 12th of August 2014, and then Union Health Minister Harshvardhan has given this answer that in case of emergency, a physician must treat the patient and no physician shall arbitrarily refuse treatment to a patient except here word except is very important, where the patient is suffering from an ailment that is not within the range of experience of treating physician. So you should prove this. And one more thing he has also mentioned, that required to stabilize the emergency medical condition of any individual who comes or is brought to such clinical establishment, and then only you can refer the patient. But again, here to stabilize. So how to define what is stabilization of patient? So again, it is a matter of a great discussion. But this was discussed in Parliament that day. So golden arrow treatment was given due weightage, that you should treat emergency patient and then only you should refer patient. But many times what happens, if you are giving emergency treatment, you have made up your mind to refer this patient to higher center after stabilization of patient. But many times it may happen during your treatment, primary treatment or emergency treatment, patient expire. And there could be allegation, why you wasted important time at your hospital when you were not competent enough to deal with the situation. So this is also a very important area, proper counseling. If at all you are giving emergency treatment, but at that point of time, you should explain to the relative, I am giving only emergency treatment. If patient is little better, we will ship this patient any other higher center for further intensive care. If at all something goes wrong, please do not blame me. This kind of counseling may be helpful in future in court
Dr.
of
MC
law.
Patel, if
Yes,
you allow
yes, sir.
me, because
Yes, sir.
Dr. Nikhil, yourself and myself, we have worked extensively with inputs from Dr. Gupte on the consent. And
Yes, yes.
when we talk about consent, it is not just about consent for some surgery. We have also advised from level of Foxy about taking consents for vaginal delivery also. I mean,
Yes.
that's where it matters.
That
And
we
in that
are going to
consent,
discuss.
we have mentioned all this. So I think if Nikhil, you can just.
Nikhil, we are going to discuss that separately. So let us finish this case first. It is there in our further discussion. So so who will decide where patient is to be transferred? Say for example, you have decided in emergency that this patient is to be transferred somewhere higher center for intensive care. Who will decide? Patient, relative, treating doctor, or who will decide?
You have to advise them. Ultimately, they have to decide.
Yes. So you can give option, and they are the final judge where they want to take this patient to. But
the nearest higher center of patient's relative's choice, the next would be the nearest higher center. If the patient say, "आप ही decide करो," then the nearest higher center जहाँ आपके contacts हो, और उसके next there would be any government hospital.
So would you like to call responsible person where you are referring the patient? Because many times what happens, if you are thinking that this patient may need ventilator or immediate operation or any other intensive care, and when patient reaches there, ventilator is not available, operation theater is not available, so it may be some more point. So would you like to inquire about rather before
prior inquiry must be done primarily on phone. And if see what happens, the patient goes there and the bed is not vacant, they refuse the patient, then the time is wasted. That's why prior inquiry is must.
Yes.
Have a phone call and just record it that we have
Realize
inquired.
the patient.
So
Even
ultimately,
you may call for the vehicle. You may inform the hospital where you are going to refer. You will intimate the hospital with a proper reference sheet, including everything in detail, whatever the treatment has been given, and document the condition of the patient while you are referring, along with the time. And if possible, ask somebody, especially a doctor, to accompany the patient.
So ultimately, most of the cases later on, once you refer the case, recently there was a case from Ahmedabad only. One doctor referred patient in emergency hysteroscopy, again pulmonary embolism on table, and patient was referred to Apollo Hospital from Shahibag area. And that patient later on was given 5 lakhs rupees bill, and patient died in Apollo Hospital. Now that patient argued in the court of law that why didn't you send me in the civil hospital which was nearby within 2 minutes range? So the why you sent me to Apollo Hospital where I spent 5 lakhs rupees? So you have to pay 5 lakhs rupees on my behalf. So it is always better idea to take transfer consent. That is known as transfer consent, in which you have to mention the condition of the patient, the reason of transfer, the alternatives given to the patient. They let them decide, and if they want your help in deciding, then you can advise them that better facilities are available in these hospitals, so it is better to shift and in these hospitals. So that kind of transfer consent should be taken, and that is also there in our, I think, book.
That's what I was. MC Patel will say that question is coming later on. But
Yes,
transfer
let us
consent is
discuss.
also
No,
one
no
thing that
problem.
we have mentioned in that consent. What
So,
Nikhil might
as far
have-
as escort of patient is concerned, Dr. Narendra Gajjar has already mentioned, and transfer document, which you mentioned, whatever treatment you have given at your place, all the documents should be given to the patient at the time of transfer. And this is the long list Nikhil, Dilip, and myself have prepared how to deal with the patient when you are transferring.
And
the patient.
let me share a
All the
secret.
detail.
All this that I drafted
Yes.
was all copied from
Yes.
Gupte Hospital.
Yes.
Gupte Hospital का transfer consent मैंने देखा और
yes.
वो मैंने यहाँ पे डाल दिया.
So we, all the three, and of course, Gupta sir, we discussed a lot as far as this part is concerned, and it is available on Foxy website also. So I do not want to go into detail. And it is the checklist at the time of transfer, which kind of documents you will have to give to the patient. And it is very important thing, preserve transfer notes of patient transferred to the higher center. So one more area in that particular case, that following negligent surgical procedure was the inference held by the court, because in PM examination, in that particular case which we started, post-mortem examination, intra-abdominal hemorrhage following negligent surgical procedure. So can person doing post-mortem examination comment like this, it was negligent surgical procedure, and can we challenge this?
We can challenge this.
Yes, forensic medicine expert is not a person to decide what is negligence and what is not.
They should only
He is not
find
supposed to
findings
opine
are-
in that way. He can write that there was tear.
finding-
Uterine artery. This much was the tear, 2 centimeter or 3 centimeter. This much was the blood, but he cannot opine that whether surgeon is a negligent or not. So that is not the area.
I will just like to enlighten or highlight here. Now, typically what is happening in most of the places, probably not in big cities, that there are MBBS doctors, not even MD forensic doctors. They are conducting postmortem examinations. Okay.
Only MBBS person are conducting
Only
postmortem in
MBBS.
government setup.
Yes,
Only
correct.
MBBS.
Now, excepting big cities. Now, in Mumbai, probably we have MD forensic people conducting, but generally at all other places, the minimum requirement at PHC level is supposed to be MBBS doctor. That's number one. Secondly, by law, post-mortem doctors are also supposed to follow ICD coding in terms of giving cause of death. Now, obviously, there is no ICD coding called negligent surgery or negligent treatment. Okay, so definitely one can challenge that. And third and most important thing is that there are good number of forensic doctors who need to be seriously enlightened about this fact that there is something called as DIC. So people who are going to die because of DIC are bound to bleed everywhere, not only in abdominal cavity, but everywhere. That's a part and parcel of DIC. That has got nothing to do with negligent surgery. So these things probably can be avoided in certain cases by highlighting or enlightening them beforehand through organizations.
So, sir, a sad part of this case was of Dr. Kalyani practicing in Wadaj area in Ahmedabad only. And sad part is before even awarded, this compensation was awarded in 1997. She left to US, closed the practice completely. So that was the sad part. Now let us come a few quick questions. On CS found that there is a big ovarian cyst. Will you remove it?
You have
In no circumstances you will remove?
Diagnosed well in advance, that is one. Whether the counseling has been done properly or not, whether consent for the removal of this cyst has been taken or not, whether this cyst is likely to cause immediate problem after surgery, that is also to be decided. Suppose there is a torsion of the ovary and which has not been diagnosed well in advance. So in that case, you are justified to remove. So depends.
So if it is immediate danger to life of patient, then only you can remove. Otherwise, prior consent is very much required.
Now, a male child of 3.9 kg delivered vaginally. There was shoulder dystocia.
Jitendra, if you allow me,
yes,
the previous case,
yes.
in good old days, sir, when we were practicing, if there was such a case where we are doing a cesarean and there was a big ovarian cyst, what we used to do, sir, PK Shah sir, apan kudla tari, we used to call some relative inside और उनको दिखाते थे देखो इतना बड़ा cyst है निकालेंगे तो अच्छा होगा, and we used to remove it. In good faith, we used to do that. Now the medical legal experts have started saying you just cannot do it. Now, can we find some way out in between? I mean, again, Dr. MC Patel and Dr. Nikhil Datar, we have done, we have literally spent a lot of our time to discuss this, and we came to some conclusion. I think Nikhil, you would be able to answer that.
So, I think I will give a very brief gist of what work has Foxy done actually under the guidance of Dr. Gupta, and we three of us have contributed. Now, so far, our journey as consent taking begins, okay, from one standard format, which is not surgery specific format, that everything under the sun has been explained to me. What has been explained, God alone knows. Nobody knows exactly. Yeah. Then slowly and steadily we graduated to something which is called as surgery specific consents, and Gitendra and Hitesh came up with a book and all that kind of thing. Still, there were some legal, ethical lacunae that were there. So that is why Foxy joined up with a legal institute, Maharashtra National Law University, which is one of the prominent national law universities in this country. And we did a joint project. In this project, we appointed a committee of 6 legal luminaries, right from the National Consumer Forum's judge to Lokayukta, to Vice Chancellor of one of the national law universities, to the president and chairman of the most large consumer organization in this country, that is Mumbai Grahak Panchayat. And this committee actually vetted the whole process of consent taking, ideal consent taking, looking at ethics, morality, law, practicality, so on and so forth. And now we have these consents freely available on Foxy's websites. So you can go ahead, download those consents and use those consents. Now, what different we have done in this consent is, consents are divided, the whole process is divided into 2 parts. One is part 1, that is about giving information to the patient. Part 2 is about patient's declaration that I have understood A, B, C, D, X, Y, Z, etc., and I'm giving the consent. Now, part 1 is basically curated by medical people, vetted by legal people. And we have thought about all these things, how much to inform, how much is fair to inform, in which language to inform, what should be the wording, what should be the manner, how can we ensure that we don't end up scaring
Nikhil sir, can
patients
you
in this, so on and so forth.
do it brief because time is running.
Sorry. And so this is available. Now this transfer thing, consent, that is available. Now this issue as to how do you deal with such scenarios, okay, ovarian cyst kind of thing. So we have ultimately kind of concluded on this issue that if the patient has given an authority of consent taking or consent giving to somebody else before the surgery, only then that another person can give the consent and the unplanned surgery can be taken care of during the procedure of surgery. Otherwise, only life-saving surgeries can be done without the patient's consent. If it's not a life-saving surgery, then you have to defer it. Whether it is in the best interest of the patient, cost saving, whatever the case may be, you have to defer it. You have to do it later on.
So I will go very fast to a few questions. Can you do CS on demand? Suppose patient is having only 32 weeks pregnancy and she was treated for infertility. Now she is apprehensive कि मेरे को जल्दी बच्चा चाहिए हाथ में, जल्दी बच्चा चाहिए. And she has come to you at 32, 33 weeks pregnancy that please do CS. I do not want to wait. So at what time you will do CS on demand?
39.
So at 38, whenever patient will demand, you will entertain that demand?
Yes, I will.
Okay. So what indication you will write?
On demand.
Okay. So that indication is there in standard textbook? because court decides on this according to standard textbook or journals, something
There is-
written in your.
Again, my documentation will help me. While I take a consent, the reason that the patient demanded, that's why I did a cesarean. I will document all my counseling that I did with her to explain her that it will be better that we try for a vaginal delivery, and all that I'll document.
Yes.
After having done that, despite this counseling, patient has opted for a cesarean section. Itna main likh dunga and then I'll do.
And
So-
and the president of American Association of OBGYN and Gynecologists, in his presidential address, which is available on internet, has recognized the right of the woman to decide her mode of delivery.
Yes. So,
So
ethics
that
has
can come
four
for your head.
principles. The first principle is the principle of autonomy. Every individual has a right to decide what she wants to do and what she doesn't want to. Second is non-malfeasance. Means you cannot do something which will cause harm to the patient, even on demand. So here it will harm 32 weeks, but at 38 weeks, there is no harm. So non-malfeasance. Then beneficence, something is in benefit of the patient. And last is, it should be justified. Okay, so these are the four principles of ethics, and we are following in doing CS on demand this principle. Now, patient admitted in emergency with irritable uterus at term, diagnosed as accidental hemorrhage, CS done. On CS, retroplacental clots were removed. Now, post-operation, BP never came up and patient died after 6 to 8 hours of surgery in ward. Will you give cause of death? Anybody?
I am well within my right to give a cause of death in this certificate, in this case. However, again, for abundant caution again, the reason is, if supposing this goes in a litigation, there is a possibility that I am going to be considered as one of the accused. So that is the reason why I will first of all call police, because let the police come and decide whether there is anything suspicious in this case. To the police also, I'm going to say, I know the cause of death. If you say I can give a cause of death, but if the police wants to take this body for a medico-legal PM.
So if police says, then you will give.
No, not one thing is whether this body is to be sent for a medico-legal PM or not. The onus is on the police and not on me. I am not the person who's supposed to decide.
But
whether
police
she
will do
deserves-
only if you will advise. Police will do only if you will not give cause of death and advise post-mortem for
Why
deciding
the
the
police
cause of
might
death.
even send the body for a medico-legal PM despite the fact that
That's
I am
okay.
ready to give a cause of
Yeah,
death. So it's up to the police.
Yes.
It's not up to me. While I am saying this, that I have a right to give a cause of death in this case, as much as possible off the record, I will try to instigate this police to take the body for medico-legal PM. Reason is that in the court of law, the cause of death given by the PM surgeon is going to be accepted more than the cause of death given by me, because I am one of the accused. However, while we are doing this, while will the experts say that always the case has to go for a medico-legal PM, we have to understand that we have got the right to give a cause of death, even in this case, even if it is a maternal case, because even if there is going to be a maternal death review, the death review is not to find out whether we were negligent or not. Even in that case, I have a right to give the cause of death in this.
Anybody else wants to comment?
Well, this used to be my view long back, that we should do that in every case, but maybe after the years of experience, the things I'm thinking differently. If you can talk to the patient's relative and convince them better, you have, first of all, you have to have a good cause, definitely. And naturally, first thing that the relatives don't want is they don't want PM. They say कि चलो patient तो
Sir,
वही
sir,
है अभी.
एक मिनट आपको interfere करूं?
Sure.
एक one.
Sure.
What, who will, you will consider, who are the relatives? Suppose husband is there, mother-in-law is there, father-in-law is there.
No.
Are
even
they
the-
relatives?
No, even the wives, people will have to be there.
Maternal side.
That is very important, because with husband consent, if you give, you are in, can be in trouble. But basically, remember that you have to have a provable, proper, documented cause. That has to be the ground rule. If you don't have that, then you don't have a choice. But if you have that, then you may, because, again, difficult to say on the dais, but doing PM and then facing further issues with PM are tremendously bad.
The moment I sent that such type of patient to PM, I got a phone call from PM person that there is something we are going to find out something from this patient.
Are you offering something?
Yeah.
Sir,
So
why
I
we are
said that
discussing?
before PM, how are you going to find out?
Sir, why we are discussing this case? Because BP never came up post-operatively. Okay. And even on multiple USG, uterus was well contracted. There was nothing inside uterus. There was nothing around uterus in the peritoneal cavity. Okay. So now, will you consider that cause of death may be something different from accidental
This answer
hemorrhage?
can be given off the dais.
So as such
Of the
discussion
dais,
about-
I would give a cause.
Yes, Dilip, discuss out. You were very much sure of diagnosis of accidental hemorrhage. You also documented weak retroplacental clots, but BP never came up post-operative. That was the one area for immediate attention. So
Now, in this case,
would you go for giving cause of death and not amounting to advice for postmortem examination, or would you like to advise?
It has to be a defendable cause of death. In this case, there is no defendable cause of death.
so basically, in this case, the abundantly cautioned gynecologist gave the cause of death as an accidental hemorrhage. Later on, when body was taken up, already taken by the relatives, husband and all, police person, the relatives from the side of lady filed case in police that we have apprehension that she might have been harassed by their in-laws, and police went for PM. Even cause of death was given as an accidental hemorrhage, but police decided, considering foul play, decided to go for PM, and PM there was a big liver tear. That was the reason, and it was found that she was bitten by her husband at home. So, sir, there are multiple things, and that is the reason. See, no book says that if death occurs within 24 hours of admission, then you must go for PM. There is nothing like that. But still, why books suggest to go for PM? Because within 24 hours of admission, you cannot assess everything. Multiple cases like this: severe preeclampsia, patient developed eclamptic fit, diagnosed as eclampsia, died in the hospital. Doctor gave that this is eclampsia, and later on it turned out to be a poisoning case. So that's why we always advise that whenever there is death within 24 hours of the admission, it is for abundant caution. It is advisable to advise
Jitendra,
postmortem and not.
Jitendra, just as you said, no, case laws are not something that you have to go follow that. So one anecdotal case from your side which says that the doctor gave a death certificate and he was in trouble. I can quote at least 20 in Pune for the last 10 years, at least 20 such cases where the doctor gave a death certificate and nothing happened. So you have to judge the situation as Dr. Gupta said.
Sir,
If it is a defendable cause of death, then you can give it.
Sir, actually, my experience is different, because most of the doctors who are giving cause of death, the burden of proof in the court of law is on the head of the doctor to prove that whatever you have written is perfect. You have to prove it in the court of law. While if you will advise postmortem, then postmortem report will come, and you have all the right to counter that postmortem report later on in the court of law. So you have double benefit. One, that your burden on the head is gone, and second, whatever opinion forensic medicine expert gives you, you can, if you have good reason to counter it, you can counter it in the court of law. So there are double benefits for this.
Let's conclude by saying judge the situation, and
ultimately that is there.
Yes, Gajjar, I wanted to add
Yes.
something.
This liver tear would have been diagnosed in cesarean section. That is one. And second thing, you have to ready to tolerate the things which press will write on the next day. Nothing wrong will happen, but press people will write the moment PM is done. They will make a story on the next day.
सर, इंडिया में लोगों की मेमोरी बहुत कम है. Don't ever disturb yourself by media people. They will print for 1 day, 2 day. After 7 days, it will be a dust in the dustbin. So media से कभी डरो मत. Patient died on table due to PPH. relatives refusing for post-mortem. You know the cause of death again, sir. That patient has died of PPH. Okay. What you will do? Will you give cause of death or no? On table.
On table. PPH.
On CS. You are 100% sure that patient has died of
I'm not
PPH.
answering, but I'm asking. Is it not possible that in a case of PPH, I give the cause of death as multi-organ failure because of severe hypotension, because of postpartum, because of atonic postpartum hemorrhage? Now, my question to all the medical legal experts here, if somebody dies of PPH, atonic PPH, am I not within my right to say that the patient died because of multi-organ failure, because of severe hypotension, because of atonic postpartum hemorrhage, and give a cause of death in this case? Gupta sir, what's your opinion?
According to me, if you've done everything that was required and documented to save her, then you can give a.
Sir, I will tell you. Whenever something happens in the four wall, on table, in operation theater, okay, that is a ratio decided in multiple cases. When something happens where the relatives have no access in the four wall, then everything you have to prove in the court of law. Burden of proof is shifted on you. So in the court of law, everything will be on your head. And if something will be proved against you, you can be held liable for the same.
Gitendra sir, then I just want to ask you one thing. Tomorrow, if a cardiac surgeon is operating on an open heart surgery and there is death on table, do you mean every cardiac surgery ASA grade 4 should be sent for postmortem? No. So
Sir,
every death that is occurring
sir,
because
cardiac
of
surgery, there they mentioned that there is a 70% or 50% risk of on-table death when you apprehend something in advance. But here in delivery and cesarean, you cannot say that
exactly where we have
50% or
failed.
70% may die on table.
That's
So in here, that abundant caution will
Gitendra,
come.
that's exactly where we have failed. When we are communicating with a, tomorrow if I come from a newspaper and I tell you, Gitendra, write an article, you're going to write about the biggest ovarian cyst you removed, the most difficult case you operated, but you're not never going to write about those PPH patients who died in my practice. You're never going to write about the amniotic fluid embolism case who died in my practice. This is where we have failed. So if we start doing that, tomorrow people are, even the judges are going to accept here in a given case, somebody can die because of postpartum hemorrhage.
Okay.
So the
Sir,
fault is with us, not with
sir,
the court. Exactly. And that's where I think Foxy can, in the years to
now,
come, can do that.
Why we have put this type of cases?
No,
in
in
this
sir, in
case,
today's,
again, doctor gave PPH as a reason of cause of death because it was the right of doctor and doctor wrote PPH. Okay. Now, in that case, later on, again, relative filed case that doctor gave this decision, cause of death, gave the cause of death to hide his negligence because one of my relative was in the OT who is working in the hospital, doctor staff. And he was telling that doctor did surgery negligently and both side uterine was cut by the doctor and there was severe bleeding due to the negligent surgery by the doctor. Now, considering that post-mortem was done again by the police and ultimately doctor was held negligent in this case. And it was held that doctor tried to conceal his own misdeeds by giving cause of death and not allowing for post-mortem. So see, we are not giving something bad messages, but we want to give message that whenever you are in situation and you feel that even there is 1% of chance, but when burden comes on your head, don't take that burden. Advise post-mortem. You will have two benefits. एक तो आपके सिर पे burden नहीं रहेगा. Second, you will have chance to counter forensic medicine report. So what is the hurry and what is the need of giving cause of death and keep putting ourselves in a problem? Now, if you will advise post-mortem and suppose police person says that no, not required, they may do that. They may say that we don't think that there is any foul play and with the request of the relative, they may refuse going for PM. That is then the burden will be shifted on the head of the police to prove that there is no foul play. Yes. So why to take burden on our head? That is our message.
But one constructive step I'll tell all of you, and this is the time has come, what you're asking rightly. If you have a patient who is going to come to you and going to deliver with you around 30-32 weeks, there has to be a proper counseling session. We call it a counseling session. We got 10, 12 points of this counseling session. What, my doctor colleagues, I told them that they are supposed to sit with the patient for at least, not only patients and patients so-called, decision-making relatives, then mother's side or father's side, or 3, 4, whatever wants to come, and discuss all the possibilities and discuss that there is something called as PPH, discuss there is something called as preeclampsia and eclampsia, discuss last minute there can be true knot in cord and baby can die. So all these have to be discussed with them at 30, 32 weeks, recorded, all these possibilities have been discussed with us. If they have any questions, write down, we have asked whatever questions that we wanted to ask, documented, doctor signature, relative signature, keep that record with you, so that half the time, when PPH occurs, patients relative know that you have been told that this can happen. The sudden fetal distress occurs, they know that you have been told that this can happen. So all that, because we keep on telling till 9 months, everything is fine and she will deliver normally. And then we tell, no, now it's emergency and cesarean has to be done. Naturally, they are going to refuse. So this positive step has to be taken.
So with a very live panel and discussion, let us conclude.
Nikhil was just saying that is where the natural labor consent is going to work. Because natural labor consent talks about everything, right from PPH to amniotic fluid embolism, even to shoulder dystocia.
So we had booked this case, but due to paucity of time, we skipped. Consent for normal labor, is it mandatory? Consent for episiotomy and perineal tear repair. Consent in trial labor. Consent for instrumental delivery, whose, when. So the same consent we have included in our uniform consent.
We discussed enough. I think let people read that consent. We have actually devised that consent and is there on the Foxy website. Please read it and give your opinion. I mean, we do not claim that the information part that we have devised is the end of all. I mean, there may be some lacunae. And I think if you people give us some inputs on that, we will revise it and we'll try to make it better than what it is now.
Sir, basically, everything is perfectly done. There is no issue, no discussion. But our opinion is a little bit different. We always opine that consent is to be taken for some surgery or for some treatment which you are going to do. Okay. Now, normal labor, can you arrest it? Can you stop it? You have to conduct. So whether patient gives consent or not, that is not the issue. And second thing, sir, I am coming to that. I am coming to that, sir. Second issue, counseling. Sir, consent, you must understand. In India, we are following real and valid consent, not informed consent. Informed consent says that you have to inform these things to the patient, and that should be kept on paper. That is followed in America. In America, patient never signs consent with doctor. Doctor and patient never signs the same consent paper. They sign separate. Doctor says that I have informed everything to the patient. They provide different links and textbook references to the patient, and they give time to the patient to read these things at home. And once they come, then only patient gives the consent that I have read everything. Now I have enough information regarding this particular thing. Now I am ready for this. Okay. So that is the job in America. While we are following real and valid consent. In Samira Kohli versus Dr. Prabha Manchanda's case, Supreme Court 3-judge bench categorically has mentioned that we are not following informed consent. We are following real and valid consent. And real and valid consent means consent is to be considered as contract in between doctor and patient. And 4 things are to be followed. Consent of competent party. Consent should be free. Consent should be for the legal object. And 4th, adequate information should be passed on that paper to the patient. And 6 things are to be included in adequate information. Purpose of treatment, alternatives available, success rate, then procedure, what we are going to do, risk and risk of not under. Now, risk of not undergoing treatment. Can you explain it in normal labor? So risk of normal labor. So that is counseling. Definitely, it is a good idea to counsel the patient. Sir, we always tell that our friends that you should have counseling session for 9 months.
Exactly.
And you have to explain to the patient that even shoulder dystocia, which is a rare complication, can happen. And you can have one session
Jitendra
of
sir, can I just simply summarize what Gupte sir said, what you agreed, that counseling, there is no other alternative
Yes.
but to have counseling.
Yes.
That everybody agrees to.
But that is not
Now,
consent.
Hold on. Now, if that counseling has a framework, that what all points need to be counseled about, do you have any objection? Does Dr.
Then you can take
Sir
only
Gupte-
patient's consent.
Nobody. So
on
now,
that patient
so
signature
now
on that.
part one, that is information. I don't think anybody has any objection to that. Now, suppose if you do not want to formalize that, you just simply document that this pamphlet or information has been handed over to the patient.
Sir,
And
the
patient says that I have read that information.
Sir, basic thing
Even
is
that
here you
enough.
are not doing anything on the patient. Normal
I
labor, can you
understand.
stop normal labor?
I
No.
completely understand,
Whether
sir.
patient gives consent or not, can you stop
I
normal
understand.
labor?
I completely understand. That is exactly why we had put this question to 6 legal luminaries and even Justice Kantikar. Okay,
He gave
who
the
is in
judgment
the
of
national-
RG Store
I know
versus
that.
Vinod Khanna.
Ultimately, he is
And he
sitting
did the
judge.
same mistake.
Ultimately,
He
he's-
used the word in that judgment informed consent everywhere
See-
rather than using real
See,
and valid
sir,
consent.
See, no two professionals can agree on one point. That's a part and parcel of being a professional. But the truth of fact is, he is the sitting judge, and besides him, practically every other judge, they agreed on this fact that whether you want to formalize or no, but counseling is a must, even if it's
we
a
don't
natural
disagree.
process.
We don't
Counseling
disagree
is
for
a must.
counseling.
So we are just providing a particular framework for counseling. That's the
That's
end of the
okay.
story.
If
Now,
it is
suppose
counseling,
somebody-
then it is okay. But it
Absolutely.
can- yes, yes.
Absolutely.
Very good. I mean, first time I am seeing that two lawyers are agreeing to something. So thank you very much, Gitendra, and thank you very much,
Yes,
Nikhil, that you at least at the end of our panel discussion
So-
agreed on some point.
So can we conclude that it is simple counseling for normal labor, because we never know, it may end up into any kind of tear. It could be a complete perineal tear and you have to repair, you have to go for further surgery also. And if you go for counseling on that particular time of point of time, it will be little difficult. So beforehand, if you have counsel, there are possibility. It may happen, it may not happen. Then it would be much easier for you to face that consequences in future. That is why consent is to be taken.
No, sir,
Consent means
I wanted to say one sentence.
we had been counsel, we had been explained. It is not like a permission. Because Jitendra said you cannot stop delivery. So that is yes Ajay.
The lawyers do not want a particular word. This lawyer doesn't want the word consent. This lawyer wants to do the counseling. So person like me will conclude counsel and document the counsel.
Yes, exactly.
Now, how to document the counsel is what Nikhil
And
has told.
what Gitendra discussed, real and valid consent. Informed consent is a part of that valid and real consent. So in India, we should go like this. So
I just wanted to
yes,
say
yes,
one
very quickly.
one sentence.
Yes.
What we are doing as of today is for the sake of justice in the court of law. It
Yes,
goes
yes.
because they are non-medical persons. They don't understand anything what we are dealing with. That's why we are taking this again abundant caution.
So we are running short of time, and there is one more panel after this. So let us conclude within 2 minutes. Yes, madam. Yes.
Mobile pictures of the patient having PPH. Any picture taken of the patient, the confidentiality issue will come out unless you have taken her consent and she is not in a position to give consent. She is already having postpartum hemorrhage. I wouldn't advise to do that. That's the reason why in the consent, what we have done is before even she gave a consent for a cesarean, she's already mentioned that in case while doing the cesarean section, you find something which for which you would feel to be tackled in good faith, I appoint my husband or my father or my uncle to give consent on my behalf. And we were not too sure whether the legal luminaries will accept that. To our surprise, everybody that he mentioned, everyone, all legal luminaries accepted that this can be done beforehand. So that's the reason why in the good old days, we used to call the relative inside. And
So, Dilip and Nikhil, so it is a kind of power of attorney? Yeah.
No. Then don't do. Then do not do. Yeah.
So,
Yeah, exactly.
Yes. All the learned panelists, let us.
The medical legal experts were all these days telling us, just don't touch. Now we are telling you, you can take a consent before.
Let us conclude only 1 minute. Only one word from each panelist with carry on, starting from Ajay. Only one line.
Proper counseling must be done beforehand.
Yes, Dilip.
Good no. Be good friends of Dr. Gitendra Sharma also and Dr. Nikhil Akhtar also, because you need both sides of the story.
What you need is actual proper communication with the patient and documentation of everything. These two things, if you follow, you won't face any problem.
Patients' rights, doctors' responsibilities, and doctors' rights and patient responsibilities all have to come together. Only then can we make practice easy, simple, practical, and manageable.
Yes, Dr. Vijay.
Good record is a good defense. Poor record is a poor defense. And most of the time what happens is that no record.
Sir, marvelous.
Means no defense.
See, we are here to give you knowledge. There is no intention to make you fear of practice. We are here to give you proper knowledge of law so that you can do fear-free practice. So don't keep any fear in your mind while practicing, because something which you have done with good intention in a proper manner, you can never be held negligent. And the word used by Markande Kazu in M. D'Souza versus Muhammad Ishfaq, that law is a watchdog, not a bloodhound. So if you are reasonably careful, no law can touch you. Okay. So be fear-free, be diligent in your practice. Do whatever standard things are there in your standard textbook or in journals, or which is practiced by your peer group, or which is taught to you by your teachers. So if you will follow these things, then you will never be in any problem. So don't worry of any medical legal case.
So, योग करे या ना करे, किंतु एक दूसरों का सहयोग जरूर करें. सत्य परेशान हो सकता है, लेकिन पराजित नहीं. And it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in little doubt. So God bless you and have a litigation-free medical practice. All the best. And with regards, thank you very much. Yes.
Okay.
And please do not assume, please ask question, but after this panel.
Okay.
And
on behalf of, okay, finish.
And big round of applause for all these learned panelists to make this panel very live and interesting.
Yeah, on behalf of all the panelists, I am the junior most. Sanjay Gupta sir, student, my student too. So I am the junior most. On behalf of all of us, I must convey my gratitude to Alpesh Bhai, organizing committee, Patel sir, Gitendra sir, auditors, and all the audience. Thank you very much.
When his email or his WhatsApp messages come to you for his vice president election, please vote for this guy.
And may I invite panel? So may I invite Dr. Anju and Dr. Saijas to conduct panel further? Yes. Yes, group photo. And then Anju and Saijas can take it. आपका कोई क्वेश्चन था?
मार ही खाएगा तो अभी
दिखाने के लिए कॉपरेट मत करो, दिखाओ चलो बाहर निकलो
दिखा के बाहर अरे कि नहीं उसके में खड़ा नहीं रखना
हम लोग बोलते बोलते
मैं माइक लेती हूँ मेरी फोटो अरे कर लो ऑनलाइन भी चल रहा है ना इट इज हाइब्रिड यू डोंट नो कोई देख रहा होगा चलो क्यों बेइज्जती कर रहे हैं वही तो है कि हमें पकड़ दे रहा है
लीजिए
नो शैतानी ऑनलाइन भी हो रहा है ना लेट्स अज्यूम कि कोई देख रहा होगा हाँ 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 कितना पॉजिटिव थॉट है बेस्ट प्राइज फॉर पॉजिटिव थॉट गो टू डॉक्टर आशा भैया ले आओ इस पे ले आओ चलो 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 आओ 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 प्लीज ये भैया हमारे जरा फोटो खींच लेना जब हमारे हाथ में माइक मुझे कॉलर माइक दे सकते हो क्या प्लीज बेटा कॉलर माइक दे दे बेटा प्लीज मेरा फोन ले लो और मेरे को कॉलर माइक दे दो एक मिनट बेटा मैं पहले फिक्स तो कर लूं फिर क्या करेगा म्यूट है एक मिनट कैसे आएगा ये आ जाएगा इसमें Shit, I hurt myself. ये आप रख लो मेरी फोटो खींच देना जरा सी प्लीज बस पासवर्ड जो थी कैमरा ऊपर जाता है इसको लगा दे बेटा पीछे
हाथ में पकड़ के रखेगा
अरे नहीं कम डाल देना यहाँ पे इस जगह पे लगा देना बेटा मेरा हाथ खराब है नहीं तो कोई बोलती है मैं खुद ही लगाती हूँ इसमें लगा दे बेटा खोल के यहाँ पे
आप लगा दो ना
लगाते बेटा कोई फर्क नहीं पड़ता ये नहीं लगा
उस मैडम को बोलो ना वो लगा दो
आजा मैडम मेरा ये लगा दे जरा कॉलर माइक प्लीज हाँ अच्छा अच्छा अरे ऐसे ऐसे
कहाँ पे लगाना है
ये भी बैठ गया बताओ।
मैं थक गया है बेचारा।
हाँ ना। बाकी तो मैं हूँ पागल जैसे।
मैम आपको तो मानना पड़ेगा, मतलब आप लोग broken,
नहीं नहीं
बाप भी आपका।
नहीं पर मैं ऐसे भाग भाग जाएगी 5 बजे बहन होने वाली 5 बजे भागो भागो भागो। चलो let's start. So good evening everyone, and we are really thankful to Dr. Alpesh Gandhi and the whole organizing team for giving us the opportunity of this very important and very important topic, which is which we come across in day-to-day practice. And I'm very happy that I have my co-moderator, Dr. Shajush. He is also a very learned person known in Foxy. And I have a very learned panelist with me. I would request all of you to introduce yourself, please.
Hello everyone, myself Dr. Apur Kumar Datta. I am National Coordinator Public Awareness Sexual Medicine Committee, Foxy.
I am Dr. Dolly Mehra, past President Ratlam OBGYN Association.
Hi, I am Dr. Riddhi Shukla. I am gynecologist and recently concentrating more on cosmetic gynecology and sexual health from the city of Ahmedabad itself.
Hello, I am Dr. Anuja Bhalerao and I am a professor and HOD at NKP Salve Institute, Nagpur.
Hello everyone, I am Dr. Kanchan Prasad and currently I am a North Zone Coordinator for Foxy Clinical Research Committee. Thank you.
So welcome all of you. We all know that, when we talk of pregnancy, it affects the woman in a different way, and all pregnant women are at increased risk of acquiring infections. This is a question we are going to answer. And with infection, there is definitely an increase of risk, severe disease. So this will also come in coming few slides. And we all know that there are various factors like severe mechanical pathophysiological changes, which lead to decrease in respiratory volume and urinary stasis. And also there is immune adaptation. So infections in pregnancy can lead to spontaneous abortion, preterm labor, perinatal death, abnormal growth, and fetal abnormalities, which are many like chorioretinitis, hydromicrocephaly, cerebral calcification, etc. And there are many risk factors, which could be multiple sexual partners, especially in last 2 or more years. And if there is a recent partner change in past 3 months and non-use of barrier protection, STI in the partner and other STI, and younger age, of course, less than 25 years. So when a patient comes to us with a history of lumps, bumps, ulcers, rash, itching, and lower abdominal pain dyspareunia, sudden and distinct change in the discharge, we must look into the past history, where there is history of again sexual partners and risk of factors for blood-borne diseases, and patient could be from a area which has got high prevalence of HIV and also IV drug use. So when we talk of STIs, we must know before testing what is the incubation period of those diseases, because if we test those patients before the incubation period, we may get false negative results. And we all know that for bacterial STIs, the incubation is 10 to 14 days. And for HIV and syphilis, it could be beyond 3 months. So my first question is to Dr. Dolly. Dr. Dolly Mehra, would you please put some light on gonococcal infections? What is its effect on pregnancy, neonate, cervical or vaginal swab? Do they have any kind of role? Or what antibiotics should be given? And is there any role of partner treatment?
See, gonococcal infection is caused by Neisseria gonorrhoeae, as we all know. And as you mentioned, that there is a specific group which is affected by these sort of infections during pregnancy, those who are single, adolescent, those who don't undergo a prenatal or the antenatal care, proper antenatal care, drug abusers, women who are into prostitution, women with multiple sexual partners. Now, how do we need to check? We need to basically test the discharge. More commonly, the cervical discharge has to be checked in these cases. And in this particular case, we need to have a gram staining. And we also can undergo the diplococci culture. In gram staining, this will be oxidase positive and gram negative diplococci, because you have to rule out, you have to differentiate from the normal diplococci present in the vagina. And this is treated by antibiotics like ceftriaxone, cefixime, spectinomycin, and it is very commonly associated with chlamydia. So you need to treat the chlamydial infection also associated with this with azithromycin.
Very well said, but I would like to here add that we must look into the symptoms. Of
I never
anything.
mentioned the effect on during pregnancy.
Yes.
So it can cause basically septic abortions. It can cause premature preterm delivery, premature rupture of membranes. Can also be can also happen with this. The neonate can be affected with conjunctiva and ophthalmia neonatorum.
Yeah, and there could be some scalp abscess also, and there it can give, if the infection is very severe, it can give to disseminated infections in the baby. So we must have a sense of great,
suspicion in these
cases. So you have very well covered the disseminated infections, and diagnosis you have already covered. So I'm not touching this. Treatment you have already covered. Now, would you please tell us about syphilis? So what is its effect on pregnancy? What are the symptoms? What is the how do you do diagnosis, and what is the treatment? And is there something like congenital syphilis? And what are the controversies when we talk of syphilis per se?
So I'll take the first and the last question together. We have to remember that the incubation period of syphilis is from 9 to almost 90 days approximately. And hence the controversy is that when we check these patients, we do a routine serum VDRL testing. And this VDRL testing can be positive in these patients who have malaria or who have chickenpox or measles or connective tissue disorders. And hence, this has to be confirmed by further testing. So, and those tests will come positive only 2 to 5 weeks after the infection. The Treponema pallidum antibody testing or the microheme agglutination testing, they will come positive only 2 to 5 weeks after the infection has been there. So that is the controversy over here. What are the symptoms? The symptoms can be very mild. It can be in form of a chancre in cases of a primary syphilis. It is basically an ulceration, a painless ulcer with a red border and a smooth base. In cases of secondary syphilis, there can be rash all over the body along with the vulval lesion, and there can be tertiary syphilis also. The treatment, congenital syphilis, I'll come to that point, because the symptoms are so mild.
Before
that
congenital, can you put more light on the diagnosis?
Yeah. So the diagnosis is, as I mentioned, that all of them have to be tested for the VDRL testing. And if the VDRL test is positive, then we go ahead with the TPHA testing. As I mentioned, we can also do amniocentesis and check for the motile spirochetes. We can do the the PCR testing, not the TB-PCR, the PCR testing for the Treponema pallidum. And in cases of congenital syphilis, the problem is that because the symptoms are so mild, the baby can be affected. And you can, in the retrospect, if you go, there can be spontaneous abortion, there can be neonatal death, there can be sudden IUD, and there can be a baby affected by congenital syphilis. So what you expect in congenital syphilis, there'll be a basically abdominal distension in the fetus because in the baby because of hepatosplenomegaly. There can be hydropic changes, there can be ascites, there can be jaundice, there can be flu-like symptoms. And if we have missed congenital syphilis at the time of birth, there can be long-term implication like saddle nose, there can be mulberry molars in these babies, there can be screwdriver incisors in these babies also. And we need to treat them with benzothane penicillin and procaine penicillin. And most importantly, if the patient is sensitive to these penicillin, then we need to undergo, the patient should undergo the desensitization therapy, and then penicillin should be given, because congenital syphilis can only be treated when we give penicillin to the patients. And the other drugs like erythromycin or azithromycin, they don't take care of the congenital syphilis part. So that has to be treated by benzocaine penicillin or procaine penicillin.
Is there any change in epidemiology of this disease in recent years?
I have no idea about that.
So it's been said that, earlier we used to believe that syphilis is gone from us, but recently it has been found that the incidence of syphilis is increasing per se. So it is again now very, very important for every pregnant woman to be tested for at least VDRL. The screening has to be done at her first visit and it should not be ignored.
And those patients who are at high risk, they should be
Definitely.
they should also be tested in the 3rd trimester.
Yes, yes. And you can take the mic, doctor, you can take the mic.
The obstetric outcome in these patients who have syphilis, it's going to, in the period of gestation, the loss is going to increase with the period of gestation, and finally the baby will be born
Even
with
unexplained IUD also. Those are the cases you must test them, if you have not tested them earlier.
Because I am practicing also sexual medicine, so it should be mandatory starting and because when I taking the history, it's a very common to have a multiple sex partner nowadays.
Yes.
So I think that was the main reason where the syphilis revert back, and now we find there's increasing in.
Yes, this is a point I wanted to bring
checking
to light
for
of everyone, that we must test for syphilis now.
And
I
along
have
with
seen lot
syphilis
of
test,
prescription-
HIV also has to be testing because they are associated with each other very
yes,
commonly.
Yes, because lot of people I see prescriptions coming from other
high
doctors,
risk,
they are not testing for VDRL. So this is a message we want to give to the audience, that it has to be all the women in their first visit, and if they are from a higher risk area, they must be screened and it should not be avoided.
Yeah,
That's
so once we screen them once in a antenatal time, and those who are high risk, and when you are seeing them for the first time and you are taking the history, so high risk population again should be checked after 3 months for syphilis as well as HIV.
One more thing which I missed out, the partner should be treated in both the cases. And, the partner delivery system, you can give the medicine to the, of course, the partner has to be checked, but if the partner doesn't come, at least we should give the medicine to the patient to give it to her partner. So partner testing is also very important.
very, very important thing. When a patient comes for antenatal visit, nowadays nobody checks the patient. This is for all STIs I'm talking about. Then all the patient, when they come for their first antenatal visit, and even if they don't complain to you of any problem, we must examine them per vaginally. This is a very important message.
You will find a cervical chancre in these patients, in pregnant patient particularly, because the cervix is very soft.
Because they
So
may not
speculum
know.
examination is also very important.
Yeah, they may not know that they are having some problem. So it is very important for us to do a vaginal local examination in each and every patient.
Whenever a patient is coming for the first time, a per speculum examination is mandatory.
Yes, absolutely. So you have covered very well, Dr. Dolly. Primary, secondary syphilis, you have covered very well, and then tertiary syphilis, and you have covered the diagnosis part also very well. And treatment you have already said. Only thing is, sometimes patient is sensitive, we can't desensitize them. In that condition, we have to put them on, azithromycin therapy. And in those cases, we must follow them closely because there are chances of treatment failure. So this is very important. And again, congenital syphilis, you have done very well. And we have to do ultrasound during the pregnancy and look for the signs if there is any, doubt. And again, testing controversies, as you have already said, there are a lot of controversy regarding the testing with the IAEA, penicillin allergy testing, and use of MCA Doppler for fetal assessment. Doctor.
Go ahead, madam.
Acha.
Take the last three.
Okay. So what about, bacteria? We are starting with bacterial and then going to viral and then going to mixed infection. So chlamydia is another infection which is quite common. I would like Dr. Riddhi to take over this. Dr. Riddhi, will you take over this question? What is the epidemiology, symptoms, effect on pregnancy, neonatal diagnosis, management of primary management, then alternate, what about follow-up, partner management, infant treatment, and what are the controversies?
Yes. So as other STDs, patient do present with discharge during the pregnancy. And when we are taking the history or when we are seeing the patient at the first antenatal visit, we have to do PSPV examination and we have to ask about the sexual histories. And there can be a urinary problem that in form of the dysuria or intermenstrual bleeding or postcoital bleeding. And majority of the time patients do not have any symptoms. But as I said again and again, that those who are high risk population for STDs, we have to keep checking them again and again during antenatal visits.
As far as the effect of chlamydia is concerned, it's a very important thing that the patients would usually have preterm labor, patients can have spontaneous abortions, and we really do not know. So it is PROM the patients can have, and the diagnosis is very difficult for at times. And they need, if you have a patient who has a prior history of preterm labor or PROM, and if you're finding chlamydia, we need to first treat it before she embarks on a pregnancy.
Absolutely. It is very important because it is one of the most common, bacterial
Causes of
infections in women. So we have to keep a high degree of suspicion. We may not be able to find the chlamydia per se, but we all know that it can cause even infertility and tubal problems. So we must have a high degree of suspicion. And also we all know that it can lead to
conjunctivitis
and conjunctivitis. And about 60, a very high percentage of infants, 60 to 70% get infected. And of course, a diagnosis we can do with NAT and NAAT, or sensitivity also varies of different tests. And
swab
with these
testing
tests
for
we can detect both gonorrhea as well as chlamydia. And treatment you have already, I think you mentioned the
azithromycin
treatment.
single.
Yeah.
Amoxicillin and azithromycin, and partner should also be treated at the same time.
Alternate treatment.
The failure rate is also quite high of these.
Yeah.
Persistence of chlamydia can be up to 10 to 20% in these patients.
Yes.
So we need to have other modes of treatment in the form of erythromycin or amoxicillin can be given.
And
for
follow-up
these
is very important in these cases. You have to
ma'am,
follow them up after. It is recommended that we have to do a repeat testing after 3 weeks after completion of therapy, because they have as you already said, so that this is what I wanted to add. It is very important, and it can, we all know that it can infect both mother as well as the neonate. And partner management is again very important. We have to refer to the, for evaluation of her husband. If he is not coming, we can give the drug to wife so that he takes the treatment. Of course, there are limited studies which say that there is a decrease or persistent recurrent chlamydia, but we have to still treat the person. Then infant treatment, we have to again treat the infection if there is high risk of infection for the child, if the severity is more. And controversies, there are controversies. We don't know when to screen and who to screen. So this is again very important thing. And what about herpes? Dr. Kanchan, would you please?
Yes, ma'am. I wanted to add just one point in the previous topic also, chlamydia. For the diagnosis, the NAT testing and culture, we have to again make ourselves expert in diagnosis by clinical features only, the discharge only, because the NAT is not readily available and it is costly also, cost around 2,000. Not each and every patient can afford that 2,000 also.
Even sensitivity and specificity is not very high.
Yes,
So
ma'am.
clinical diagnosis and suspicion about this disease is very important.
Very important.
You are very well covered this. Yeah. So what about herpes? And how is the transmission? What is the effect on pregnancy and neonate? How do you diagnose? Can we do any kind of prophylaxis? What about the treatment? What about recurrence? And what are the delivery guidelines? And what are the controversies?
Herpes, we all know it is caused by herpes HSV1 and 2, and it is transmitted from contact, the skin contact from person to person, and to the baby it can affect by vertical transmission, especially during the delivery when the baby comes in direct contact with maternal secretions. But there are few studies also where the rare transmission can occur antenatally and sometimes postnatally also, where the baby gets this transmission from other person who's handling the baby, not directly from mother. And regarding the diagnosis, we can see in active lesion, we can see the active lesion which is over there on labia and perineum, and we can do PCR testing for the diagnosis of HSV1 or HSV2. And it depends, the antibody testing are also available, and which will help us to differentiate whether it is primary infection or non-primary first time infection or recurrent infection, because the mode of transmission or mode of affection of baby depends, will be affected differently in all these transmission. It will be higher in case of primary transmission, primary disease, and in case of recurrent it is relatively less. But still, and regarding the delivery guidelines, we all know that if there is any active lesion, we should go for cesarean section, because the baby gets affected can be very badly. Baby can get affected in 3 types. First, there is only a localized lesion to mouth and eyes and skin. Second, it can get the central nervous system affection, and third, the disseminated disease. And first one is of course milder, but this last 2 affection, baby can have a long-term neurological sequel, and morbidity is very high. So if there is active symptomatic lesion, we should go for cesarean section, although it does not completely eliminate the vertical transmission, because in some cases there can be antenatal vertical transmission. And also it is now advised if patient is having prodromal syndrome, like later on, previously she had that episode of primary episode, and now she's having recurrent, that she's having prodromal, like she's having the burning sensation and the itchiness in vulva. Then also we can offer her cesarean section, because during the time of delivery she can transmit and to the baby that virus.
You're very well covered that if the symptoms are from first episode, the risk is higher vis-a-vis a recurrent disease. And then a patient who have genital ulceration, we must keep a high suspicion, even if the test does not come out to be positive. And serologic screening can be negative in many cases. And repeat screening has to be done in 6 to 8 weeks time. And diagnosis is again by culture, which is not available to each and everyone. And of course, PCR and detection of antibody, they are very expensive tests, and they are laboratory based assays. So point of care testing should be done basically on clinical diagnosis. Then sensitivity is again very, very limited, and very, very important that serology, though available, but it lacks specificity of viral this thing, and it is sometime can be completely negative, and testing is available to identify type specific antibodies are not very specific. So IgM testing is not clinically useful. It is the guidelines, and IgM again absent in some primary infections, and IgM detected with recurrent infection has not much of value. So serologic testing specificity and sensitivity is not very, very high. So clinical and repeat testing is required. And then rapid serological testing, again, the sensitivity and specificity is not very high. I'm keeping it short because we have a very long panel to conduct. We are to keep it to the point. And prophylaxis, again, in pregnancy, we can offer, because it can offer the suppression to women with the history of HSV and initial outbreaks. Then treatment, you have mentioned treatment already?
We give 400 milligram TID for acyclovir in acute phases and primary phases for the 7 to 10 days. And in recurrent case, we can give it for 5 to 7 days. And for the suppressive therapy, we can give it from the later weeks of pregnancy, third trimester till the delivery for suppressive therapy.
You can take the mic. You can take the mic.
Usually it is associated with immunosuppression. So other STIs can also be present along with it.
Yes. It is very important. All the viral infections per se, when we talk, they are associated with immunosuppression, primarily or secondarily. So antiviral therapy we have already covered. Current ACOG recommend says that trial of labor is indicated in absence of prodromal or lesion. Otherwise, we have to offer the cesarean. You
Actually,
have
as per the RCOG and ACOG guidelines for the delivery, it has been said that cesarean is the mode of delivery, except when a patient has come in labor with fully faced, fully dilated head at vulva.
Yes.
That's the only place of vaginal
Otherwise,
delivery.
cesarean is indicated.
Otherwise, cesarean is the mode of
Yeah, absolutely. So again, a controversy about screening, whether we should screen every patient or not. It's a controversy. Now, what about hepatitis? Apur, Dr. Apur? Yes. Yes.
First of all, ma'am, at the outset, I would like to thanks to Alpesh to you for giving me the opportunity. Now, what we have actually discussed till now, I just wanted to, I am coming from a very small place and where you can't even think of doing these type of tests. So we advise, and even the government is advised about the syndromic treatment. Syndromic treatment means when a patient, a lady come with any type of discharge, you just give, I have seen the cases, if suppose that, oh, you might have gonorrhea, okay, do this test, the patient will never return back to you. So give in the same time, if you are suspecting, yes, it may be chlamydia, give then and there, return it and document it as previously you have to document, yes, on these symptoms, maybe query chlamydia, and give the treatment. Because this patient doesn't turn up and they will come at the preterm labor and bhai, doctor sahab, aapne kya kar diya? Hum to aap hi ke paas dikha rahe the, and I got to preterm delivery. So these all what I feel, these all symptoms, these all, the investigations, everything is just for theoretical. Literally theoretical, but we have to rely on our own clinical symptoms and we have to treat out accordingly. Now,
no, I would just like to add, you must give treatment, but you must recommend the test also.
Yeah, definitely.
Because tomorrow, if a patient says, "Ki sahab, doctor sahab ne to kaha hi nahi tha, ye jaanche karao," and they can put a blame on you. So we must advise, and if the patient refuses, then you give the treatment.
Syndromic management is there in the guideline for the PSC and periphery.
Yeah, definitely.
It's there in
Definitely.
guideline.
Yeah.
Now,
no, but you never know nowadays.
Yeah, ma'am.
You never know nowadays.
As well. That's the bottom line. Now coming to the viral hepatitis. Now everybody, when we are talking about hepatitis, everybody is tried hepatitis B screening about B. But I have seen a lot of cases of hepatitis A, because my usual patients are the low socioeconomical, the hygienic, personal hygienic is very bad, and the patient come with the symptoms of diarrhea, nausea, and everything, abdomen pain, and we are tested it and we find it's turned out to be hepatitis A. So my dear friends, just the bottom line message is, if you are getting this type of symptoms, you must think of hepatitis A also. So coming what in have in the hepatitis A, it is the fecal-oral route. All we know, hygiene is one of the main things which we have to in our mind. Now coming to any effect to the baby, the answer is no. It doesn't has any effect to the baby. So you just counsel the patient, it will doesn't affect, it will subside by own or by the simple things. Yes, if the viral load is more or if there are many concerns, we have immunoglobulin, we can prescribe it. But after delivery, we don't have any immunoglobulin for hepatitis A. Coming to hepatitis B, yes, we all are concerned. And we have to do, it is, in every ANC patients we have to do. If it is turned out to be positive, then please do hepatitis E virus load, because is determined whether it will infect the baby or not. So, so if it is positive, E is very high. That means there is 50% chance in utero, and in delivery, there is a 90% chance to transfers of the transmission. So this is the number 1 point. Number 2 point, whether to deliver by cesarean, the recommendation is no. In HIV, there is always क्यों HIV में तो है, इसमें भी होगा, because HIV, hepatitis B seems to be bhai. But no, delivery is strictly no recommendation of having the elective cesarean hepatitis B. Yes, what we have to do when the delivery has done, we just have to give prophylactic immunoglobulin as well as hepatitis B vaccine within 12 to 14 weeks. About the breastfeeding, yes, we have to recommend breastfeeding because the chances is very rare in case of hepatitis B.
And it gives antibody to the
Antibody to the
yeah. And
Nowadays
what about
with-
monitoring?
Yeah, ma'am.
Monitoring of the patient, pregnant lady.
Monitoring of the patient, yes. What we have to be in our mind, hepatitis B cause, hepatocellular carcinoma, and it's a hepatitis. So monitoring should be there by the hepatitis E viral load, and the husband should be investigated. If it is negative, we should give the shot of hepatitis B vaccination to the husband.
And
Yeah,
even for the HIV nowadays, if that mother is well covered with antiretroviral,
We will come
medicine.
to HIV. Doctor will come to HIV. No. What I want to stress here is that, we have to take a multidisciplinary approach in these cases.
And one
We
more thing.
must take a person who is, expert in treating hepatitis. It could be a general physician if you are from a smaller place, or it could be a gastroenterologist, a physician. So in this case, we must have a
Disciplinary.
approach, which is very, very important. And we must do their LFTs as and when required, along with basic other tests. So
transmission rate of hepatitis B is much higher than HIV. So all the universal precaution has to be taken by all the
Definitely.
healthcare professionals.
in every case,
In
not
every
only
case. Yeah,
positive
definitely.
case, in every case,
In every
because
case.
the risk of transmission.
But transmission rate is much higher.
Yeah. See, when we talk of transmission for hepatitis, supposing you are operating on a patient and you come to find out, that the transmission rate is up to 10% for hepatitis, and it is 1% for HIV. So it
Just
one
we
thing,
should take care
as-
of our staff also. They
Yeah,
should be
everybody.
aware that
Not
this
only
patient is
staff,
HIV positive
your
while taking.
helpers, like your ward ladies,
Yes, because
you
they
know,
don't
cleaning
know, they
staff,
don't have
because
knowledge, and that
everybody has
awareness
to
should be put in the head of our staff.
Yes. That is known as post-exposure prophylaxis has to be followed in each and every patient if we do not know their status.
Even during delivery,
Yeah,
postpartum
every-
hemorrhage is very commonly seen in these patients. So one need to be aware of this and take
Yes.
proper measures, because patients with hepatitis are
Yeah,
bound to have
I have had a
PPH.
patient who came, I had just sent her test, and she died on the table because of PPH.
And some
So
amount
I
of
still
PPH,
remember
the
that time I
patient
was very
lands up in
young,
hepatic
and
encephalopathy.
a patient
So that
came
is
in
very
labor, I
important.
didn't know that she was hepatitis.
I have also witnessed number of patients having hepatitis A going during the course of pregnancy in the hepatorenal shutdown and
Yeah, it could be-
DIC and
it
lot
can
many
be very fulminant. So this is what we were talking.
Ma'am, in 1 minute about hepatitis C, D and E. Hepatitis C, bhai agar ho gaya, Bhagwan hi malik hai.
Yeah,
There's a no vaccination to baby, no vaccination to mother. We can't do anything. By
Very
consent
fatal.
le lo,
Most
very
fatal.
fatal, and just stay ki bhai Bhagwan hi tera malik hai. About hepatitis D, bhai wo to bhai bhai hai. Like D and B, bhai Modi jahan hai, Shah wahan hai, to ek
This
saath
slide I have
rahega.
summarized in the first slide only. I have summarized everything.
And about E, yes, it's a very fulminant, very fulminant. Mortality rate is always high, and it is definitely multidisciplinary. अगर आपके छोटे setup में hepatitis E virus pregnancy में हो गया, तो it's almost 100% mortality. It should be referred to a multi-specialty so that it should be
Yeah.
treated.
So this is a slide which I made in the beginning only, that hepatitis A, the transmission is vertical. Again, universal precaution, because there is high viral load, we will have problem. Again, infant will receive passive immunization within 12 hours. So breastfeeding is important, and hepatitis C, we have already said, LFTs are very, very important. Vertical transmission is low, and while hepatitis E is very fulminant. And regarding the hepatitis B, we all know that about 25% can occur because of sexual contact also, not only injectables. We always talk of that, but if a partner is positive, there is very high risk of transmission. So serological testing is very important. Then hepatitis B you have covered. I'm not, because time is very less. So I'm not, risk of pregnancy you have already talked. Management, you have already talked that there's limited use of invasive monitors, and patient of hepatitis B, the infants should receive immunoglobulins and vaccination for hepatitis B. And then breastfeeding does not appear to, you have already said that. Prevention is by taking all the precaution during pregnancy, by having them vaccinated in antenatal period, and treating the partner. Hepatitis C you already covered. Hepatitis C I'm not taking because it's quite long. And now coming to HIV. What is AIDS? What is the epidemiology? How is the transmission? Effect on pregnancy, diagnosis, assessment of progression, how you do it, mode of delivery, and what are the anti-HIV drugs?
Since the time is very less, so I will
Just
cover
be-
it
be remain to point.
very brief.
Point,
HIV immunodeficiency virus. What is AIDS? When this HIV occur in the body, its attack on the killer CD4 count cell, the immunity is decreased. When the immunity is decreased, there is a lot of opportunistic infection leading to the HIV AIDS. So when the AIDS, between the HIV infection and AIDS, it may be in 1 month, or might be in a lifetime, the patient can't have any symptoms of AIDS. Coming to the transmission, we all know since our childhood, TV and everything was there, and it's a vertical transmission, sexual intercourse from the blood, and definitely during the childbirth from the mother to the fetus. Okay. Now,
and when you are talking about transmission from mother to child, it can occur during her pregnancy, during the delivery, and postnatally during breastfeeding also.
Breastfeeding also.
So all the three phases we have to
do. Now coming to what is the mode of the delivery? This is again nowadays it's
no, you have to tell me about diagnosis and then assessment progression.
Okay. Yes, ma'am. First of all, yes, it is a universal screening. Everybody, when they came for the first time, we have to do HIV testing for the husband as well as the wife, HIV-1 as well as the HIV-2. Though in these cases, HIV-1 is more common, HIV-2 is more common in homosexuals. So this is the thing. Now, when the HIV is diagnosed in the first trimester, so per se, what we have to do? Now, the extra precautions, first of all, the counseling is very important, because as soon as the private practice, I have seen that when it's turned out to be positive,
the patient says, no, I don't want to get that test done. Can she have an option of opt out?
No, ma'am. It's
No,
yeah. She has. Sorry, she has. It is the opt out test.
Yeah, so she can opt out, but of course, as you said, when we counsel that it will affect your baby. It is, they usually get, agree to it. Yeah. So, yes. Counseling is very important.
Very important.
And once a patient comes positive, you have to reconfirm and then only declare to the patient and connect her to the center. And what about assessment of progression? How do you do it?
Ma'am, CD4 count, definitely.
And
first, when we are doing the CD4 count, we have to first do it, start the treatment. After 2 weeks, we have to see the progress of the treatment. After 2 weeks, every monthly. For if it is a normal level comes to be very unattainable level, then every 3 months up to 34 to 36 weeks. At the level of 34 to 36 weeks, if it is the low level of viral load, we can advise for the normal vaginal delivery, what the ACOG guideline is saying. But if the viral load is high, then definitely we have to do an elective cesarean at 38 weeks. First thing. Secondly, during this ANC, what extra test we have to done? The first, when the HIV is turned out to be positive, we have to do something like, for example, a glucose test. because in many a time the antiretroviral medicines are actually hyperglycemic. So we have to do regular blood sugar monitoring. Secondly, LFT and serum creatinine, because these are the things which are actually causing the problem. So this is the progress of labor. This is what we have to monitor. CD4 count. Along with that, we have to do also the viral load, that how many copies of the HIV viral is there. It is again very useful in that.
As far as the HIV drugs are concerned, you can take the mic, please.
Heart should be used in the antenatal or 3-drug regime. We can start in the antenatal regime or antenatal period, and it can be continued. Nowadays, we have very very effective drugs in like leucogyri and amitriptyline, like that. And they have been seen that they are very, very effective in patients with HIV. And studies have also been done, and an impact trial has also been done, which has proven the efficacy of these newer drugs in treatment of HIV.
So there are 3 categories of the patient, basically those who are diagnosed before pregnancy, they are already on antiretroviral drug. Then you continue the same regime during the pregnancy. They are diagnosed but not on the antiretroviral. Then at the 4th month of the pregnancy, you start with the antiretroviral. Patients who are diagnosed during the pregnancy, you can start antiretroviral drug from the 4th month onwards. And there are patients, if
you
they
can
are
start from any time. You don't have to wait.
no, if their counts are good, then
No,
you
the
can
new
wait till
guidelines are the moment you're diagnosed, in spite of the WHO guidelines say that you don't wait for viral counts, you don't wait for CD4 count, you have to start the therapy as soon as possible, counsel the patient to
And then
continue
start.
the therapy not only during pregnancy, not only during breastfeeding, but throughout the life.
and then if patients are diagnosed in postpartum period,
you-
then also you can continue.
You have to continue
Yeah.
throughout the life. You
Throughout.
have to continue your counseling all the time. So it is very, very important to do the counseling. And
Baby's testing
Yeah,
should be
that-
done
that has
after
to be
1.5
done after
year.
see,
No, if high risk,
immediately, no, not
if
immediately.
high risk, if
No,
only
no,
baby
no,
is high risk and symptoms.
6 weeks and 6 months.
No, 6 months,
6 months.
1.5 year and
Yeah, yeah.
1.5 months and
6
6
weeks
months.
and 6 months. Very easy to remember. So just start. The moment comes, she newly registered, you find her positive. Start ART as soon as possible with proper preparedness and counseling, of course. Continue throughout the pregnancy, I just said, and delivery throughout the life. And if she presents late in pregnancy, say about 36 weeks, then also it should be initiated promptly and preferably at ART center, so that they can counsel and they get the drugs later also. Hence, efforts have to be made to connect them to the centers. And the first line treatment since 1920, 2020 guidelines is that we must give them a TLD.
One
That
tablet.
is
Tenofovir, lamivudine,
and dolutegravir. For all infections, HIV 1, 2, both infections, and if there is history of single dose of nevirapine or TB and HIV co-infections, and then this has to be started. Only one disadvantage is that the patients, there is a slight increase in risk from 1% to 1.2%, 1.5% of neural tube defects in the mother if they are given in first 3 months, and there is increase in weight gain, so which can be easily managed by lifestyle management.
And
These
if
are the
a
only two
patient is,
advantages.
yeah,
And
if patient gets diagnosed,
And
it's
if
around
she-
34, 36 weeks. Then if she does not get into the labor, at least wait for 2 weeks for antiretroviral to work.
No. Now the latest guideline is the moment you find out, you don't even wait for the confirmation.
No. I am talking about delivering the baby. Delivery. Delivery, at least you wait for 2 weeks for antiretroviral to work, and then you should plan for C-section or something.
Yeah.
If patient is diagnosed in late,
Yeah.
Not for the medicine, but for the delivery.
So it is very, very important that DTG can be given to all women in her adolescent and childbearing age. And of course, they have to be counseled when they are planning to for conception. And they should be told about the slightly increased risk of neural defects. And of course, now WHO recommends TLD as the first line therapy for any PLHIV, and because it has got many benefits per se, it has got faster and greater viral suppression, fewer mother to child transmission, fewer side effects, and high barrier of developing drug resistance, which is a biggest nuisance with HIV drugs, and hence NACO recommends DTG based regimes, and they have to, of course, take a regular healthy exercise to prevent the high weight gain. As you said very well, that if our vertical transmission can be reduced by giving ART, and if they have not taken, then only we opt for cesarean. So cesarean only when the viral load is high or mother has taken less than 26 months of therapy, and or she has taken only AZT, and vaginal delivery can be given if she has taken a complete course and the viral load is less than 1000 copies, and she has taken ARV during the, so NACO recommends no cesarean, only obstetric indication. So Dr. Kanchan, what you want to take? They are all getting late. They are very late. We can continue. There are only 2-3 things left.
Important thing is that HIV testing in the antenatal patient should be done in the first trimester as well as in the early third trimester.
Yeah.
Because we do it just once, but it has to be done twice because of the long incubation period of HIV.
Yes. You can take this. Ajao.
6:30. I think we should go down. The inauguration time.
Arey, push lo na, ye question.
I think for want of time, we'll skip HPV and go with something more common. Okay. We'll make it very short because I think it's almost going to be inauguration time. Candidiasis, who want to take it? Dr. Riddhi, just throw some light on candidiasis, on those headings, if you can.
Yeah, as we all know, it's commonly occurring infections we see day in, day out. And as we already discussed for other STD, we have to do routine examination, PSPV examination, find out, we have to ask, counsel patients, give we have to give treatment during the pregnancy as well, and treat the partner and prevent neonatal transmission.
You want to call it a sexually transmitted infection? No.
It is not called, but it can be sexually transmitted.
Yeah. Some clinical features. What are those predisposing factors? Somebody can throw light on that. Yeah. These are the ones. Some antibiotic therapy is the other one. Pregnancy or anywhere using estrogens, maybe pills or estrogen only therapy. Anemia where there's some level of immunosuppression that is happening. Symptoms of something curd-like discharge, which you have been studying from our undergraduate days, and some superficial dyspareunia. Diagnosis, generally many times we don't do anything. We look at that, you just look at a speculum examination and an adherent white thick discharge, and it's candidiasis. But always consider the possibility of coexisting infections too. So especially when though it's always clinical, when your first line of therapy fails, always think of something that you're missing out. Yeah.
pH test, which
Yeah.
I usually pH strip there in my OPD.
Okay.
When there is any discharge,
Yeah.
I just do it. It's a very simple
Yeah.
to differentiate whether it's a bacterial vaginosis or whether it's a Candida.
How many of you do a wet mount?
Yeah,
You know, just make a mount and give it to your sister. She'll see the hyphae.
Exactly.
If it is candidiasis.
Exactly. And it's something which is very simple and has got a pretty good yield as far as diagnosis this is concerned. I'm just running through it. I don't think we need to discuss about the treatment. I think it's something which all of you know. Trichomoniasis, Dr. Anuja, can you just throw a light upon it? Just... Mike, please.
Comes with greenish frothy white discharge
Hmm.
PV. And the patients usually, if you take the smear and put it on the mount, you can see the protozoa moving, the
Yeah.
flagellated thing.
Yeah.
The differential between, as we have already seen, between bacterial vaginosis, you have the diagnosis is by Amsel's criteria,
Yeah.
whereas trichomoniasis is a very clinical diagnosis. Amsel's where you get to see clue cells, whereas in trichomoniasis you have got flagellated.
And there is,
protozoa.
just to add on, there's a possibility of lot of this nucleic acid amplification testing and all,
Basically,
but it is
they are
hardly
not
ever
going
used.
to be transmitted as such to the baby or anything, but most of the times it leads to preterm labor, PROM, or these can be the most important problems that the patients can have.
True. And switching over to the last of the criteria, I mean, last of the
As I
infections,
already
which is,
said, the diagnosis is by Amsel's criteria.
Yeah.
These are 4 criteria where you
Yeah.
get to see clue cells.
Yeah.
And the pH is more than 4.5. You
Yeah.
are able to.
yeah, very important to know about the predispositions, any predispositions for bacterial vaginosis, because it is actually not exactly an infection, right?
Yeah, it is Gardnerella. There are so many atypical bacteria which are responsible for bacteria.
Yeah, it's primarily an alteration in the normal flora.
Alteration is
You
the
have less
normal
of
flora of the vagina.
exactly.
That
You
is
have
it.
less of H2O2
That's why
producing
it is-
lactobacilli, and you have more of anaerobes. That
That's why it
balance is
a
shifted.
Osis and not itis.
Yeah.
And usually they are not seen alone. Most of the times you get to see infections lingering together.
Yes, and
they remain it for a quite long time also.
yeah, and obviously it has got some obstetric concerns. Probably the one infection which is directly related to a bad obstetric outcome much more than others. Amsel's criteria is something which you have all talked about. Predispositions, they are considering that vaginal douching, especially for women who have the habit of
Douching is not recommended. They say
Exactly.
it's better to do a wash rather than a douche.
even otherwise also it can lead to an alteration in the flora. They are questioning even the repeated use of many of these intimate hygienic preparations,
Yes.
predisposing.
That is a
Yeah.
predisposition.
That's predisposing to all these things.
Yeah.
So we should not advise them all
True.
these vaginal, basically shampoos, so-called marketed in the
And
market.
they are so marketed and yeah.
Yeah, so many young girls nowadays routinely using intimate hygiene products, and they are coming up with.
True. And as a
okay,
gynecologist, if you are good at talking, if you once convince them, they're going to use it for their lifetime.
Hmm.
So, isn't it? You tell that your routine soaps are not good enough. This is going to be antibacterial. This is going to help you prevent. That's going to be for a lifetime. So you need to be very careful. Now, the ones that can actually prevent recurrence of bacterial vaginosis are ones which are so-called lipid replenishing, something which are relatively higher fat content. They are expected to keep the flora much better. And they are also very rightly talking about the appropriate material for the undergarments for these women who are predisposed to recurrence of bacterial vaginosis. We were always talking about cotton. They're adding silk to that. It's a very non-reactive material, so it actually reduces not just pruritus, but also recurrent bacterial vaginosis from happening. So silk and cotton is something which the entire world is talking about. I think that's all to add, I think. You want this? Yeah.
So to sum up, 1 minute. To sum up, that ACOG guidelines say that chlamydia in a woman at high risk should be tested on first visit, and all the women at the first visit and third trimester rescreen, especially women under 25 are at a higher risk. Then gonorrhea again should be tested on first visit. Then high risk women at third trimester again, hepatitis B in all the women, and hepatitis C for a woman at risk, and herpes also again a woman who is at risk and not recommended for the herpes. Syphilis, all the women it should be tested. So to conclude, safety to safety treat your infection during pregnancy is very, very important, and we must all treat them safely. Yeah, from us, from all of us, thank you for staying with us. Yeah.
What I feel, this is a very simple topic, but this is often missed. This is often missed, very simple topic. So people are very important, and we should treat it.
Let's have a photo, yeah.